Good morning, good morning. Thank you. Yeah. So, I think so. This is a case of recurrent sore throat and snoring, nasal obstruction for around maybe 6 months to 1 year. And we have been treating her with first, she also had a bout of acute sinusitis. So, we treated with antibiotics and then intranasal steroids. But the symptoms were not resolving. So we did an X-ray, and I think so grade 2 to 3 adenoids and grade 2 tonsils. So our plan is debridor adenoidectomy with conventional dissection and snare tonsillectomy. Okay?
Okay, Amma.
So I'll show all the basics. I just want to show how to pack the nose. Everybody knows that, but still I just want to stress on the basics.
Okay.
So even without headlight, you can pack. If you know the anatomy, basically you should follow our D&E steps. Okay. So take a pack. This is thermo wool. I think so Dad has already shown we don't use the conventional gauze piece.
Okay.
This is orthopedics packing material. It slides and glides easily on the floor of the nasal mucosa. Okay. So first thing what I do is, I press my forceps onto the floor and then I just glide it. See, okay. It's going. You can just put first pack in the floor. It goes easily, and then just pull it down to create space for the next pack.
Okay.
And then again slide that. Now it's, I think so, hugging the superior border of the inferior turbinate. Once again, press it down. If there is space, you can already, you can pass another one. If there is no space, then just leave it.
Okay.
Then again the same way, slide this. As we do, Vidyasagar sir has shown debridor adenoids in a different way.
Yeah.
With 70 degrees.
Yes.
That gives you a panoramic view. But with the same blade. So there are now 3 types of debridor adenoidectomies. Three subtypes. One is Satish Jain sir's technique, where he uses with 0 degree endoscope and then 60 rad blade.
Okay.
We use 0 degree endoscope and we use rad adenoid blade, which is the adenoid blade marketed by Medatronics.
Okay.
This is the blade. It has the cutting edge on the reverse side. Okay. You do not see the cutting edge on the anterior side. And I'll explain the pros and cons with our technique, and of course Satish Jain sir's technique and skill is on a different level. So sir, what the differences that I have noticed with our technique when compared to the 60 rad blade? Because Vidyasagar sir also uses this, but he uses with 70 degrees endoscope. It gives a panoramic view, but sometimes for beginners, that view is difficult to get understand of and everything, because regularly everybody does D&E. Why I'm explaining this is, with 0 degrees you have direct view. So
yes.
These 3 subtypes are there right now, small differences. Each technique is excellent. At the end of the day, the goal is just to remove all the adenoid tissue in the hidden spaces like fossa, Frosenmuller also.
Yeah.
And before starting, I just want to once again say that today, right now, I'm because of my father and mother. I always, even though he's behind me, it's like his shoulders right now on me. So I'm confident, and also to all my gurus.
Yes. Yeah.
Who have helped me reach this stage, especially my professors, Janardhan sir, VKC sir, Ramesh sir, Rahul sir, Ravi sir, Kusmanjali madam. And also, I always call the elites of ENT as my Dronacharyas, because I learn a lot by just seeing them. Like an Ekalavya, I learn what they are teaching. So everybody should be an Ekalavya, grasping the Guru's technique, whoever is teaching. So on that note, and I also thank Ravi Krishna uncle, Madhavi auntie. They are our just
good morning.
Show them good morning. Yeah. They're selling good morning, and Madhavi auntie.
Okay. Good morning, Amma. Good morning. Good morning, Dr. Madhavi.
The 2 people that are giving the excellent field, you have seen yesterday and you will also see today. They just make us feel comfortable with the anesthesia that they give us. And for a surgeon, what more to ask than an excellent field? So now I'll just put the Boyle Davis mouth gag. And before starting, I just want to explain the anatomy of eustachian tube a little bit and fossa Rosenmuller if possible, and then we'll proceed with the
Okay.
surgery.
Deepu, what is the anesthesia you have given and pre-medication?
Sir, this is general anesthesia, no pre-medication given. The regular inhalational anesthesia, sir.
Okay.
Propofol, relaxant, sedation, I think so. They've gone with fentanyl. Yeah.
Do they maintain hypotensive anesthesia?
Yes, sir. Yes, sir. They always do. Endoscopic picture. Light on. Light on.
You are using 4 mm scope or 2
No,
mm
no, sir.
scope?
This is pediatric. 2.7 mm.
Okay.
Yeah. Because she's 7 years old, so yeah. So you can see this is your.
Endoscopic picture, please.
Yeah,
May I request audio visual? Thank you. Yeah. Thank you.
ట్యూబ్ సెంటర్లో ఇద్దామా?
ఇప్పుడు చూడండి మేడం. ఓకే. రిమూవ్ ది ప్యాక్స్ అండ్
Yeah.
put the tubing tube.
Did you get the endoscopic picture?
Yeah. Yeah. Deepu, we are getting.
Okay.
Deepu, you packed with that gauze you told.
Yes, sir.
Is this adrenaline with
Yes, sir.
Zelacaine or only adrenaline saline?
No, sir. This is 4% with adrenaline.
4% with adrenaline.
Adrenaline, yeah.
Do you put any xylometazoline in nasal drops before surgery?
No, sir. No, sir.
Adrenaline
So
is-
some papers have shown that it has a rebound hypertrophy. It blocks the receptors, and then again you can't again apply for certain amount of time to get the vasoconstriction.
Okay.
So usually it's not advised, but lot of neurosurgeons do that for the transphenoid surgery.
Okay.
The xylometazoline, even ENT people do, but now I think so everybody have shifted to 4% with
Adrenaline.
adrenaline.
How much adrenaline you are adding, Amma?
Sir, for topical, I think so maybe you can even add 2 ampules without any worry, sir.
Okay.
Not an issue. Okay. So these are grade 2. This will be nice. Awesome. I'll just.
You are using debrider blade from other side, huh? Dr. Deepu, you are using instruments also same side with the same nostril, or you are using from other side? No, no. Acha, acha, acha. Dr. Deepu, we are not able to hear your voice. Audio visual, we lost connection. అక్కడి నుంచి రావడం లేదు చూడు వాయిస్.
Hello, Manideep, we are not able to hear your voice.
ఒక ప్రభాకర్
యా మధు.
ఒక అది ఏదో బ్యాటరీ చూస్తున్నారు.
ఓకే ఓకే.
He just explaining the eustachian tubal anatomy,
యా
the torus tubaris, and you were asking whether the instruments are passed from the same nostril.
యా
Endoscope and elevator are passed through right nostril only.
ఓకే ఓకే.
Hello, hello.
యా మణిదీప్, we are with you.
Okay, good, good. Yeah, a small hitch. Okay. So So eustachian, just a second, uncle. I'll just
Okay.
take a minute. So the eustachian tube anatomy, the bulge of the eustachian tube is called the torus tubaris.
Yeah.
And then the medial edge of the eustachian tube is called salpingopharyngeal fold.
Salpingopharyngeal
fold.
Okay.
I'll tell the importance later. Then the lateral edge is called salpingopalatine fold.
Okay.
And the inferior edge, this is the levator veli fold.
Okay.
So why I'm telling this is everybody can remember easily. How to remember anatomy is to crack the code of etymology. Etymology is the science of origin of words.
Yeah.
Because all our medical terminology is because of European people. We have the Latin predominance, so they are derived from Latin. So you can easily, why is it called salpingopharyngeal? Basically, dissect the word, two parts, salpinx. What does salpinx means? It means tube.
Okay.
And pharynx means the pharynx. So the medial border, which is in contact with the pharynx, is called as salpingopharyngeal fold.
Okay.
And the lateral border, which is in contact with the palate, that's why it's called salpingopalatine fold.
Palatine fold.
And this inferior border of the choana, which lifts the palate,
Yeah.
that's why it's called, the muscle is called also levator veli palatini. Veli means a wheel, a covering of the palate. Levator, what does it do? It lifts the muscle. So if you remember each word and the origin of the word, you can never confuse and know the boundaries and okay, what is medial, what is lateral. So immediately, a few seconds of your time, you can easily process.
Deepu, can you repeat levator palatine?
Yes, sir.
Veli.
Levator means lifting. Veli means wheel is like a, it's called as a covering in Latin.
Covering.
So it covers the palate.
Okay.
And palate of palatine because it is a palatine muscle. So it three part, why is it called is levator veli palatini? It lifts the palate and covers the palate. So that's why it's named. And the good thing about naming anatomy is they have named the function.
Yeah, yeah.
So if we remember how each muscle or joint or even ligament works, then you can easily remember the anatomy. And this goes with skull-base anatomy because the head and neck anatomy has the most complicated names. Even in my first year, I used to feel like, oh, why this much of complication? So we'll proceed with our debrider adenoidectomy with that. Okay, white balancing done. So now I'm introducing my debrider blade, and one of the main advantages of using a rad adenoid blade is you can lift the palate without injuring it because the blade is on the opposite edge. See, the uvula didn't get sucked. But in coblation, you have to pass an infant feeding tube to not get the uvula sucked into the coblation suction. Okay?
Achha, okay.
And one more thing, I always say, your debrider blade at the mouth should never be in center. Why?
Okay.
Because your gag is there. When you want to reach the superior border of the choana, this will come in obstruction. So when you're trying to do on the right,
so laterally you are applying, laterally you are
beginners, all the PGs can do debrider adenoids without any issue, but when you try putting your blade here, they'll face some difficulty and they'll not be able to debride, or the debrider blade will touch the other structures and then it will be a panicky. So always pass from the opposite side so as to not get the Boyle-Davis the debrider blade. Okay?
okay.
So one of the pros is this, sir. Using rad adenoid blade, without infant feeding tube, you can lift the palate. See?
Yeah, yeah.
I'm lifting it.
Yes.
And not injuring the palate.
Okay.
So now pass like regular DNA. Okay. Yeah. So I can see my blade. Okay.
Yeah.
See, now I'm able to pass in the superior border of the adenoids on the right side because I'm coming in an angled way.
Yeah.
Okay. Foot pedal. Okay. నాకు left foot. I'm a left foot pedal guy. No issue, this bleeding is not much, yeah. So I'll start debriding. So with the second point of the using this blade, now I am moving with the gravity. So the tissue comes easily into the blade. First, always debride in the central area. Be gentle. Do not poke into the tissue. Let the tissue come into the blade because it has a suction power. Okay, I'm going slow. Then up to perseverance rate you have to do. Now turn your blade. Why I have explained the anatomy is you have to debride the medial border of the tube, just the salpingopharyngeal fold, because the adenoid tissue would have also, the follicular tissue will be hypertrophied even on this. And our main aim is to clear the eustachian tube function.
Yeah.
So debriding this, see, I'm not going on to the tube. I'm letting the tube, the medial border come to me. Okay?
Yeah,
So
yes.
this is crucial for beginners. Never ever put your debrider blade into the tissue. You will always be safe. Okay?
Yeah.
So this third advantage of why we love this blade is now I can pass my blade into the Rosenmuller fossa and lift the eustachian tube anteriorly and then debride. Even though I'm not seeing, as I'm not touching the tissue and I'm letting the tissue come to me into the blade, I am safe. And in this way, I can remove the fossa of Rosenmuller. Yeah. We can remove the tissue on the fossa of Rosenmuller and not injure the tubal cushion, which is essential for maintaining the integrity of the eustachian tube.
Yeah.
And see, I'm already reached the perimysium. We can not perimysium, just above the, I'll explain, but with this technique, uncle, one crucial point is you have to feel the resistance, because as you are not able to see the tissue, there are three things I'll explain once I pack, how the tissue is getting resisted onto the blade. That is crucial. This is more like seeing and also palpatory surgery. As Satish Jain sir tells, you have to up to reach the perimysium of the tissue. Then only you have removed the entire tissue. See, the bleeding is also minimal. Of course, it's very minimal grade. So again, I'm debriding here. This is where it bleeds the superior part. So now I have stopped. I want to go to the opposite side. Now once again, as you can see, this is crucial, sir, for beginners. Now I'm rotating my blade again to the opposite side.
Okay.
See, my blade is already
Yeah.
directed to the superior part of the left side of the coena.
Yeah.
So never in the center, because the gag will always obstruct this. In
Yes.
my initial days, I didn't understand this. These are crucial points for beginner surgeons, because these are all observations that you get by doing each surgery. So passing this blade from the lateral edge is so crucial to have a clean field and a good dissection. So I'm passing. Once again,
Yeah.
you can see some discharge.
Dr. Manindip,
Sir.
is it pus coming from the nasal cavity? We are able to see some
Yes, sir,
mucus
some
discharge.
sphenoethmoid recess, there is some discharge. It was
Okay.
not there earlier. But I think so that is because maybe some sphenoid, sinusitis would be there because of the adenoid tissue.
Okay.
fact. The discharge comes. So dad is telling the decongestion of the nasal mucosa will make the mucoid discharge to come. I don't think it's unhealthy discharge, it's just the mucoid
Yeah, mucoid.
discharge. Yeah. So once again, I'm debriding the superior part.
The most important thing is you are allowing the tissue to come
Come
to
to-
you and you
yes.
are cutting it.
Debride.
That's
And
most
one more thing here for the PGs, even for exam sake, is the power of debrider, the RPM, is always inversely proportional to the cutting power of the tissue. That means if you have 3000 RPM, you'll cut more tissue, soft tissue. If you have 5000, you'll have less tissue in your blade. Why? I'll explain after once I pack. I'll show you how the blade rotates. It's a formula everybody can write in exams. So I'm debriding. So again, I'm working with gravity. Gravity is my friend here. So that is Pro 1, the advantage of our adenoid technique. I'm reaching till Passavant's Ridge. I've tried with Satish Jain sir's technique, but it is only, I faced struggle because SAR's hand and skill and anatomical understanding is something superior. So once again, sir, I'm rotating my blade. See, I've rotated my handpiece. I'll show how I rotated. This is also crucial. So my hand, I've rotated it, and I've taken support of the gag so as the blade should not slip. Once again, I am debriding the salpingopharyngeal fold, the medial border of the eustachian tube, the tube with pharynx. That is what salpingopharynx means once again. So just letting the tissue come, we can debride. Now, the third advantageous point of this thing, I am lifting the tube completely anteriorly with the non-debriding surface of my blade, and then again, as Vidyasagar sir says, coblation is hovering. Even debriding force of Rosenmuller is hovering. You should never touch the tissue. Let the tissue come. Hover over that. Okay. So it's good. I think I've done a good job. You can just suction without debriding and then see any tissue is left. Yeah. We'll pack now, sir.
Yes.
So
Excellent.
we pack with ferracrylium cotton balls. So my assistant takes a cotton ball and simply slides. And I feel packing with cotton balls is always good, sir. Cotton is a firm structure. It puts pressure. You are having a surface hemostatic agent applied to that, and you are also taking the pressure factor into this. And so both ways you are trying to have the hemostasis happen. So this is good for adenoids. I'll just see if there is any space. Take your finger and slide here. If you feel you can squeeze in, if you feel like you can squeeze in another cotton ball, pull up the cotton balls with your fingers like this, and then again put a dry cotton ball, but no, not needed, sir.
Okay.
So this is important. Can you show the ferracrylium bottle?
You are using liquid ferracrylium or gel?
No, sir, liquid, sir, because cotton ball will soak up with the liquid. It can absorb more liquid.
Okay.
This is the ferracrylium we use, Sepguard. Are you getting the external picture, sir?
Yeah, we are getting, we are able to see the bottle.
Yeah.
How much percentage, anything like that?
So this
Ferracrylium?
I think so it gives 1% volume by weight.
Okay,
But
okay.
as it is topical, you need not worry, sir. It's like they'll pour in the cup, let all the cotton soak. If
Okay.
still the cotton balls are not yet wet completely.
How much time we have to keep?
Sir, once again, this is clotting time, sir. It's always better to wait. So it's already 9:05, 38 seconds. I think so. I've put around 9:05. So let's wait for 5 to
Plain cotton ball or
Plain, sir. Plain, sir.
plain?
Because tonsil, what that tells is, if there is any, because adenoids doesn't have any muscular or venous, any vein bleed. It is just a capillary bleed.
Yeah.
So surface hemostat is really good. But in tonsil, you can get an arterial venous bleed and also a muscle bleed.
Yeah.
So if we put that surface hemostat, it will definitely stop the bleeding, but there will be clot formation. So
Okay.
that's why you will not see any bleed. But
Okay.
once you relax and then any extubation time occur, the contraction of muscles, again the bleeding starts.
Okay.
So it is always good for tonsil not to put ferracrylium because it's
Okay.
always
Is
better
it
to
wet?
coagulate.
Yeah. Is it wet cotton ball or dry cotton ball?
Dry, sir, dry.
Dry cotton
Dry.
ball.
We do not follow wet, but I don't, because as we do not follow, I have not observed the nuances of wet cotton ball. If
Okay.
it has any advantages. You do wet cotton ball, sir?
Yeah. Usually
we do
we
wet cotton
squeeze
ball.
the saline and we put.
Okay, okay, sir. We put dry cotton ball
Oh,
once
good,
again.
good.
I am separating the tonsillolingual sulcus. Okay, yeah. Dissector. So pass
You
your,
are starting incision from the upper pole.
yes, sir.
Good.
So once again, you are able to see, sir, the capsule?
Yeah.
Yeah. So that is what, this first step is actually very crucial in getting a good plane, sir, avascular.
Okay.
So take some time for this, then everything will again be easy. Once again, so I was catching the medial part of the tonsil. Now I am catching the superior part of the tonsil.
Yeah.
So once again, separate the anterior pillar now. Let you see the capsule. Separate the posterior pillar, a little bit of this thick fiber,
Yeah.
and then you can peel. I've peeled, sir.
Yeah.
So I call this peel tonsillectomy. This is simple, no cotton ball, no worry of injuring the bed with even dissector. If you get the plane,
Yeah.
getting the plane is what matters. So separate this. Okay. Now I think so I've had enough dissection. Now I'll put the snare. Everything is banana peel. Even in septoplasty, you should get that good perichondral avascular plane.
Yeah.
It is a banana peel. So once again, go through the snare. Cut. Okay. Now lower pole is bleeding. Okay. Good. So put cotton ball. Suction.
So Manideep,
Sir,
in your practice,
Sir.
how many times you have brought the patient again for postoperative bleeding and how you have controlled that?
sir, I've heard stories from my dad.
Yeah.
Once I came in these 3 years, by luckily my dad's grace, because I don't believe in God. So we have not yet seen a bleed.
Yes.
Yes, we have
So-
just one
Now,
more.
Dr. Madhu is there?
Yeah, he's God to me, sir. He's everything
yes,
to me,
okay.
sir. I am I'm right now sitting in front of you people and doing this surgery just because of him. How he has trained me, the setup that he has put forth.
Yes.
Yeah. So because of his mercy only, I am right now here. So he is like a God to me. Yeah. So we'll just relax, sir. Always we should relax because the constrictor muscle should relax. And if there is any hidden bleed, we can easily find out. I think so. Yeah, we'll wait for 2 minutes, and then because it's 9:05, we have put adenoid cotton balls.
Yeah.
It is 15 minutes now. So
Yes.
always pack the adenoids, forget, then come to tonsil, do all your stuff. Sometimes we even, because of the biofilms, adenoids, the CRS develops in these kids sometimes, and the maxillary sinusitis will be there in kids. We do antral wash, inferior meatal antral wash to remove all the pus. So even we do that. In the meantime, tonsils also will given enough time for hemostasis, and then at the end, we look for hemostasis. And before removing the adenoid cotton ball, I'll show you a beautiful catheter tube. This is epistaxis catheter tube, sir.
Yes.
This is silicone, made
Yeah.
of silicone. So this is very soft, even the, give me a syringe. And this is available with decibel. This has two parts, which inflates the nasopharynx and also the nasal part.
Yeah.
So not just for adenoids also, I think so this costs around only 5,000, and this is autoclavable, reusable n number of times till it lasts. So I think so this has lasted us for more than 50 cases.
Okay.
So if you even look at the economics of it, it is like 100, or even it goes to, if it comes good way, 50 per case, that's it.
Okay.
And this gives a good pressure hemostasis. It's like same Foley's, but Foley's has high pressure and high volume. This is a high pressure, low volume, same like our eustachian tube. So take 10 cc for eustachian tube.
Okay.
So 10 cc of air, and then see,
Yeah.
the bulb is inflated. So this acts as a pressure in nasopharynx.
Okay.
And this is silicone, so this is so soft. It is non-traumatic to the tissue also.
Okay.
And I'll show you the nasal part, even in OP cases. Okay, so this has a small nick because of instrumentation. The bulb of the nasal part is gone, but the adenoid, the nasopharynx part is working.
Oh, no
So,
problem.
yeah. Now I'll remove the adenoids cotton balls, and then we'll see if there is any bleeding. If there is any ooze, we usually put this epistaxis catheter and again wait for clotting time to happen.
Okay.
45 degrees scope, sorry, forceps.
You don't use diathermy,
Sir,
Mandeep?
as last resort, sir.
Okay.
As last resort, because we believe in pressure hemostasis.
Okay.
My father is like, if need of coagulation only, we'll do. Otherwise, we will preserve the integrity of the mucosa.
Okay.
Okay, yes, sir. Yeah. Scope clean, Savlon.
So if at all there is a bleeding, what is your choice of controlling?
Sir, if coblation, there is nothing better than coblation. If not, then we can have the Stamberger curved suction forceps. I'll just. Suction means curved suction bettu. There is one more cotton ball lodged in
Not
the
mic
coina.
ivagalava?
I'll remove it with pull it out from curved suction. Yeah. Endoscope.
Hello.
Yeah, yeah.
Yes, sir.
No, he's doing under general anesthesia.
Hello.
Sir, dad, sir, I think so you can switch on
Yes.
to dad.
Hello, Prabhakar.
Yes, Dr. Madhu, we are with you.
Yeah, I am just showing a tongue tie, which
Okay.
is very common situation.
Okay.
Are you getting my overhead camera here in the other theater?
No, no, no. We are
Okay.
still seeing with the.
Okay, right, no
I'm
problem.
pushing the cotton ball, sir, with suction.
1 second, Madhu. We'll see how the bleeding controlled.
Yeah, no problem.
Just 1 second and we'll
One-
come. Yeah, we are able to see your picture also.
Yes, sir.
Right,
I don't
right.
think there's any
You
bleeding.
can see PIP also. Once
Yeah.
Deepu
Yeah.
over, I'll just take a couple of minutes only.
Yeah.
We will show you two varieties of tongue ties. One
Okay.
is with Colorado
So if
needle,
there is any
another is
cotton struck,
conventional.
you can just push it like this with your
Yes.
curved suction through
Yeah.
nose.
Almost no bleeding at all, Mani.
Yes,
Manideep,
sir. Yes, sir. Yes, sir.
there is no
You can see.
bleeding.
Yeah. Now my always irrigate.
Acha, you irrigate after.
Yes, sir. I'll irrigate and dislodge any clots and
Okay.
see if again any bleed is there. This is essential. You
Okay.
should do it religiously for debrided adenoids.
Okay, okay. So there is a note a point.
Yes,
So
sir.
always we irrigate
Yes.
after debriding the adenoids.
Nah, right side. But never touch the tissue.
Yeah. Without touching the tissues.
This is also crucial, sir. It's okay even if you touch the tissue, but try to not touch the tissue. Once again, I'm passing my suction from left side to right side.
Okay.
This is crucial to reach the superior part
Yeah.
of coena.
Yeah.
Irrigation, please.
You are using only normal saline.
Left side. Yes, sir, normal saline. Irrigation on right side. Right side side.
Okay, Deepu, can we
Yeah,
go
yeah,
to
yeah. Please, sir. Sir,
Dr. Madhu? We
for,
are with you.
j-
We have seen beautiful. Can we have a big applause to Dr. Manideep for the excellent demonstration of adenoidectomy by microdebrider?
Okay. Hi, I think you have enjoyed my son's
Yes.
adenotonsillectomy, which
Yeah.
is bread and butter or roti pappu for us,
Yeah.
bread and butter for Americans.
Okay.
Okay, now are you seeing the open mouth of a small child?
Yes, yes.
This is a severe tongue tie,
Yeah.
and I have put a boiled gag,
Yeah.
and anesthetist is in line.
Yeah.
ఇక్కడ ఉండాలయ్యా నువ్వు. Here I am using a tongue spatula.
Yeah.
I had given 1 cc of gelatin adrenaline already.
Okay.
కిందకి ఇట్లా అన్నాను. And take a artery forceps, press
Yeah.
the frenulum,
Yes.
and
Sir,
at the base
we
of
are
the
not
tongue.
able to see, sir.
Yes?
Camera,
Camera,
is not
camera.
focused, sir.
Yeah, focus the camera. Madam, కొద్దిగా steady. I am doing under overhead camera.
Yes, sir. Ask him to come.
Closer,
Yes, sir. From above, he has to take, sir.
Is it okay?
No,
No,
sir. We are
not-
not
not.
able to see the frenulum.
No, I have not put the frenulum. Is it now seen?
No.
This is the lower teeth.
He is putting the camera from side. We are seeing only lips and your instruments.
He has to come to right side, sir. 2 minutes. Cameraman.
నువ్వంటే రైట్. ఇప్పుడు ఏమన్నా దగ్గరికి
Yeah,
వచ్చి-
yeah.
now we are able
I think
to-
now
yes.
it is a better picture.
యా
Yeah, now we are able to see.
పట్టుకోమ్మా కింద కనుకోయ్యా. నౌ మై అసిస్టెంట్ ఈజ్
Yeah, now we are able to see.
కొద్దిగా ఎందుకు పట్టుకుంటున్నాను. I have just compressed with artery forceps
Yeah.
and a straight scissors, and don't cut the submandibular gland
Yeah.
duct opening.
Yes, yes.
I have already cut. Now you can see, you need not suture the tongue tie.
Yeah.
And majority of the times, because of adrenaline is given, there will not be any bleeding, and now you can see the total. And in between, you can expand like this.
Yeah.
And that is all you need to do, and put a small cotton wick.
Yeah.
This is a conventional tongue tie.
Yeah.
Okay?
Madhu, Dr. Mahendra, Professor Mahendra came
Yeah,
from
yeah, yeah.
Karnool.
I'll show you another technique with Colorado needle.
Yeah.
So that is like telling that laser tongue tie. Okay?
Okay, okay.
We will go to the other table.
Okay.
So we want
So
to
what is the anesthesia you have given to the child?
we have given glycopyrrolate and midazolam,
Midzolam.
and given, I think, inhalational.
Sevoflurane?
మాధవి ఇచ్చినామా సివోఫ్లోరిన్ ఏమన్నా?
Have they given ketamine or sevoflurane inhalation?
No. Only midazolam and glycopyrrolate.
Okay.
అరే నువ్వు ఏడ్చకూడదు ఓకేనా? సో దిస్ ఈస్ అనదర్ గర్ల్. వీ హ్యావ్ నాట్ ఎట్ గివెన్ ఎనీ
yeah.
అనస్థీషియా ఆల్సో.
Okay.
హోల్ట్ అవ్వలేదు. చిన్నగా ఇంజెక్షన్ ఇస్తాను సరేనా, నొప్పి లేకుండా.
Can I?
గివ్ మీ 2 cc.
Hello?
సిరంజ్.
PIP ఏమనండి ఎండోస్కోపీ.
Madhu, Nashrao made a very good point. With the ketamine, there will be lockjaw, so we can't open the mouth properly.
We have not given,
Yeah.
but if at all sevoflurane as an inhalational, that will be sufficient.
Yeah.
And adults usually we can counsel. I don't know whether, I think this girl is a bit bigger. Em peru nana ni peru? No, right. 2 cc syringe.
Hello, Prabhakar sir.
Yes, please.
I just want to show the tonsillar fossa.
Yeah.
Close up. So,
ఇది ఉంది సరిపోతుంది.
so this is the left tonsillar fossa.
Yes.
No bleed.
Yeah.
And this is right tonsillar
Very
fossa.
good. Excellent.
So, I've just
Excellent.
peeled.
Yeah.
This is, you can peel, and the fossa is also so beautiful.
Manideep, have you used any diathermy or any?
Nothing, sir. Not
Nothing.
at all.
Can have a big applaud for the bleedingless
Thank you,
without
thank you,
using
sir. All the
diathermy or
blessings,
not, he did.
Yeah.
Good.
Thank you, sir.
Nice
I'm-
demonstration.
yeah.
Thank you, Manideep. Dr. Madhu, we are with you. You are doing under local?
Age of the child, sir?
Madhu, what is the age of the child? Manideep, you asked them to switch over mic to Dr. Madhusudan.
అయిపోయింది
బస్ అయిపోయింది ఇంకా అయిపోయింది నొప్పి ఉండదు రే. We will show you with this Colorado needle.
Okay.
So what I would like to say, that is a cold, what you have seen already,
Yeah.
it's just crushing the tongue and the frenulum of the tongue tight, getting attached in between the two submandibular duct punctum.
Okay.
So the main thing is you should not damage the submandibular duct drainage system.
Okay.
So crush at the base of the tongue and just take a scissors and cut.
Okay.
And the mucosa is so nice, it gets mucosalized.
Okay.
If the incision is are big, you can take a Vicryl 40 and also put a suture. Am I the 20?
Thank you, sir. Sir,
Okay.
This tongue tie appears very simple. But
Yes.
you have given a take-home message, sir. Thank you. To
No,
protect the submandibular.
No, yesterday somebody asked us, sir, why don't you show tongue tie also? That's why we have taken a decision that why can't we show tongue tie also? Though they are very simple, if you see how we can, it's very simple. Though instruments are, one is, this is tongue spatula, one artery forceps. ఇంకా మాట్లాడొద్దురా.
Sir, can you
Right,
show?
I am taking this spatula,
Yeah.
I am taking this artery forceps
Yeah.
and actually crushing the base of the tongue, okay?
Yeah. Yes.
Now, I'll just taking this Colorado needle,
Yeah. Focus.
my focusing. So I am cutting, are you able to see the cut?
Yes, yes. No, not
Not
clear.
able to see clearly, sir.
చూడమ్మా.
Focus, focus.
Focus అయ్యా
It's
ఇక్కడ.
exposed from below. If a cameraman
can-
shifts little to expose from the side or little, now little.
Sir, camera has to be focused, sir.
వద్దయ్యా ఎందుకు వద్దు? Is it now focused?
No,
Ah,
sir.
better, sir. Better. Still, it can be.
Camera is
We are able to see, but
అరే
the
నువ్వు
focusing
ఇక్కడికి
need.
చూపించుకున్నావా?
The
We
floor.
need focus.
Floor must be focused.
Focused.
Floor of the
ఇక్కడికి రా,
mouth.
ఇటు పక్కకు రాయా. Is he now focusing the floor now?
Yes, sir. Yes.
So I have already cut.
Now we could
Okay.
see your Colorado needle
Okay.
usage.
We are able to see the picture, but he is not able to focus it. Okay, it's all right. No problem.
Direction is good.
to
Madhu,
what depth you
this
can
is
go,
nothing
sir.
but monopolar artery.
Yeah, monopolar, do the.
So it is a curved needle. Curved needle.
Yeah, curved
Yeah.
needle. I just want to say,
Up to
So
what
it's a
depth you will go, sir?
diathermy. You are doing diathermy cutting.
diathermy cutting, whatever it may be,
Okay.
and see, you can, still there is a fibrous band, I just cut that.
While cutting the fibrous band,
Yeah.
Yes.
should we be in the middle of the tie or should we more towards the tongue, sir?
Towards the tongue.
Yeah, we should not injure the
we
duct
feel,
opening.
we feel we have given enough amount of mobility,
Yeah.
so we'll just put a gauze piece and close down.
Post-operatively, any advice, Madhu?
No, just betadine wash
Ah.
and routine some painkiller and antibiotics.
No,
Syrup.
no, do you advise them to do any tongue
Over,
exercises?
Huh?
Any tongue exercise
Yes, upwards and sidewards.
upwards and sidewards tongue
That
exercise?
is because floor is already anchored right from the birth.
Yeah.
So upwards, touch your upper incisors
Oh.
and sideward movements. అరే
Yes.
నీకు ఇప్పుడు కొత్త చాక్లెట్ ఇస్తాను ఓకే
Sir.
అగో అందరికి హాయ్ చెప్పు హాయ్
Okay, thank you.
Sir, hello, sir.
హలో
Sir, you please
Don't
pull
switch
the
it,
tongue to the, touch the tip, sir, the lip, upper lip.
Yeah.
వాట్ అప్పర్ లిప్
Yeah, it has to touch the upper lip, na, sir.
Yes.
ఆహా అరే నువ్వు పైకి తగిలిచ్చురా పంటికి పై పంటికి కాలుకి తగిలిచ్చు
పై పెదవి.
ఇట నన్ను ఇగో నన్ను టచ్ అవ్వు ఇన్స్ట్రుమెంట్ తీసుకో
పై పెదవిని.
ఆర్టరీ ఫోర్సెస్
Instrument to
యూ వాంట్ టు చెక్ కదా
yes,
పై
sir.
పళ్ళను పై పెదవిని.
Yeah, yeah. Yes,
Okay,
yes.
are you
Yes,
able
sir.
to see?
Yeah, we can
Yes,
see.
Yes.
పై
Yeah.
So
పళ్ళను పై
once
Yes.
they get the exercise, they will do.
Yeah.
చూపించిన డెప్స్ చూపించిన రెండు చూపించిన బోత్ సబ్లింగ్వల్
tongue may be painful when
Yeah,
he is
yeah.
holding the tooth
ఓకే అయిపోయింది
forceps.
I just want to show you. I
Yeah.
don't want you to do under local anesthesia also.
Yeah.
You can give under some general anesthesia or something like that. Okay.
Yeah, excellent
Sir,
demonstration.
need
Can
not
I have a
switch,
big
sir?
applaud for Dr. Madhusudan
Next
Rao?
academic.
Excellent demonstration, both under GA and under local
System
anesthesia.
Sir, need not be sutured, sir.
చేసేసి చాలా బాగా చేసినాం బట్ కొద్దిగా టైం తగ్గించుకో
Sir, need not suture, sir. One question. Second question, jet blast, is it superior, sir?
ఫర్ టంగ్ టై మహేంద్ర
Sir,
జెట్ప్లాస్టీ
sir, is it superior, sir?
No, with my experience, we regularly do now tongue tie is included in the Arogya Sri program.
Yes, sir.
So any tongue tie comes to our hospital, we shift into the Arogya Sri program.
Sir,
So I don't think any jetplasty or anything is necessary. A clean cut incision. I don't even advise Colorado needle, which can cause fibrosis.
sir,
The best is clean cut scissors and plain mucosa and it will heal off.
sir. Thank you, sir. No need to suture also, sir.
Having the tongue spatula, which has a slit in the middle, that
Yes, sir.
that slit will hold the tongue fibrous band,
Sir,
and the two expanded tongue spatula will lift the both sides of the tongue.
tongue, yes, sir.
So here you apply the artery forceps
Ah,
just to reduce the
Crush.
vascularity. I have already given xylocaine adrenaline
crushing
and
and cutting.
just
Crushing and cutting.
crushing and cutting. Here there is a submandibular duct opening, right and left. So you can see the edges of the opening. So avoid that and just cut. Simple cut.
Right, sir.
It's not
Advantage
like-
of Colorado cartridge, sir.
I just showed you the other method,
Right, sir.
but Colorado needle is again thermal injury.
Sir.
People are very fond of laser, everything laser. So
Towards
you can-
laser. It is towards laser.
Towards laser.
A
That's
step
all.
towards laser. Thank you, sir. Thanks a lot, sir.
ఇక్కడ సిస్ట్ పెట్టిస్తావా రామ్
Nice show, sir. Would you like to add some info? Till in the break, sir. So what are the techniques you do use in your institute, sir?
Cutting with monopolar, no need not to use suture also. Nothing.
Anytime have you observed jetplasty and
No, nothing. No. For these other wall submucous fibrosis, we do jetplasty.
what is that plastic surgeons prefer in these procedures?
In the jetplasty,
Jetplasty.
that's
Plastic surgeons, they prefer
jetplasty.
jetplasty. Madam, would you please add few points for the benefit of all?
Anybody knows jetplasty for the tongue tie? They
I
can
think
enlighten.
madam must be introduced first.
Madam is the professor from Akash
Medical
Medical
College,
College.
Devnalli.
Your good name, madam?
I'm Dr. Tejaswini.
Akash Medical College, where? Bank.
No, sir, I have just seen plastic surgeon doing Z-plasty for both earlobe repair and tongue tie release in my college.
Okay. Good.
The jetplasty we used to do in our current medical college, with the guidance of plastic surgeons, we did that. If a proper post-op exercise is not there,
It
Again-
may reunite.
it may reunite and it's like something like recurrence. So so patient participation is more important for a better result. The jetplasty, by doing jetplasty, on the table itself, in the jetplasty we had to suture inevitably. That's one thing. When we suture, there is no chance of reuniting in a wrong way. So that is a advantage one. And plastic surgeons, they do, as Madam rightly told, fond of jetplasty in various parts of the body, wherever they want very much widening. Anybody in the audience can add if they have.
Dr. JP, Dr. Jaiprakash Reddy, any idea about jetplasty?
Boss, good morning. Good morning, sir. Jetplasty in tongue tie.
No idea, sir.
No idea.
Actually, the jetplasty is not required for tongue
Yeah.
tie. So it looks very simple surgery, but when you take the patient under general anesthesia, there are two issues here. Number one, we don't usually intubate the patient,
Yeah.
thinking that they're simple surgery.
Yeah.
Number two, mouth opening is a big issue.
Yeah.
So once you use a Doyne's retractor, it will be bigger for the child.
Yeah.
And third point is, when it bleeds, there is no pack that you can keep in the
Yeah.
post.
Yeah.
So these are the three problems.
Yes.
So in my practice, what I do is I take dental blocks.
Okay.
I take dental blocks from the dental practitioner.
Okay.
There are three sizes available.
Okay.
So you can select the suitable one and keep at the retromolar area, molar
Okay.
area, so that the mouth opening will be easier with that.
What is that name? Dental?
Dental blocks they use to give the
Dental
injections.
floss, yeah.
They'll be available in the black color, sir, actually.
Yeah.
They'll be in three different sizes.
Okay.
And keep it at the retromolar area so
Yeah.
that it will get opened easily.
Okay.
Then we need to take with 10 silk, you have to take a bite to the tongue
Okay.
so that the assistant will hold the tongue upwards
Okay.
under anesthesia.
Yeah.
Then using either diathermy or radio frequency,
Okay.
you just make a cut near to the tongue surface, sir, not
Okay.
towards the floor of the mouth.
Okay. Okay.
So then we have to, actually the frenulum artery is there at the end of the
Yeah.
frenum that bleeds. So we have to take a tie with the
Okay,
30 micril, sir. 2 stitches will be enough.
Okay.
Or
Okay.
if you use radio frequency, no need of
Okay.
this is how I do, sir. No jetplasty is required.
No, okay. Yeah. Usually we also all practice by using just a diathermy, we can cut any, that is the name of the needle he told Colorado. Just you can take normal diathermy monopolar and you can cut. Usually there will not be any bleeding.
Sir, the advantage of Colorado needle, what is shown here,
Yeah.
is that it is bent like this.
Yeah. So,
So you can, what you are cutting, you can easily see. It will not come in the way of doing.
Yeah.
That's the advantage, sir.
So vision will be there.
It's not very expensive also.
Okay. Is it available with our people?
Yeah, it's
Arun?
available. It's
Okay,
about
okay.
some 500 or 700 rupees. That's one needle will cost.
Yeah. Thank you, JP, for your enlightenment.
Thank you.
Thank you, sir. Sir, what sir told is, it's not dental floss, it's the dental blocks. They have to be kept in between the jaws.
Dental blocks.
At the molar level, in between the two jaws. That's almost fixed opening would be there. We used to do that. And with the jetplasty, when we came to know about that in the initial stage, we used to prefer to do that. Only thing is, more enthusiastic jetplasty may sometimes, if not care is not taken, likely to injure these sublingual or submandibular salivary, submandibular glands. So that's the care where we have to be taken. That's all. And post-oply, one is exercise was told, another is proper pain reliever has to be given. Otherwise, because of the post-op pain, the child keeps without opening, without tongue movements, that also leads to reunion.
Operation theatre.
Are you able to hear me?
Yes, Madhu,
Yes,
we are
sir.
with you.
Yeah, are you able to see a small cyst in the right side of the cheek?
No. Picture.
Now
yeah.
we got. Yes, sir.
Salivary sister. What is that?
No, it may be a minor salivary gland cyst.
Minor salivary gland cyst.
This is the right side of the cheek. A Doyne's retractor is there.
Yes.
This is almost 1 centimeter cyst. I just want to show even how the small cyst can be removed.
Yeah.
Okay?
Yes.
Is it clear for you?
Yes, we are able to see.
So we give an elliptical incision
Yeah.
and give like this
Yes.
and come to the anterior surface
Yes.
and take the same incision on the opposite side. Give me
Yeah.
tooth forceps. Right. My assistant will hold and now I'll combine these two incisions. Right. Give me an artery forceps. You can take and suction is there. So you can take an artery forceps and hold this and now take a sharp knife. And now I am just reducing and cutting the entire base of this gland.
Yes.
Okay? And put a gauze piece. Now you can see the gland which was seeing, are able to see the gland cut?
Yes.
And this is the base of the gland.
Yeah.
And very simple, take a 3-0 mer silk. True
Madhu,
silk, mer silk.
is there any need to send to biopsy?
Yes.
sending.
Compulsory. We have to send it to the biopsy. Not much bleeding, I think you are able to see. Once you
Yes.
put 2 sutures, it will just. ఇప్పుడు రియా చూపించినాడు చూడయ్యా మర్సిల్క్.
I think you have infiltrated. You have given local infiltration.
Yeah, local infiltration. Local infiltration I have given. I given 5 cc of simple xylocaine with 2000 adrenaline.
Okay.
No pre-medication, no IV fluids, nothing. Vicryl. Vicryl absorb అయిపోతుంది. Okay, right. I'm sorry. And actually, I thought of putting silk, but Vidyasagar is beside me telling, Madhu, put a Vicryl.
Okay.
Because I thought Vicryl sometimes get wet and get absorbed. Then that is
Yeah.
also an advantage, Madhu. It gets
No.
absorbed.
Vidyasagar is in a rich area.
No, it's not the richness. I am taking a bite from here, and my Manideep is assisting. He will take the needle, and we will just take.
Usually you use silk, Madhu, normally,
Yes.
and you will remove it after 1 week.
1 week. I thought one thing is economy, not economy, but I thought it will become loose, Vicryl.
Yeah.
Vicryl is
But
costly.
Catgut will always become loose and it may
Yeah.
slip off also, but Vicryl doesn't. Because he has a vast experience in doing ulo, palato, modified
Yeah.
geta plasty. We will give another small cut like this, okay?
Yeah. Any suggestion that Vicryl should not slip? How many knots we have to apply?
No, double knot.
Double knot?
I think that is more than sufficient. We will show you another case like this. Papa, వచ్చిందా? Right.
So Vicryl is definitely more convenient. Patient acceptance will be better. Only thing is, it's little costlier. More cheaper is catgut, but catgut would be like a wire. It would be pricking for the patient.
See, now with these two sutures,
Yeah.
it's almost nice approximation and that should not cause much problem at all to the patient. Okay?
Yes. Yes.
So, what mean is, these are all things even a budding ENT surgeon should not feel I will get more amount of bleeding or something.
Yeah.
So, this patient is well under conscious, just xylocaine, adrenaline, without any fluids and everything, but Ravi Krishna and Madhavi are still with us. Okay?
Yeah.
Right.
Thank you, Madhu,
No,
for the
thank you,
nice
thank you.
demonstration of basic things
Yeah.
like tongue tie and cyst.
Right. And next is adenoidectomy.
Okay.
సతీష్ చేస్తాడు కదా దీపు ఇది నేను చేయమంటా దిస్ ఈస్ ఏ కేస్ ఆఫ్ 13 years old girl.
Okay.
పేరు దీక్షిత.
Okay.
And this Dikshita had a really snoring complaint of the snoring. And can you show this CT scan? You are able to see the CT
Yes.
scan?
Yes.
This is the scout and gout film.
Yeah.
And you can see a prominent incisors.
Yeah. Yeah.
This itself shows.
Yes.
And if you can measure the nasopharyngeal airway
Yeah.
from the skull base
Yeah.
to the upper surface of the palate,
Yeah.
in that more than 80% of the space is being occupied by the mass of nasopharynx.
Okay.
Once the patient lie down, this is in erect position,
Yeah.
lies down, the uvula and soft palate gets attached and naturally this patient goes into obstructive syndrome.
Okay.
And incidentally there is a deviation of the
Nasal septum.
nasal septum. But we are not thinking of this nasal septum is causative for her nose obstruction. This is there maybe from the age of 6 or 7 years and going on.
Yeah.
So at the present moment, sinuses are almost all clear.
Yeah.
And adenoids, you can see here, ingoka film undamma,
Yeah. The coronal cut also.
coronal cut. ఇది ఇంకొక ఫిల్మ్ ఉందా ఈ పాపది దీక్షితది
We are able to see nicely, Madhu.
acha then okay because
Yeah.
this is almost like a surgical cut,
Yeah.
so you are able to see, and it's only the compensatory hypertrophy of inferior turbinates.
Yeah.
And this is the sagittal, almost you can see in the midline.
Yeah.
It's almost occupying the whole nasopharyngeal
Yes. Yes.
space.
Yeah.
Otherwise, all the sinuses are well in clear.
Yeah.
So again, we are going to show you another adenoidectomy in a simple way, so that all varieties of adenotonsillectomies will be over for today. And the next case will be Dr. Satish Jain will be starting an extensive fest.
Okay.
Unimaginable polyps, osteitis and infection of an young girl, multiple ethmoidal polyps and
Madhu?
chronic. Yes.
Are you using still adenoid curate? No.
No,
In medical colleges, madam, are you using adenoid curate?
no. If at all you want to do Arogyasri,
Yeah.
there is this thing when you do not want to, naturally in Arogyasri, you don't want to spend money. In such cases, still it works out.
No. In medical colleges, they are using still
There are
adenoid curate.
Mahendra is there,
Yeah.
and Tejaswini, I think from Bangalore, Asha is.
Yeah.
And
Sir, we have been using adenoid curate.
Sir,
Okay.
As long as it is not stolen, we may be using. It's not available, sir.
in our medical college, I
Sagar,
am
you are
using
using adenoid
microdebrider. sir.
curate till?
Microdebrider.
No.
Yeah.
In our medical college, I am using microdebrider. Very beautiful, time consuming. Bleeding is very less and more accurate. Removal of the adenoids.
After adenoids, how you are controlling bleeding, Naishra?
No bleeding with debridated, sir.
No.
Just-
Are you using this paracrium?
Huh?
Paracrium liquid are you using?
No, nothing, normal saline, warm saline we use.
Only warm saline.
Warm saline.
Okay,
Warm
good.
saline means 37 degree room temperature.
Okay, okay.
Sir, Madhu sir, small question here.
Tell me.
This patient is having gross adenoids.
Yes,
Again, there is a gross deviate nasal septum.
yes,
The patient came with difficulty in nose breathing.
yes,
Am I clear?
yes.
Do you give guarantee of relief of the breathing symptoms after only you do the adenoidectomy in this patient? Because there is a DNS.
Very wonderful question, Nageshwar Rao.
Yes, sir.
And I also love to answer.
Yes, sir.
Number one, any child is snoring cannot be attributed to any amount of deflected nasal septum.
Sir.
Snoring is only, I think, majority of 95% of snoring is due to the nasopharyngeal junction.
Okay, okay.
So, if you remove the adenoids and the patient snoring goes off, in spite of having that deflected septum, that will not cause snoring because the septum blocks one side. The other side is there, na? Body
Yeah.
septum phenomena, deflection did not happen in a day process.
I'm not asking about the snoring, sir, but difficulty in nose breathing. Still,
Yeah.
They will be acclimatized,
yes.
and she's a small child, Dikshita. So pediatric septoplasty has come into actually pediatric FES. We have kept one case today also. I think pediatric FES. You can ask Satish Jain.
Yes, sir.
What are the limitations to do a pediatric FES? What to do? You want to do a wide middle metal antrostomies and wide dissection of bulla ethmoidalis, remove the total uncinate, go like all this, no?
No,
It
Madhu.
has-
Yeah, you are right. Majority of the cases when we see huge adenoids, we see CT scan, there's a severe sinusitis, pan-sinusitis.
Yes.
But usually we don't touch sinuses. Just by doing adenoidectomy, everything will be regress.
For us, in spite of all these things, to be doubly sure, routine antral wash cannulas, pediatric antral cannulas, trocar.
Okay.
So you just put into the inferior turbinate, press, just push. If then any mucopus just comes into the nose.
Okay, okay.
So adenoidectomy itself can give a good mucokinetic, mucoregulatory, and mucostimulatory,
Okay.
like ambroxyl or acetylcysteine combination with antihistamines are coming.
Yeah, yeah.
You give and naturally the circulatory phenomena will increase and all the secretions will come out.
Yeah, yeah. Thank you.
Right.
Thank you, Madhu.
Right.
Yeah.
Sir, is it the child, is it just simply a snoring case or is it a diagnosed case of OSA, sir?
Diagnosis case of?
OSA?
Yeah.
As a
It's an
simple
obstructive airway with snoring, but it's a level 1. See, when Vidyasagar is there, I am not sure. See, you know, level 1 is up to nose and nasopharynx. Level 2 means when you open the mouth, Friedman's position or whatever positions of tongue base, pillars, soft palate, uvula, palatopharyngeal folds, posterior pharyngeal wall, tongue, all will come under level 2. Once you cross this base of the tongue, till the vocal cords, almost you should consider as level 3. Level 3 is very dangerous. Even I don't do anything because you need a assisting airway like tracheostomy when you are doing a level 3.
Yeah.
A simple gross adenoids and snoring, it's a level 1.
Okay.
Remove the adenoids and his snoring disappears. That's all. No
Okay.
issues at all. If the child has a big grade 4 tonsils, so naturally you remove those tonsils and even level 1, level 2 is also attended. That will really give a very good relief. Even you can eustachian tube, C-type or B-type of your impedance, put a grommet tube. So you are operating on the nose, operating on the throat, operating on the ear, combined. Sagar, you want to?
Madhu?
I think sir has.
Yeah, Sagar, please.
Sir, good morning.
Good morning.
Sir, nice to meet you all. It's a pleasure to be with sir's OT all the time. So I think sir has nailed it very clearly that even in pediatric OSA, you have to identify the level of obstruction, type of obstruction, and severity of the collapse. And what is contributing for the obstruction is the most important thing. So he has very beautifully told that in this particular patient, adenoid is the one that is the culprit. So just remove the adenoids and see how the child is doing. That itself is enough. In pediatric, I think pediatric OSA is a big topic that we can talk for hours. But in pediatric OSA, if you have a documented evidence of witness apnea, even more than 1 per hour, it is considered a positive for pediatric OSA. So almost 80 to 90% of the pediatric OSA gets treated with your adenoid and tonsil surgeries if they are the most important culprits in that. In spite of them, if there is, you have done a adenoidectomy and tonsillectomy, and in spite of that, if you have the patient suffering from snoring or sleep apnea, then you have a gamut of array of evaluations that you need to do. That you can do it later, and then you can decide what next to be done for that particular patient. One particular thing that I would definitely look in before doing a adenoid in this patient is look at the arch of the palate, whether the palate is high-arched or not. If it is high-arched palate, then we have so many procedures that has come into vogue now. You have to think about the dome procedure or SARME. I think we have discussed all this in the recently concluded IASSA Con, wherein that also plays to improve your nasal breathing.
Yeah, Sagar.
Yes, sir.
If you don't mind, can you expand that words, mandibular advancement and palatal expansion?
Yes, sir. So the rapid maxillary expansion.
Rapid maxillary expansion.
So this rapid maxillary expansion plays a
By
role.
surgically or by prosthesis?
Yeah. So if you do it by surgically, then we call it a SARME. And I will expand it later, sir.
Yeah.
But because Deepu is about to start.
Okay.
What I will tell is, like, if the patient is having a high-arched palate, then with your dental colleagues, the pediatric prosthodontist, you can place a small prosthesis in the palate, and you can slowly do a distraction osteogenesis.
Yes.
That is like you are going to expand your palate, for which your mid-palatine suture has to be opened up. So that we open it surgically also. So what it does, by making mid-sagittal cuts, then you keep your expansional device there, that you can anchor it to your palate or to the process itself. There are 2 types that are available. And slowly, post-operatively, after a period of 14 to 21 days, you slowly expand that screws.
Yeah.
That will actually widen your palate, and it will reduce the height of the arch. So that itself will open the nasal breathing.
Nasal airway.
Nasal airway.
Yeah.
So that is one thing that you need to consider whenever you are seeing this pediatric OSA patients.
Yes.
So take a look at the adenoid, but also look whether the patient is having a high-arch palate, both clinically as well as in the radiologically.
Yeah.
So
Sagar, thank you very much for the excellent explanation regarding the expansion of the palate and increase in the airway of the nose.
yes, sir. Thank you,
you.
sir. I think now Deepu will take over.
Yes, sir.
Sir, Dr. Sagar garu.
Dr. Deepu?
Sir, hi, sir.
Yeah, we are with you.
Yes, sir. Good. Okay. You're getting the endoscopic picture, sir?
Yes, yes.
So this patient has a DNS also. So it will be a little bit tough to pass the scope. But I'll try to.
Yeah.
Ah.
Yeah. Dr. Manidi,
Sir,
we want to see how the setup, because a lot of audience now, they want to see setup of the operation theater table and surgeon, how he is standing or
Okay.
sitting.
Yeah, yeah.
And how
no,
you are
I'm
holding the
standing,
instruments.
external camera PIP ichesandi.
Yeah. Just show. Thank
sir,
you.
yes, sir. One
Acha,
second.
you applied a mouth gag?
Yes, sir. I applied the mouth gag.
Yes. Yes, we are able to see.
Yeah. So for debrid adenoids, it's important that you are, as we will not put just for adenoidectomy,
Yeah.
without tonsillectomy, as we will not be in rose position.
Okay.
It will be also easy to pass the scope and instrumentation, sir, because the bipods will not come in the way.
Yeah.
But the only thing is the gag will relax here. So
Okay.
I've seen some surgeons put a bowl here,
Yeah.
or better than that,
Put a cup.
cup.
Yeah.
If not, tell your assistant to hold the gag still, like
Yeah,
pull
yeah.
more anteriorly.
Okay.
This is also fine, and also you can put a cup like this.
Good idea.
Yeah. So once again, so if any audience missed out, shall I again go about the eustachian tube anatomy, or shall I
Yeah,
start?
you can. I think because at that time not many people were there.
Okay, sir.
Now everybody, you can also talk.
Okay. Yes, sir. Yes, sir. Yeah.
Sir, I think you are
Sagar, sir.
asking the expansion of SARME and SARPE, sir. Is that what you are asking, sir?
No.
In that time?
No.
SARME is surgically assisted rapid maxillary expansion.
Surgically assisted
SARME.
rapid maxillary expansion.
Yeah.
Okay,
And
sorry.
the other one is SARPE.
SARPE.
Surgically assisted
Ballpoint
rapid
like
palatal expansion.
Rapid palatal expansion.
So these are the two words that you need to remember.
Okay.
Okay, sir.
Yeah, Dr. Manideep,
Sir.
we are with you.
Yes, sir. Okay, I'll explain the eustachian tube anatomy once again.
Okay.
So, okay, I'll have this ball point. So it
Yeah,
will
we are
be-
able to see clearly.
Yes, sir.
Endoscopic picture.
Yes, sir. Just a minute, sir. Taking ball point. So, the most prominent part of the eustachian tube is called the
Yeah,
torus.
Dr. Manideep,
Sir.
the small announcement is
A
going
small
on. 1
announcement.
second.
Yeah.
Yeah.
Cars by numbers 2536 3007. They are parked in front of the pesticide shop, which is obstructing their entry. Can you please move the cars? Cars numbers 2536 and 3007.
Dr. Manideep,
Yes, sir.
yeah, we are with you.
So, sir, the main important parts of the eustachian tube are the torus tubaris, the bulge of
Torus
the...
tubaris.
Yes, sir.
Yeah.
So, torus means the bulge,
Yes.
tubaris means the tube. So,
Tube.
torus tubaris.
Okay.
Then why I am stressing the folds is because I have shown you in the earlier case, I will explain again. The medial border of the eustachian tube is called salpingopharyngeal fold.
Okay.
As I have explained the etymology, the origin of the each medical word, it's the signs of origin of each medical word as it is derived from Latin is called etymology.
Yeah.
So salpinx means tube,
Salping means tube.
Pharynx. So the fold that is in relation to the pharynx, the
Yeah.
medial edge is called as salpingopharyngeal
Pharyngeal fold.
The lateral fold of the eustachian tube is called salpingo-palatine fold because it's in relation to the palate. And the inferior bulge, as I am pulling it up with ball point, this is the levator fold,
Yeah.
which is the mucosal surface, the dorsal mucosal surface of the levator valli palatini muscle,
Yeah.
which pulls the soft palate, hence the name levate villi. It covers the palate and it is a palate muscle. So
Yeah.
levator valli palatini. If you want to remember anatomy without forgetting, it is pertinent that we go to the etymology, know what does that mean, because it's not in English, so
Yeah.
it's in Latin. So know what that means, then you can never forget what the complicated anatomical structures are.
Yes.
You need not by heart, sir. So
Yeah.
why I am stressing is, we will debride this medial border of the only salpingo-pharyngeal fold.
Yeah.
So, yeah. Now, I think so, I am also able to see the opposite side also, the eustachian tube with 0 degrees only, sir. I think so, you can like see the hint of the medial edge of the salpingopharyngeal fold on the opposite side.
Yes.
So, once again, I will show how I enter. As the Boyle-Davis mouth gag will always be in center, and our adenoid blade cutting surface, as we use rad adenoid blade, which is on the opposite side. So we go from right and then pull the pallet up. The first advantage of this technique is you can easily pull up the soft pallet without injuring the soft pallet, as the cutting surface is on the opposite side. Now go with a straight 0 degree. As I am going from lateral opposite side, I am able to pass up to the opposite choanal superior surface, and now I debride. So let the tissue come into the blade. This is important. So go down, debride. So as I didn't explain the resistance phase, sir, as in this technique it is more of seeing and also palpating with your blade how much resistance. Now I am facing a little bit of more resistance from the tissue. Now I am trying to touch the tissue but also be gentle, like hovering. But here in the lymphoid follicle phase, the adenoids, it comes easily. It's like a soft jelly type. So you will be able to appreciate that you need not put any pressure on the blade to debride. So now I will rotate to debride the medial edge, just the medial edge. See, again I am not touching the tube, I am letting the tube come to me. So debride up to perimysium, which again is important, as Satish Jain sir will again show how he gets to the perimysium with a reverse 60 degrees blade. Sir's technique is excellent, but it takes certain level of skill to maneuver the blade. This doesn't, because as I told earlier, this works with the gravity. I am having the help of gravity with me. In the other technique, you have to go against the gravity. The third part, I can able to lift the eustachian tube with my blade and also get a glimpse and then debride the fossa of Rosenmuller. In this step, it is important that you hover the blade over the tissue. Never go deep into the tissue. Just let the tissue come. So I have debrided. So now I will go to the opposite side, sir. Yeah. As there is comfortable space, actually I didn't go to the opposite side, sir.
Yes, yes.
But in case of a narrow nasopharynx, you, especially in children, you have to shift your blade to the opposite side to debride on the right part. So this is the advantage of our technique, and we reach up to the perimysium. So whenever I feel more resistance from the tissue, that's when I know I've reached the fibrous part of the adenoids, which is over the perimysium. Then I'll be so careful not to, I've stopped, not to poke like this into the muscle. This is important. It's like elevate, you have to hover, same like coblation, how Vidyasagar sir has shown, we do not touch the tissue. So again I'll lift the eustachian tube and then slowly.
In the coblation, we do not touch the tissue, but in
Sir,
debriding,
I mean, we have to touch the tissue, but we'll let the tissue come to us, sir. Not
Right.
like actively go and then debride.
Okay.
Yeah. So here I'll debride up to Prasavan stage. Yeah. Okay, sir. I think so I've done enough job. I'll now pack with cotton balls. My assistant will take, drop it into the mouth and then push with the tongue into the choana, which is coated with the ferracrylium, which is a surface hemostatic agent. You can already see the color of the blood change. It's becoming a whitish color, sir. So that is how it stops the bleeding, and this is good for adenoids, as adenoids bleed is a capillary bleed, not venous or arterial or muscle bleed. So we can easily stop with pressure and not with gauze or anything, sir. Cotton ball is good because the cotton ball is a firm structure which will put pressure more on the muscle. So we are taking two things at once, like the surface hemostatic help and also the pressure hemostatic help. And once again, my assistant just pushes the cotton ball for a tight pressure effect. You can see the bulge of the soft palate too, and we relax the gag, and we wait for the clotting time to happen. So right now it's 10:09:38. Let's say I put the cotton balls at 10:09 a.m. here. So we'll wait for at least 5 to 7 minutes, sir. It is important. Again, debrider adenoids is more of waiting than doing for the hemostasis to happen. So I just want to show the external picture. So let's say,
Yes, yes, we are able to
It's
see.
visible, very clear.
so sir, when let's say this is my coena, I come from here. So the adenoids is like this. I'm debriding and my blade easily goes. I mean the tissue easily comes. But once I reach the fibrous part, you can see even my glove is exerting certain resistance onto the blade. That is when you should feel the pressure, the resistance onto the blade, and be careful in your debridement. If you even then go deep into the tissue, then you will have more chances of injuring the muscle. So these three resistances, and the muscle will have highest resistance. So there will be initially no resistance at all. Then you will feel firm resistance like this. You can able to see the glove is affecting. But once you press deep like this into the muscle, the resistance will be more. So seeing, and also in this technique of with our rad adenoid blade, it is important to understand this resistance so that you can easily glide your blade. And I am debriding in the center part like this. You can see I am rotating to debride the medial edge of the salpingopharyngeal fold. Again, when I am doing on the left side, I will be able to debride the medial edge of the salpingopharyngeal fold. So these few things make our technique as the advantages of it. The only disadvantage is you cannot never see the cutting edge. I agree that. But with all these points in our mind, I think so we can debride safely without causing any injury. Even a beginner can do. Satish Jain sir has come. Sir, welcome to our OT. Namaste. So sir will start the case. Thank you so much, sir. Yes.
Safe debriding.
Yes, sir.
Keeping
Safe debriding is
Excellent,
Keeping
excellent,
in
Manidip.
all senses.
Yes, sir.
Excellent demo, Dr.
Thank you, sir.
Manidip.
So just to advocate our technique, the advantages and pros of our technique, why not even seeing the surface is also not bad. Yes, it is always important to see the debriding blade surface, but sir will show how beautifully he creates the plane from passavant's ridge. He passes it, he presses on the perimysium. It's a feast to watch, sir. I love Satish Jain sir debrider technique, but as my father has taught me this, I've observed these nuances of why this technique is also good and why anybody can do this. So these are all few points. First point, once again I reiterate, we can easily pass without injuring the soft palate because the cutting surface is opposite, and the tissue can easily come and you can pass along the gravity. The third thing, you can easily rotate and debride the medial edge of the eustachian tube, and you can lift the eustachian tube and debride the fossa of Rosenmuller. So with all these points, I think so I'll wait for hemostasis to happen, sir. Satish Jain sir will start a very, very interesting case.
Manidip, we could hear you.
Sir.
Manidip, we could hear you.
Yeah.
Now we could see
yes.
the picture.
Yeah, we got the picture.
Yeah. Thank you, sir. Once I'll see the hemostasis, I think so I'll show in between. In the meantime,
One of the delegate wants to see your debrider. What is the model of
sir,
your debrider?
yeah, so once again, why I took Serval is, Serval debrider is one of the best economical debrider that you can have. This is the latest Serval handpiece, but the blade is the Medatronics only. Udhar dikha, the console. I think so this is the older version on Serval console. But for debriding adenoids and basic FES, this is really top notch. Anybody, the beginner can also afford this, and this is a really good debrider, sir. This is from Serval, Omega model.
Yes. So Manidip, this is Omega Serval.
Yes, sir. Yes, sir.
The Medtronics blade can be fit to this Serval also.
Sir? I didn't-
Medtronics blade.
Yes. So that main advantage of why this is good is because we can fit Medtronic any blade, 0, 60, adenoid, 120, 12, 40, and only 90 degrees blade we can't fit because it is made for M5 handpiece, which has slots. As yesterday Gaurav sir was telling, for frontal he loves to use 90. Even I am not used. I want to purchase it and I want to try. but only that blade I think only fits for M4 or M5. Rest of the blades I think so we can also fit it for Omega serval handpiece.
Okay, excellent. Your demo is
Great.
excellent.
Yes, sir.
Safe.
Yes, sir.
Riding,
Safe. Yeah.
with keeping all senses, beware of senses.
Yes.
But during usage of microdebrider,
Sir.
actually, this is not, we are actually going anti-gravity. So with the gravity, the tissue won't come towards us. But with the debrider uses, the suction effect, with suction
Yes.
effect, the tissue comes towards the debrider blade, little.
And sir, I just want to stress, for debrider to function properly and for blades to last long, you should have a good suction, sir. Liposuction
Good
is
suction
a must.
is the
This
message.
is important, sir. Otherwise, the blades and the handpiece motor gets blocked if you use normal powered suction, and then you will not have life for the blade also, not for the handpiece also. Our investment will be bad. So purchase a liposuction along with a good micro debrider. I think so now we are getting for 40 or 50,000. Sripati Naidu sir was telling, I think so you have one Vizag brand, he knows that. They are giving it for 50,000. Good powered liposuction. Liposuction is a must.
Will you please show the liposuction
Yes, sir.
once?
Yeah. We use Venki, sir. So I want to stress, this is 15-year-old liposuction. Still working top notch. So this investment is a one-time
Venki's,
investment for you. So please invest on your good suctions also. That lipo we
Is
bought
it
like 15
more
years
powerful
ago.
than our
Regular
conventional Venki
sir.
suction?
Yes, sir. Yes, sir. The Pro aspirator model, I don't think they are doing this model anymore. But Venki is really good, Chennai brand. But the only thing is we get this serviced every year. We change the bearings, we change the
Your
oil.
voice is not clear, Manideep.
Sorry, sir. Am I audible now? Clear?
Thank you, Dr. Madhi.
Yeah.
It's
Yes.
a good take-home message. A good suction
Yes, sir.
is a good take-home message for the micro debrider to be, whoever is using, whenever it's
Hello?
being used.
Hello.
Sir, is it audible?
Yes, yes.
Yeah. So good liposuction, and also sir, service and maintenance is also an important factor. Every year we clean, we call the service person, we clean the bearings and also we change the oil. It's just like regular car engine with a very powerful horsepower engine inside it. So it also needs regular maintenance. Lot many people do that. It's hardly costs you around 2,000 to 3,000 for liposuction. But yearly once if you do that, this is for 15 years we are getting it in a good condition.
How much is the pressure
Wow,
you use?
excellent.
Yeah, these are all few things, and all credit goes to our staff, sir. We have this costly equipment.
Hello.
Picture is lost.
Mandeep, can you hear me?
Sir, power cut.
Now again it has
Mandeep,
come
can
back.
you hear me?
Hello.
Hello?
You're subduing
Hello,
your
are you
small
able to
credit
hear, sir?
goes to-
Yeah, yeah.
So, the small power cut. Yeah.
What is the
We are
negative
back.
pressure you use for the section?
Sir,
Use full pressure or
full pressure, sir.
pressure, okay.
Full pressure, sir. The suction power should be good.
Okay.
Whatever the tissue that comes into blade should not stay in the blade, and it
Okay.
should go into the suction.
Okay, got it.
And one more thing, for anybody who have missed the earlier surgery, so this adenoid blade is a pediatric adenoid blade, which has irrigation channel.
Pardon?
Irrigation channel, sir,
Irrigation
like the regular blade. But the adult adenoid blade doesn't have this irrigation, which is very bad for debrider adenoidectomy. So if you are asking Medtronics people, ask debrider adenoid, because my junior saw this last year. She went back, purchased. She didn't know that, even I didn't know that there are two models. She again called me, the blade is getting blocked, I faced more difficulty, luckily grade 2. So I asked her to send a photo. It was not having irrigation. Then she inquired and they told this is adult adenoid. So please ask for the pediatric adenoid blade, which has irrigation, which will not block the blade, as the irrigation and suction will pull out the tissue.
Wow, excellent.
Yeah. 10-9 kada. So it's 10-18 here, sir. I think so we will remove the cotton balls and see if there is any bleeding.
Okay.
M5 కొత్తవి పెట్టేసా. M5 060. Light on, endoscope. See. 45. You can see the color of cotton ball, sir. It has changed.
Yes. Yeah, yes.
Anybody? Okay. Curved section. So sometimes those cotton balls, because of the ferracrylium, they slide. So I go through nose and take a curved suction and push them from above. This is also important to remove the cotton ball in a non-traumatic way. Now you can remove through straight.
So, Dr. Manidip, you have kept the ferrochrome
Yes,
soaked
sir.
cotton.
Cotton ball, sir. Go to the completely there. Now this is also important, sir. You have to irrigate and see. Oh yeah, one more. So, sir, I don't like bowl. Why? Because the space is really less. Once you pull with your hand, you get more space. So I always love to tell my assistant to pull the blade. Yeah. Always, this is also important, pull with the soft palate with your suction, hug the soft palate. So that way you will not touch the posterior nasopharynx. These are all small things, but they really make a huge difference. Irrigate. Yeah. So there is a small ooze here, sir. So what we'll do is we'll put a Eustachian tube catheter and again wait for few minutes. This will also stop. Let's see. This is not to worry. Yeah. Right side నుంచి చేస్తావా పోతుందా డిఎన్ఎస్ ఉంది yeah. So my this is called an epistaxis catheter. So with 10 cc of air, he has dilated the bulb. It's like a Foley's, but silicone Foley's, which is high pressure and low volume and non-traumatic to the nasopharynx. And again, we would love to keep this dilated for again 5 minutes. And my assistant will pull this because the bulb will lodge the pressure into the nasopharynx. So any minor oozes also, if there are there, we can easily stop.
Hello,
Even
auditorium.
If we have any
Yes, sir.
bleed, then we have to take.
Yes, yes, we could hear
Now
you, sir.
Dr. Satish Jain is ready for the next case.
Thank you, Manidip. We will
Yeah, yeah, sir. Please, thank you, thank you. Yes, sir.
Thank you, Manideep.
Yes, sir. Thank you, sir.
We will switch over to
Yeah,
another
yeah,
OT.
yeah. I'll just, yeah. Thank you so much for giving me this
38
opportunity.
years old
Yeah.
woman,
Yes.
Madhuri, with total nasal obstruction with recurrent attacks of cold, sneezings and everything.
Yeah.
And once you see, just lift the tip of the nose, you can see bunch of white grapes in both nostrils. And
Okay.
the whole right nasal cavity with a deviated septum to the left. And actually, because of the deviation septum, the left side is not visible in the nasoscope. And she is having allergic sino-bronchial syndrome with asthmatic attacks also.
Okay.
And she was afraid of surgery and suffering for the past more than 10 years.
Okay.
Now we have taken up in the free camp, and this is for our Dr. Satish Jain.
Yeah.
Now the CT scan explanation, sir will give you in detail.
Yeah.
And
yeah.
the CT scan shows how much amount of disease and how, and Charcot-Leyden crystal, allergic fungal mucin is very clearly seen even in routine examination.
Yeah.
And all the other no comorbidities or parameters which are limiting the disease.
Yeah.
And hearing is also good. In spite of so much, there is no eustachian tubal malfunction.
Okay.
Okay?
Thank you.
And-
May we, we are able to see.
Yeah.
May we welcome Dr. Satish Jain to Nandyal with a big applaud.
Hello.
Dr. Satish Jain.
Hello.
I am Dr. Singari Prabhakar. Good morning.
Hello, good morning, sir.
Good morning. We
Good
are all
morning.
eagerly waiting for the last 7 days for your arrival.
Oh, sir, pleasure is all mine to be here at this prestigious center
Yeah.
which Madhu had developed from his heart. I remember, I have my fond memories of the last time when we did couple of cases.
Yeah.
And this is something I always get inspired when I come in contact with Madhu.
Yeah.
Believe me, it gives us so pleasure to be part of his, work, what he's doing for the poor people, helping poor with all, surgical treatments, all medicines, any sort of treatment with his heart.
In the name of
So,
his
Modi-
parents, sir.
Madhu, I am really indeed so happy to be part of this unique, movement you have started. Thank you so much for making me. Yeah, it's been 33 years. I remember last time you told our details of what you have developed. So many things.
Satish Jain, sir, he is doing this in
Doctor-
the name of his parents.
Yeah.
In memory of his parents, he is doing, sir.
Amazing, amazing endeavor. Thank you, Madhu, for making me
Yeah.
part of it once again.
Dr. Satish,
Yes, sir.
here your favorite students are there. Dr. Nageshwar Rao from Vizag,
Good morning,
professor,
sir. Good morning, sir.
and Dr. SVD Prakash.
So nice to.
And I will
tell you all
invite
of-
Dr. Jayaprakash Reddy, professor from Kurnool. May I request Dr. JP, please come on to the.
Dr. Jayaprakash Reddy has
dais.
come today only for your surgery sake, sir.
Yeah, we are.
And I am Professor Dr. Mahendra Kumar from Kurnool Medical College, sir.
So nice, sir.
Thank you, sir.
Thank you, all of you, for sparing your valuable time to be here, and
Dr. Jayaprakash Reddy
know-
want to say hi to you, sir.
Good morning, sir.
thank you.
Nice to see you again back here.
I'm so happy to see so many of our colleagues here. Dr. Sripati Naidu, who has been part of our, life for many, many years. He's like brother. Thank you so much. Thank you, Madhu,
Sir.
so much for giving this opportunity to interact with you all here once again.
Sir, we happened to visit your hospital, sir, along with us, Dr. Singer Prabhakar.
Oh,
During
really?
one national conference, myself, Dr. Mahendra Kumar, Singer Prabhakar, sir, and his team, we visited, we got the opportunity to visit your hospital, sir.
So nice.
Thank you, sir.
Thank you. Coming to the case, please.
Sir, can you read the CT, sir?
Coming to the case, like Madhu has already given the insights into it, the patient having multiple polyposis. I hope you have seen the nasal endoscopic picture as well, with multiple polyps occupying the nasal cavity with some mucin coming out in between. See, this is a classic case of CRS for surgical treatment. When it comes to chronic rhinosinusitis is like a syndrome nowadays. The treatment of chronic sinusitis has gone sea change ever since Messerklinger and Stamberger had, approached them through the natural ostia, claiming the natural ostia to be the site of drainage of the entire sinuses. And that revolutionized the treatment of chronic rhinosinusitis. And the goal of sinus surgery at that time used to be to open up the sinus ostium to establish the ventilation and drainage for their health. And the entire pathology in the sinuses, in the dependent sinuses, would revert on its own. And it works, this concept works. But what happened over the period of time? People had done a lot of functional endoscopic sinus surgeries. In spite of having done good sinus surgery, the polyps would recur. That made all researchers look into the, understanding this disease, what exactly this kind of disease is, which is coming back in spite of the best surgical treatment. And that led us a lot of information. And now we have understood this as an immune complex disease. Immune complex disease means it is affecting the immunity of the nose and paranasal sinuses, which has led this disease. So anything, this is purely a medical disease. Concept of sinus surgery still stands. You have to open up the sinuses to establish the ventilation and drainage. But that is not good enough. We have understood the pathophysiology and the entire cascade of this chronic rhinosinusitis. All the cytokines involved in formation of all these polyps and all these, variety of CRS sequences. This is not only one kind of a disease, CRS. Now, lots of endotypes have been defined. Endotype means every sinusitis variant has a different underlying pathophysiological process. Unless and until that pathophysiological process is, targeted, the disease would come back. So that's a very, very complex scenario. This particular patient has multiple polyps, has fungal mucin. I will show you some characteristic findings on CT scan. And this is a special variant of allergic fungal sinusitis. CRS variant AFRS, allergic fungal rhinosinusitis. This is a different endotype which has a different pathophysiology, has a different treatment goals and different prognosis. So the goal of treatment in this particular endotype now is obviously sinus surgery to establish the ventilation and drainage. Not only that, here the fungus is acting as an antigen. Why this disease developed? Can you enlarge over here to give a insight what exactly the... Are you getting the CT scan picture, sir?
Yeah, very clear.
Yes, sir, clear.
Can you zoom out here? See, the sinuses have expanded with heterogeneous densities inside. Sinuses have expanded. Disease is compressing on the walls and sinuses have expanded, yet it is non-invasive fungus. So this is a special endotype of CRS, allergic fungal rhinosinusitis. So, in this, what is the pathophysiology? How different it is from other CRS variants? Here the pathophysiology is this particular person is allergic to some environmental fungus. What we generally inhale? We inhale a lot of materials in the environment, micro materials in the environment, and fungus is since ubiquitous in the air, we inhale usually. And normally whatever fungus we inhale or mucociliary activity expels this into the nasopharynx and then into the gut. But whoever is allergic to, immediately the allergic reaction come into the, have its role, and the eosinophilic material is secreted around the fungus. If it happens to get trapped into one of the sinuses, it keeps on expanding, expanding and expanding. Fungus in the center and the eosinophilic material all around, and this gives a classical picture of this AFRS. So the primary pathology is allergy to fungus, means a type 1 hypersensitivity to the fungus. Type 1 hypersensitivity is allergic reaction. This is not invasive fungus. Non-invasive fungus this is, and this is because of the reaction to the fungus antigen. So the treatment for any hypersensitivity like we see in the body or any kind of hypersensitivity is steroid. For this also the mainstay of treatment is steroid, but after removing the fungal antigen. So the goal of sinus surgery in this particular case is to open up all sinuses to establish the ventilation and drainage, number one. To remove all fungal material in toto so that the further allergy reaction can be prevented, entire inflammation can be brought down. And third is to give wide openings of all sinuses so the steroid can be, the topical steroid can be instituted, can reach in the depth of the sinuses to take care of reaction, rather than the need of oral steroids. So, we have three-pronged goal in this case for surgery. One is like any other sinus surgery, to open up sinuses, to widen the ostia, to establish the ventilation and drainage, to remove this all inflammatory load, this fungal antigen and eosinophilic material. And third, at the end, to give wide openings of all sinuses so that you can, keep surveillance for long. You can institute topical steroid def into the sinuses. So
Sir,
that
how
is-
much period? Sir, how much period you will give? Systemic steroids and topical steroids?
Yeah, that depends upon follow-up, how you are able to control the allergic reaction. See, after this surgery, when everything heals up, our policy is to start the topical steroid, oral steroid for a few days and topical steroid until everything heals. Then we subject for the allergic testing to find out the allergen, and we subject for immunotherapy as well.
Okay.
With topical steroid and immunotherapy, if the mucosa remains normal, symptoms all under control, we can keep on reducing, keep on tapering the frequency as well as concentration of topical steroid. But this kind of cases require a lifetime surveillance.
Okay. Sir, immunotherapy means sublingual, you want?
Sublingual.
Sublingual immunotherapy.
Yes.
Sir, this is Nageswara, sir.
Yeah.
Do you practice aspirin sensitivity test, or if at all, what are the indications?
Pardon?
Aspirin sensitivity test.
Aspirin sensitivity test is indicated to diagnose one of the massive variant, I would say, another variant of CRS which has massive inflammatory profile. I would say, as I said, there are various variants of CRS, various endotypes. This AFRS is one endotype. So out of all endotypes of CRS, the highest inflammatory profile which endotype has is AERD, aspirin exaggerated respiratory disease. And to diagnose that, you have to do aspirin sensitivity to establish the diagnosis. And to treat the underlying pathophysiology, then ultimately you have to do desensitization as a final part of the treatment, the main part of the treatment rather than surgery. So in AERD, how you suspect? Patient presents with polyposis. Right. Well done. Patient presents with polyposis, multiple polyps, history of asthma. Any patient presents with polyp and history of asthma must be tested for aspirin sensitivity. If patient is sensitive to aspirin, up to 10% of the patients are sensitive to aspirin, in spite of not giving any history to the past sensitivity to the aspirin. So you have to test on a positive note aspirin to sensitivity, and if it is, after the full house fest, as a final main course of the treatment, to be instituted is aspirin desensitization. Because if the patient remains sensitive to aspirin, more and more leukotrienes are going to be formed, and whatsoever surgery and steroid you give are never going to work in long run, and the patient will bound to have recurrence. So every endotype has a different pathophysiological process going on, and this is what we have achieved now, have been able to segregate the CRS into various endotypes. So this particular endotype now today we are treating is AFRS. Now the goal is, as I said, full house fest. You have to give wide openings for the future lifetime surveillance, as well as, pushing topical steroids, full topical steroid in depth to prevent recurrence. At the same time, we will remove this entire inflammatory load. That is antigen as well as eosinophilic material around. Now coming to the sinus surgery part. The diagnosis is always on the clinical grounds. History, nasal endoscopy, you can say clinical grounds. CT scan is finally done to see the anatomy, 3D anatomy, and to rule out any other misdiagnosis or any other diagnosis. So here CT scan, the role of CT scan is hardly any in diagnosis. Yes, it substantiates your diagnosis by giving a classical, picture on CT scan of heterogeneous hyperdensities of this eosinophilic material and fungus. That adds on to your diagnosis, substantiates your diagnosis, that's it. Otherwise, the role of CT scan is to give you full three-dimensional clinical detail. Normally we get in the DICOM format, so we can reconstitute in all three formats 0.5 mm. Here we have pictures only, so quickly I will, the case is ready. In 5 minutes, I'll touch upon some anatomical findings. See this, enlarge. Yes. This is the first coronal picture. Can you see?
Yes, sir.
That's the frontal bone going behind. Every time we are going behind, see the two frontal sinuses, unequal, intersinus septum, full opacity in the frontal sinus, and the floor is formed by the beak. See, this is beak,
Okay.
frontal beak. Anterior to posterior we are going, the floor is formed by the beak. As long as beak is there, you are in the cavity, true cavity of the frontal sinus. Now as you go behind, now the beak is going away. See, the beak is completely gone.
Okay, sir.
And this is where the frontal sinus is draining. So frontal sinus is draining from behind. I will show you on the coronal sections and the sagittal plane how the frontal sinuses are drained from the most posterior part. That is frontal drainage pathway, frontal recess. Anteriorly it is flowed by the beak. And this is very, very important anatomical finding. In surgery we will correlate. We will follow this beak from anterior to posterior. We will follow where the beak ends is going to be the frontal sinus. As simple as that.
Yes.
This is the most reliable landmark which is never destroyed. Beak is always present and you can take into consideration as a most reliable landmark. So where the beak goes off, now the frontal drainage pathway is there, and as you go behind in the frontal, see now, what you look like frontal sinuses are not frontal sinuses. This is extensive pneumatization over the orbit. This is supraorbital recess.
Cell.
So supraorbital recess is after the frontal sinus, anterior to posteriorly. Once the frontal sinus ended, the supraorbital recess started. See this supraorbital recess, and then the cribriform plate starts. So cribriform plate starts almost after a centimeter after the frontal sinus beak. Where the beak ended, after a centimeter, the cribriform plate starts.
Yeah.
And now this is true ethmoidal cavity. In ethmoidal cavity, there are two important things to be noted. The turbinates on either side running from the junction of the medial and lateral lamella of the cribriform. You have to see the depth of the cribriform plate. See, all completely white out, complete opacity there. Huge deviation of the nasal septum to the opposite side because of the expensile, polyposis. This is just because of the expensile lesion. See this?
Yes.
See the cribriform plate, the supraorbital recess. As you go behind, see, my cribriform plate started here. I am going behind. At the end of the cribriform plate, just before the end of the anterethmoidal roof, the orbit is beaking and leading to a vessel. Can you see this?
Yes.
This is anterethmoidal artery which enters the lateral lamella of the cribriform plate. Where? See now, if you go back, first the entire frontal beak, no anterethmoidal artery in there.
Yes.
Then the entire anterethmoidal roof, see entire cribriform plate, no
Yeah.
anterethmoidal artery. This is most posterior. So you don't have to, frighten yourself with the anterethmoidal artery, and it is very, very posterior structure running to the posterior most part of the anterethmoidal roof.
Yeah.
The moment you cross the anterethmoidal artery, the cribriform plate disappears and the postethmoidal roof comes.
Yeah.
See this?
Yes.
The thick, flat postethmoidal roof.
Yeah.
So the anterethmoidal artery courses through the posterior most part of the anterethmoidal roof.
Yeah.
That is very important, finding you must keep in mind. See the septum, how it is deviated
Yes.
because of ballooning of these polyposis.
Yeah.
Now, as you go behind the thick postethmoidal roof, see everything complete white out.
Yeah.
Even the ethmoidal septations are destroyed and big roomy cavities are formed by the fungal material.
Yes.
So all anatomy is destroyed, all anatomy is distorted. As you go behind, see the orbit has become so small. See now, that is, even the beginning of the sphenoid is destroyed.
Yes.
See the ethmoidal cavity, the sphenoid cavity now.
Yeah.
Why I am saying sphenoid here? It is so difficult to make out otherwise. And this is important otherwise, because the moment you accidentally, if you accidentally enter into the sphenoid, one can get disoriented and damage the optic nerve and carotid artery if you are not able to identify it correctly. So entry into the sphenoid should always be, very, very properly done under
Sir,
vision.
what is the depth of the sphenoid, sir, where you have to avoid injury to the optic nerve internal carotid artery from the anterior surface of the sphenoid sinus? How much is the depth?
Sphenoid sinus depth.
Yes.
Depth of the sphenoid sinus varies. See, more the sinus is pneumatized, more are the chances of damage. More the sinus is pneumatized, lesser will be the thickness of the bone over the optic nerve and carotid artery, sometimes even dehiscent. Look at this sphenoid sinus. So big, expanded because of the fungal material. See this? So expanded. Even the optic nerve here looks dehiscent.
Yes.
To me, even the carotid artery also looks dehiscent at some places.
Yes.
So, the more the sphenoid is pneumatized, more are the chances of finding the optic nerve and carotid artery dehiscent, and more are the chances of damage.
Okay.
Less the sphenoid is pneumatized, you are likely to find a thick bone over the optic nerve and the carotid artery, which makes you a little more and more safer to damage those structures. So, you have to be careful while entering into the sphenoid. Here in this case as well, the septum is distorted, the postiothmoidal cells are distorted because of, expansile lesion, and entry into the sphenoid is not very clear. So here CT scan, I can tell you where the sphenoid is. See the roof of the postiothmoid?
Yes.
Formed by the frontal bone all over from terion to terion.
Yeah.
Terion to terion postiothmoid. Now see what happened. The bone is gone.
Yeah.
This is lesser wing of sphenoid. Where you find this bone, see the lesser wing of sphenoid.
Yeah.
No terion to terion. This is the beginning of the sphenoid sinus. This cut is there where the sphenoid sinus begins. Because it is roofed by the lesser wing of sphenoid, not by the frontal bone.
Okay.
Got my point?
Yes, sir.
So now is the beginning of the sphenoid sinus. Beginning of the sphenoid sinus. This is clinoid process. And here you see that is the depression of the optic nerve. Here I can see suspect some dehiscence of the optic nerve. And as you go behind and down, that's the carotid artery, that's the carotid bone over the carotid artery. It could be dehiscent as well. This is the lateral recess of the sphenoid sinus. This is, see, the pterygoid process on the left side.
Yes.
Intact pterygoid process.
Yeah.
And here the pterygoid process is pneumatized and occupying this opacity.
Yes.
So this is lateral recess pneumatization of the pterygoid process. That's how we can see there's a complete whiteout with massive disease on the right side. This AFRS is most often unilateral in younger patients who are more immunocompetent. See, I told you this is immune complex disease, but this is prevalent in more immunocompetent patients. The patient who is allergic is showing massive reaction to the fungus, massive eosinophilic infiltration. That means his immunity is massive, very strong. So this is particularly prevalent in immunocompetent young individual, unilateral disease, that is classical of AFRS. Other side is blocked because of the deviation of the septum and compromise, overall airway, aeration of the sinuses. So we'll open up the other side as well.
Sir, this is immune-mediated mucosal disease. Why the other side of the left maxillary side is totally patent, not involved in this?
Yes, see, I told you, when we inhale the fungal material which is ubiquitous in the air, the moment any of the fungus happens to get trapped in the sinuses, the reaction starts. Not in the nasal cavity. The fungus per se in the nasal cavity is expelled by the mucociliary activity into the nasopharynx.
Okay.
So any fungus which happens to get trapped into its sinuses, then the entire this vicious cycle starts.
Okay.
So mostly it starts unilateral. Sometimes you may see bilateral, uncommonly. If you treat unilateral, keep long-term surveillance, you may not find the other side disease. If not followed up properly, the reaction may continue on the other side and you may find disease developing on the other side. So that's how their presentation is. So the treatment is full house fess to remove all this antigenic material and eosinophilic material, number one, to establish the ventilation and drainage of all sinuses, keeping the mucosa intact.
Yeah.
That's how it is non-functional surgery, functional endoscopic sinus surgery. If you don't preserve the mucosa, because mucosa is the one which is going to serve the mucociliary activity, mucociliary function. If the mucosa is removed, then it's not fast.
Yeah.
So second goal is to establish the ventilation and drainage, and third is, at the end you will see I leave wide opening for the future surveillance and introducing topical steroids in the depth. So these are three goals for my entire, treatment of this case.
Yeah.
Any questions?
Sir,
Any
how long can we give the antihistaminic and montelukast?
Zero. No role.
No role.
See, what do antihistamines do in the allergic reaction? What happens in the allergic reaction? The allergen is exposed to the nose and the IgE mediated reaction starts. Mast cells degranulate. When mast cells degranulate, the histamine is released. Histamine is released in the circulation, and histamine binds to the histamine receptor and then give all symptoms of allergic rhinitis. Sneezing, vasodilatation, running nose, all those symptoms are given by histamine after binding to the histamine reaction. Okay?
Okay.
Antihistamine, what does antihistamine do? Antihistamine at the end of this cascade bind to the histamine receptor competitively, so the histamine doesn't bind to it and give the reaction,
Okay,
give
sir.
the symptom. So the role of the antihistamines is just to prevent binding of histamine to the histamine receptor and give symptoms of allergic rhinitis. It doesn't have any role on the natural course of allergic cycle, So this
Thank you,
is
sir.
just symptomatic treatment of allergy. It has nothing to do with treatment of CRS.
Thank you.
No role of antihistamines in CRS at all.
Yeah. Thank you.
And same in this patient, there is no role of antifungals.
Okay.
This is pure non-invasive disease. This is type 1 hypersensitivity to the fungus wherein eosinophils came in abundance and gave this problem.
Okay.
So the treatment of choice is steroids.
Yeah.
Role of sinus surgery to remove this all antigen and reaction material and to allow the steroid to go inside. So the mainstay of treatment is steroid. Zero role of antifungals at all in
Okay,
this
sir.
particular scenario.
Madhu, case is ready?
Yes.
Dr. Madhu?
Picture dikhana. So the case is ready. If
Sir.
you have any questions.
Hello, Prabhakar.
Yeah.
Case is ready, intubated, everything is ready. Sir is going for scrubbing,
Okay.
and everything is made ready because it is an extensive case of AFRS. The intricate physiology related to that was explained, and actually this is an expansile. You can see pressure destruction of the bony margins, and you can see both optic nerves and sphenoid roof and pneumatization of the pterygoids and even all these things. So because of this, we have kept as a first case for Satish Jain.
Yeah.
So everybody will come across this case. So you have to learn the surgical skills and everything.
Are you getting this endoscopic picture there, sir?
Yes, sir.
Yes, sir.
See,
Yeah.
what disease you have seen
Yeah.
has been reduced by something. Can you see? The disease doesn't look so massive coming out of the nose. It was. But what Madhu has done for us, he has given thorough pre-operative steroids to reduce the inflammation, reduce the polyps, reduce the inflammation going on to improve the surgical field. And this is what needed. This is one of the most important tactics to improvise your surgical work, to keep the surgical field good.
Sir,
And this preparation starts even weeks before surgery.
sir, before you start the surgery,
Yeah.
how do you prepare the part to be operated, sir? What is
Yeah.
the preparation like?
Yeah, that's what I'm going to show you
So
from
how
beginning.
how much of
Yeah,
adrenaline
yeah,
is?
I am coming to that.
Yeah.
I'll wash up and come back and show you. This is what you are seeing is the pre-operative preparation done by Dr. Madhusudan. And this is the actual need of, this kind of preparation is needed to improve the surgical field. Why? Surgical field has to be the best possible to keep your visualization good. This is inflammatory disease wherein all nose and paranasal sinuses and mucosa is inflamed. And because of the inflammation, all vessels are dilated. And there is so much of bleeding. In order to control this, you have to curb the inflammation. And as I said, this is an allergic reaction for which steroid is the best treatment. So this preparation with oral steroids weeks before is the need of time to prepare such cases, and Madhu has adequately prepared this case. See,
Sir, how many days you will advise, sir? Pre-operatively steroid?
generally, depending upon the case you fix, 1 to 2 weeks at least, minimum a week at least, with prednisolone only in tapering doses. Pure oral steroid, no role of antibiotics. If there is secondary infection, yes, you can give. Otherwise, the mainstay of preparation is the steroid.
Okay.
I'll come to the intraoperative preparation as I wash up.
Okay, sir.
So we can continue our discussion during surgery as well. Feel free to interrupt me anytime.
Prabhakar,
Yes.
sir has gone for scrubbing,
Okay.
and actually we have given 2 weeks steroids.
What is the dose?
We have given actually not sir told prednisolone, but we have given methylprednisolone,
Okay.
IV pred or what you get predmet, 8 milligrams TID for 5 days, 8 milligrams twice a day for 5 days,
Okay.
and 8 milligrams once a day for 5 days.
Okay.
And nasal douching, we are very particular that mucin should come out.
Douching with?
Douching with salt and bicarbonate.
Okay,
That
saline.
sachets.
Okay. Okay.
And we specifically tell that all the dust is there in your rooms. First you clean the dust, we will remove the polyps. And actually this girl yesterday came and she told the express, sir, 75% of my problem is over. Do I need surgery?
Yeah.
And that is the effect of your 2 weeks preparation. Sometimes it is a defensive aspect. Because sir has given very good treatment, why should I get operated? She may miss and you may lose
Yes.
your income.
Yeah.
So, but it's not that you should not prepare or this thing, but a good preparation will make your operating field very clear.
Yeah.
And you will have a less bleeding and everything. And we say you are a lifelong patient.
Yeah.
You can get your immunity status become dependent and guessing, and sometimes pulses of what you call steroids has to be given, and steroidal spray is a hallmark.
Yeah.
They have to take steroidal spray and nasal douching.
Madhu,
Yeah.
how do you advise steroidal spray local topical? Twice a day or once a day?
No, if it is too much, you can say twice a day.
Huh.
Suppose you go to a function and come back, you feel like sneezing. Otherwise, once in maintenance, you can, depending upon the patient, patients will take decision, Prabhakar.
Okay.
They are so intelligent, they take the otherwise twice a day will be usually more sufficient for most of them.
Okay.
Sir, Madhu sir,
Sir,
Nageshwara, the same question I have asked to Stamberger sir.
sir,
What he told is, how many times you brush your teeth? I told twice.
Yes.
So what he told me is, keep the nasal spray in your bathroom. After brushing of your teeth, just inhale one spray.
very good.
As long as you live, you brush your teeth, you have to
Spray.
take the spray.
So
that is his answer.
keep the spray in the bathroom.
Yes,
That's
yeah.
the best.
That's his answer. Stamberger's answer.
So Stamberger. So you will never
Nice, sir.
forget
Thank you.
to, you will
Sir,
never forget to not
Sir.
to brush your teeth, how much
Yeah.
busy you may be. So if you see the spray just beside the toothpaste or brush, immediately you, very good idea.
Yeah.
Very practical idea by Stamberger.
Madhu?
Sir,
Are-
sir
are-
has come.
Yeah, please.
Sir,
We'll enjoy the
Mike-
surgery.
Hello.
Sir, we are with you.
Yeah, am I
You
audible?
are, yes, you are audible, and we are eagerly awaiting for the surgical steps and you discussion regarding the surgery, sir. Theory part we can discuss later. You
Yeah.
give all the practical tips for the surgery.
Yes, sir. Sure, sir.
Thank you.
Thank you. I hope the picture is good there.
Yes, sir.
Yes. Very, very clear, sir.
So, we discuss about the pre-operative preparation. Now, the intra-operative preparation is equally good,
Yes.
equally important.
Yeah.
The goal is to reduce the inflammation, to improvise the surgical field.
Yes.
And here we have to do couple of things.
Yeah.
This, this surgery gives bleeding from capillaries. The
Yeah.
source of bleeding is capillaries, not large bore vessels.
Sir, the picture is very
So-
large, sir. Can you make it little zoom out, sir?
Pardon?
The picture is very large here. So you can, the endoscopic picture can be reduced a bit. Zooming can be reduced.
Very large.
Yeah.
No, no, we can
Can you
reduce-
zoom out? Zoom out is very much.
Yeah.
Can you zoom in
Yes, yes.
Now?
a
Now-
little bit more?
Extra, no, better, sir, better.
Yeah.
Now it's better.
Okay. So, for the intraoperative preparation, you have to look at lot of things. Number one, at your anesthesiologist. You know, the source of bleeding are capillaries. And in order to reduce the cardiac output, to reduce the capillary bleeding, the best thing is to ask anesthetist to reduce the heart rate. So we always ask our anesthetist to keep the heart rate around 60 to reduce the cardiac output. 60? Oh, great. See, already the heart rate is around 60.
Okay.
So that is the best thing. You can ask your anesthetist to reduce the cardiac output in order to reduce the overall capillary bleeding. Number two, in order to decongest the mucosa, see what I'm using.
Merosil.
This is a foam like Merosil. I soak this foam depending upon the patient's age and the status, the systemic status. This is a young patient, so we are soaking in 1:2 ratio. 1 is ratio adrenaline and 2 ratio saline or
Okay.
ringer, whatever. And see this, this is such a soft foam. You
Yeah.
can take everywhere and just apply on the mucosa.
Okay.
Our goal is to not forcefully insinuating anywhere.
Yeah.
Just apply this adrenaline on the mucosa surface to reduce the, to decongest the capillaries. That's it.
Yes.
This is the first decongestion what we have done. Just apply adrenaline everywhere on the mucosa to decongest the capillaries. Not to use pressure anywhere at all.
Yeah. So no
Using-
pushing.
No pushing at all. Only just applying adrenaline.
Yeah.
Just applying adrenaline. Applying everywhere. This is 1:2 and this will decongest the mucosa to make our surgical feel good. The advantage of this foam or Merocel is it is so soft you can insinuate in any narrow space. Once you insinuate, it can open up the narrow space after decongestion like this, and it is absolutely atraumatic. This is an immune complex disease where the mucociliary activity is compromised. And you have to do every possible thing to prevent mucosal damage, prevent damage to the mucociliary system. And this soft Merocel or soft sponge is so useful. We never advocate using gauze or anything. Yeah, this is special foam which Madhu uses, I remember last time. And this is almost a zero cost foam which you can use. And see this, like when we use Merocel, we cut 2 Merocel into various pieces of various sizes, 8 to 10 pieces. Soak them in this, see this, use this, rinse this, when you bring out, rinse in the saline, soak them in the same solution again. See this?
Yeah.
Squeeze a little and reuse. So the same sponge can be reused again and again. And this Madhu has procured this as a, common man's sponge into this nasal cavity. This is sterilized.
Yeah.
There is hardly any cost, and this is equally effective to the costlier Merocel. And he has been using for years and years together with no difference in the goal what we aim at Merocell.
Yeah.
This is amazing. See this? What I have been doing for last 5-7 minutes, just applying Merocell onto the surface.
Yes.
Foam on the surface, nothing else. No pressure. See on the other side, this is deviated nasal septum because of the mass effect of the disease which is reduced because of the steroid treatment. This is very important. See this, what oral steroid has given reduced everything which was so ballooning and
Yeah.
compressing on the septum.
Yes.
You know what happens? Sometimes patient come, you give a course of oral steroid, they become symptom free in no time. They come back, doctor, you are next to God, you have treated my disease, cured my disease. Please continue the same medication, I don't want any surgery. Yeah. Yeah, otherwise patient will tell you, please continue me on the same medication. The previous doctor was looking so greedy, he was advising me unnecessary surgery. And you have treated me with this medicine only. So you have to counsel your patient before preparation also, that we will start the preparation with some steroids which are harmful if given in long term. So we will give you for short term until you become symptom free, and when you become symptom free, then the surgery what we are going to do will do the best. So we will operate only when you become symptom free. Then only the best surgery can be done, then your patient will remain fully counseled. Otherwise the patient may run away. That I am good, I want only medicine, no surgery.
Sir, what is the difference between the pediatric phase and adult phase in the polyposis cases?
Yes, lot of difference. Very
Clinical,
important
only
question.
treatment aspects.
Very important question, I tell you.
Yes, sir.
Pediatric phase is a different endotype altogether.
Yes, sir.
Like adult phase, which are mostly eosinophilic, pediatric sinusitis is mostly neutrophilic driven. It is never eosinophilic, number one.
Sir.
It is non-polypoidal, almost always. Pediatric sinusitis is almost always non-polypoidal. If you find bilateral polyps in a child, young child, it is considered as cystic fibrosis until proved otherwise. So you have to rule out cystic fibrosis, which is a disease where there is default in the chloride transport mechanism giving viscid secretion, making secretion viscid to block the mucociliary activity. So pediatric sinus surgery, pediatric sinusitis is altogether different from the adult in the pathophysiology, number one. Treatment wise also, see this adult sinus surgery, the success of this sinus surgery is ultimately, since it is eosinophilic driven, the success is ultimately dependent upon the post-operative irrigation, otherwise it can come back. Because it needs steroids. You cannot give oral steroids for long, for life, but yes, you can give topical for long, even for life. Otherwise they can come back. So in pediatric sinusitis, you know, this irrigation is not very practical. You can't expect the children to cooperate with you, the daily irrigations like you do in adults. And the chances of synechia, recurrence are very high. The anatomy is so complex. The structures are so closely approximated to each other. The distances to the skull base orbit is small. Chances of complications are more. So in pediatric sinusitis, the mainstay of treatment is medical. If still the disease persists, symptom persists, and it comes to surgery, the first surgical treatment is adenoidectomy, not the sinus surgery. The reason being, I told you, this is mostly neutrophilic, and the adenoids are the source of biofilms, giving infection again and again, reaching to the sinuses, and adenoidectomy many a times cures the sinus disease, as it removes the source of infection. Yes. So in pediatric disease, the goal of treatment, the pathophysiology, everything is altogether different. See now the preparation.
Yes, excellent, sir.
Third part of the preparation, which what we have done, is to keep the head end little 5, 10, 15 degree, whatever high, to facilitate the venous drainage from the head to prevent venous congestion. Okay?
Okay.
Now look at this stage. To look at the anatomy. That's the inferior turbinate. Below
Yes.
is the inferior meatus, which is not so relevant for the sinus surgeons, particularly in this case. And the important thing which is there in the inferior meatus is the opening of the nasolacrimal duct, which is not relevant for the sinus surgeons here. Then this is the inferior turbinate.
Middle turbinate.
Middle turbinate.
Yeah.
See this going up, becoming little polypoidal also. See this?
Yes.
Polypoidal. Now as you go behind, look at the choana and nasopharynx behind. And in the nasopharynx what we see the posterior wall of the nasopharynx, no adenoid tissue. This is the Eustachian tube torus, Eustachian tube orifice, and behind is the recess, the fossa of Rosenmuller. This is the posterior end of the inferior turbinate, posterior end of the middle turbinate, the third part of the middle turbinate. This is the first part of the middle turbinate in the sagittal plane. Second part of the middle turbinate turning laterally to insert on the lamina. See this?
Yes.
This is in the coronal plane. This separates.
Yes.
All cell anterior are anterior ethmoidal cells, all cell behind are posterior ethmoidal cell. And this third part lying in the axial plane,
Yeah.
this one is the third part of the middle turbinate. Then this area is the middle meatus. See this anterior most region in the lateral wall. Our area of interest is the lateral wall only.
Yeah.
This first anterior area is the flat one. This is
Yes.
with no hardly any important structure. As you go behind are the prominences. This first prominence here, where my suction tip, this first prominence going up is the course of the nasolacrimal duct.
Yes.
Prominence of the nasolacrimal duct. Behind this, see this polypoidal distorted thing. This is your uncinate process, which is a mobile structure.
Yes.
The only mobile structure in the entire lateral nasal wall is the uncinate process, which has become distorted because of the massive polyposis, everted. Then behind that is the, see this, which has also become polypoidal.
Yes.
This is the bulla ethmoidalis, which has become polypoidal. See the
Yes.
polyp. And bulla is compressed behind. More the polyps are, more the bulla is compressed, become atrophic. So these are the landmarks what you can see, and everything is distorted here. Okay?
Yes.
Now, to get into the sinuses, we all know in sinus surgery, you must have seen yesterday as well, the first step is uncinectomy. This uncinate has two parts, the above vertical like my ball probe, going high up and mostly take a lateral turn. It joins the medial wall of the agarnase to insert laterally on the lamina papricia. And in that scenario, your frontal sinus drain medial to it.
Yeah.
And this is what you see most often. In uncommon situation, because of the abnormal agarnase and other things, this uncinate may turn medially to get attached on the turbinate or skull base, then you have to be careful.
Yes.
Then it has a lower horizontal part. See this horizontal part going far behind like this.
Yeah.
Most often going to the this perpendicular plate of the palatine bone,
Yeah.
or merges in the inferior turbinate to end somewhere posteriorly.
Yes.
So this is uncinate.
Yeah.
And behind the uncinate, between the uncinate and the bulla ethmoidalis, is the infundibulum.
Yes.
This is hiatus semilunaris inferioris, which enters into the infundibulum laterally. What you see this opening, what is this?
Accessory
Yeah.
ostium.
This is not natural ostium.
Accessory ostium.
This is accessory ostium. Natural ostium is never visible. Natural ostium is never two-dimensional. So this is a punched out defect in the lateral nasal wall, which has only two mucosal layer.
Yes.
One on the nasal side, one on the sinus side. This is, this is fontanelle or accessory ostium.
Yeah.
So let us debride these visible polyps to explore the anatomy better in this region. So here I am using this shaver, micro debrider, debriding little bit of this uncinate which is everted. See this polypoidal bulla, all gone polypoidal. This is 40, red 40. See the bulla has become atrophic. This is expected. When there is massive polyposis, the bulla becomes atrophic.
What is the RPM, sir?
Yeah, please.
Debrider RPM.
5,000. I am just debriding the polyps. We are lucky to have with us here Dr. Vidyasagar. He is a prominent, inspiring, otolaryngologist in this region and for us as well. Vidyasagar, please keep on commenting. Your comments are always valuable.
When boss is in action, nobody else speaks.
No, please feel free. See now, this is your uncinate. So now what I am going to do, I am using my reverse biting. See this?
Yeah, reverse biting.
For the junior colleagues, always use the instrument followed with the telescope. See, bring your instrument first and then follow with the telescope. When you remove the instrument, focus with the telescope and remove under vision. So you don't traumatize the walls
mucosa.
on the either side. So I am taking off this uncinate with the reverse biting at the junction of horizontal and
Sir, if you have time, because there are many juniors are there here, postgraduates.
Yeah.
What are the do's and don'ts in the face?
yes. While doing this, that's a very important question, using this reverse biting. Number one, the structure at risk is your nasolacrimal duct, which is just anterior to it. See this? So when you use this, direct this inferiorly to stay away from nasolacrimal duct, number one. Then keep coming anteriorly, bite through the uncinate until you reach the hard bone. The moment you come across the hard bone, you are supposed to stop to prevent biting through the uncinate.
Nasolacrimal.
These are two important things to be taken care of.
Okay, sir.
Number two, see this uncinate is everted. I have bitten through the uncinate and made this window. Can you see?
Yes.
I am biting through biting to show it better.
Yeah.
What is this instrument, sir? It's not routine
Yes.
instrument.
And see now,
Scissors.
I can use my debrider to widen it. You have to communicate the natural ostium with the accessory ostium. That is very important. If you don't, what can happen otherwise? Whatever
Circular
drainage,
phenomena.
Recycling of the mucus.
Recycling.
the drainage coming out through the natural ostium can go back inside the sinus through the natural accessory ostium.
Sir, I think the pathology, what was looking in the CT scan, and in reality in surgery, at almost the drugs have done the job now.
Yes, because of the steroids.
Yes.
So the preparation is so important.
Yes.
It makes your identification of the landmarks much easier. It makes, bleeding very, very less. See the maxillary sinus from inside now.
Yes.
Your war will be very simple. Otherwise, the war will be with hemorrhages and all tissues. If you prepare well, your war will be very simple.
Yes. So the well you prepare, the less time you spend in the operation room. Otherwise, it's a bloody pool you have to struggle.
Yes, so the field is most important to prevent complication.
Yes, sir.
This is the surgery of landmarks. The margin of safety is very less. The important structures, orbit, skull base, optic nerve, carotid arteries, sometimes at some millimetric distance. A slightest of the disorientation can push you in major trouble. So identification of landmark is the most important thing to prevent complication, and that is best achieved by.
Sir, the size of the maxillary sinus opening in sinusitis versus polyposis.
Pardon?
The size of the maxillary sinus opening, maxillary sinusotomy.
Yeah.
In case of polyposis versus sinusitis.
It depends. It depends on the need, what you are operating for. Depends upon the pathology. For this AFRS, you know, you need to deliver topical steroid in abundance. You need to follow for life, long term. You actually need to have a mega opening.
Okay, sir.
Yes.
For a simple polyposis, you don't need to. And people have graded differently according to their convenience. By and large, let me tell you,
The maximum of middle meatal antrostomy size should be attained, I think.
yeah,
All dimensions.
yes, in AFRS, yes. So like
Yes.
this opening, I have made little bigger. I can make it more bigger if I want to by removing this perpendicular plate of the palatine bone, this one, to flush it till the posterior wall.
Okay, sir.
If I want to really enlarge it further and give more gravitational drainage, I can remove this part of the inferior turbinate to flush it with the floor. This one.
Yeah.
Okay.
So depending upon the need,
Sir, in this case, what is your plan?
yeah, in this, looking at the disease.
Because
I
in
don't
this
want
case,
to-
the disease was very extensive.
Yes. And see how steroid has tremendously changed the picture.
Yeah.
So that's called as mega antrastomy, no, sir?
Yeah, a little bigger. See, already I'm waiting for the debrider. So, a relatively bigger size, relatively mega antrostomy, so that you can do surveillance in your outpatient department using 0-degree telescope or 70-degree. See this kind of opening?
Yes, sir.
And you can push the topical steroid much better without any hindrance. So it is all, individualized decision how big the opening should be, depending upon the pathology, depending upon the need. And see this, how big the opening I have made. You have to make sure that your topical should reach in abundance in the depth of the sinuses. See this?
Yes. Yes, sir. Very.
So this is creation of middle meatal antrostomy, simple so far. See this?
Yeah.
What we have achieved is uncinectomy and middle meatal antrostomy. Nothing else. Give me a Merocel. What I will do, at every step, we use the same sponge, adrenaline soaked sponge, to keep the mucosa or keep the bleeding in check, because this is capillary bleeding. You can easily control with the Merocel packs. See this?
Yes, sir.
Now the second part of this surgery, this is very, very important. Removal of the upper part of the uncinate.
Uncinate.
Why it is important? Upturned over there. This upper part of the uncinate is very close to the lateral limit of this entire paranasal sinus labyrinth. That is
Okay.
orbit.
Yes.
See this, my
Yeah.
upturned through cut.
True cut. Yes.
Upturn, true cut.
Yes.
Very nice instrument at this stage.
Yes.
Just to take off this uncinate. That's it.
Yeah.
Very nice.
And at this point of time, you can define your lateral limit.
Which
Because
company is that true cut you have used now, Satish?
Nagashima.
Nakashima.
Sir, I think the instruments what you are using appears to be little longer than what we routinely use. Is it correct?
Yeah. Because I use the same one in the skull base as well.
Okay, sir, right.
See now,
Yes.
what you see behind this one,
Bulla.
this is your lamina peperacea.
Okay.
See the movement, you remove the upper part of the uncinate, you reach to the lateral limit of the entire paranasal sinus labyrinth. So that's a very, very important guide. See this?
Yes.
I am still using my red 40 and I have reached my lateral limit so easily. See this?
Yes, sir.
All the way. See the upper part of the uncinate?
Yes, sir.
Now at this point I will show you the simplest approach to the frontal sinus. Simplest. See, this is your axilla. One can easily identify the axilla.
Yes, sir.
I am taking off the part of the axilla, flushing with the bone. Can you see this?
Yes, sir.
Yes, sir.
Yes,
clear?
yes, very nice.
See, this is my lateral limit all the way. All the
Okay.
way. I am still with a 0 degree.
Okay.
This is your maxillary sinus. I remove the upper part of the uncinate here. Orient yourself. And all the way, this is lamina papyracea, all the way till axilla. See this?
Yes, sir.
Define the axilla very clear. I hope it is very clear.
Yes, sir.
Yes, sir, very clear.
See, use the landmarks which are easiest to identify. If your landmark is difficult to identify, then it cannot be a good landmark. So I am using axilla as my landmark. This is the point I am going to do my frontal sinus work even before removal of this bulla. Though the bulla here is also rudimentary, it is of no use to be considered as a landmark.
So, what an intact bulla with rudimentary.
Yeah, here but it is rudimentary, so I am not,
Yeah, not much
considering
considered.
it as a good landmark. Now I am changing to 70 degree. 70 degree is the scope of choice here for the reasons I tell you. If you recollect, during the CT scan I refer to the beak. The frontal sinus is flowed by the beak all the way from anterior till posteriorly it ends at the frontal recess.
Yes, sir.
And beak is almost always present. Second landmark I am taking into consideration is the beak. See this?
Yes, sir.
Yes.
Always use the landmarks which are reliable. See this? Axilla you can easily see. See this? Why people are so, why people are so, frightened with the frontal sinus work? For the fear of complications, And there are three fears of complication, three complications here in the frontal sinus surgery, always, which the surgeons are frightened with. Number one, injury to the skull base. Number two, injury to the orbit. And number three, injury to the anterior ethmoidal artery. All these three you can overcome and do a confident job using 70 degree. The reason being, 70 degree gives you ability to visualize your limits. For example, with 70 degree I can see my orbital limit. Can you see this lamina?
Yes, sir.
So if you see the lamina and do not cross this, you are not going to enter into the orbit while doing frontal sinus work. This is my lamina. See this?
Yes.
So this is my lateral limit and I can keep with 70 under vision. Okay?
Sir, sorry to disturb you.
Yeah.
If you don't have 70, can you convert the 0 degree to 70 degrees? Can you show the external picture?
Yeah. If you don't have 70 then?
How can you use
How
the
can
0
you
degree
use this
telescope?
0 degree as 70 degree? Any angulation of the scope or any show the external field?
How can you convert the 0 to 70? You can convert the 70 to 0.
Sir.
Halka. Leave it. See now. So that is my lateral limit. Okay?
Sir, please show
Yes.
Sir, can you please show the beak?
Yeah, that's what I am coming to.
Yes, sir.
So this is my lateral limit which I always have to respect and not to cross this to enter into the orbit. Second 70 degree offers me the ability to visualize my medial limit. See this turbinate?
Yes.
This middle turbinate goes up. Anteriorly it is attached to the lateral wall.
Yes, sir.
But posteriorly and superiorly it goes up and gets attached to the cribriform plate.
Yes.
Above there.
Yeah.
At the junction of medial and lateral wall. And this you can refer as your medial limit.
Yes.
Yes.
If I keep with 70 degree my lateral limit and medial limit and view and work in between,
Yes.
I am never going to give any damage.
Yeah.
Neither laterally nor medially.
Yes.
So as long as I don't damage the turbinate and stay lateral to it, I stay immediately away from the skull base.
Yes.
Okay?
Yes, sir.
Third is your anterior ethmoidal artery. Anterior ethmoidal artery. I told you anterior ethmoidal artery is far behind.
Yeah.
And this bulla, as it goes to the skull base, it covers the anterior ethmoidal artery. I am just removing the tip of this bulla.
Yes.
Just to keep the picture better. So as long as your bulla is present,
Yeah.
it covers the anterior ethmoidal artery for the surgeon.
Yeah.
you know,
Yeah.
and you are away from all the critical structures.
Yeah.
Now, staying between these two limits, can you see in the roof? That is
Yes.
the beak.
Yeah.
See this? This is your beak.
Yes.
This is
Yes.
the thickest bone in this region.
Yes,
Yeah.
sir.
So thick a bone. See this?
Yeah.
Yes, sir.
What I have to see with 70-degree under vision, keep an eye on the lateral limit and medial limit, stay in between on the beak, see?
Yeah.
I am
Yes.
following the beak, where the beak ends is what?
Yeah, it's a frontal recess.
You don't need to bother any time. It is always frontal.
Yeah.
What's my point?
Yes.
So, whenever you use 70-degree, keep your medial and lateral limit defined. Keep under vision with the 70.
Yeah.
70 offers
Yeah.
to keep all the medial and lateral limit under vision covered. So that's the beauty of 70-degree.
Sir, Dr. Jain,
Yes, sir.
if you don't mind, can you just orient people with the 0 degrees, how much benefit we are getting? Because the majority of the people we are using 0 degrees and
Yeah.
we find very difficult to identify the landmarks.
Yes. So 0-degree will not offer you visualization
Yes.
into the frontal.
Yes, yes.
So 70-degree gives you direct visualization. See this.
Yeah.
Look at the thick
Very, very,
beak.
very clear, sir. Can you give a big applaud for the excellent demonstration of the frontal recess? You made everybody easy. I think they can
It
go
is
and
easy.
look.
You all can do it. This is
Yeah.
beak.
Yes.
So this is the obstacle.
Yeah.
My frontal sinus opening is behind the beak. See this?
Yes.
This is what we saw on CT scan.
Yeah.
See, the frontal sinus is here.
Yes.
It is flowed by beak, and ultimately it ends here.
Yes.
So what Graf has described, to visualize more deeper into the frontal sinus to deal with more pathologies,
Yes.
what you can remove?
Beak.
From here till here, remove this entire beak,
Yeah.
and then you will be able to see through the 0-degree directly into the sinus.
Yes.
So obstacle is the beak. And to overcome this obstacle, we are using 70-degree.
Yeah.
Sir, now,
See, that is your frontal sinus.
Yeah, yeah.
yes, sir, sir, now,
Very clear?
Very clear, sir.
So 70-degree offers you the ability to do it without any risk.
okay, sir.
I have my lateral limit, I will not cross it under vision.
Yes.
I have my medial limit, I will not cross it.
Yeah.
And this is how my bulla is, as long as bulla is there, I am least bothered about the anterethmoidal artery reverse. I have not even thought of anterethmoidal artery coming in this way.
Yes.
Now remember during CT scan what I showed. In CT scan, I showed you the beak.
Yes, sir.
After the beak, we went almost a centimeter behind where the cribriform was there.
Yes.
Then almost after a centimeter behind was the anterethmoidal artery.
Yes.
At the end of the anterethmoidal roof.
Yeah.
So my anterethmoidal artery is miles away while working at the frontal sinus. You don't
Yes,
need to even
yes.
think of that.
Yeah.
Sir, now,
Don't frighten yourself.
sir, can you
Now see what I'm doing. I'm enlarging this frontal the sinus opening behind.
Okay,
See now under vision what I'm using now? The so-called adenoid blade.
okay,
The reverse blade.
okay.
Yeah.
We never advocate this to use for adenoid because this is rear facing. If you use for adenoid, the cutting edge is behind. See that?
Yeah.
Beyond your control. And with the 70-degree, your cutting edges are in front of you. See this now?
Yes, yes.
We call it skull-based burr.
Skull base.
Skull-based blade. See now?
Yes.
See, the principle of microdebrider is to use under vision.
Yeah.
Now I am using the reverse, keeping my skull base under view. See this?
Yes, yes.
Yes.
This is our skull base blade. Adenoid blade, never recommend for adenoids.
For skull base you are using.
Never. The anterethmoidal artery is far off. See now the frontal sinus?
Yes, yes.
And see, this is how the posterior limit is widened.
Yeah.
What is it?
Sir, what are the ways of removing the beak?
Not at the cost of removing. Here in this case, there is no need of removal of beak.
No, if
Yes.
at all you want to remove, what are the instruments that are required?
If I want to remove the beak, see, my posterior limit of removal is the cribriform plate, beginning of cribriform.
Okay,
Yeah.
Is going to be my posterior limit somewhere here.
okay.
Yes.
Staying anterior to it, everything is safe. There is no critical structure.
Yes.
Yes.
You can remove this mucoperiosteum all the way complete, or you can preserve it as a flap.
Yeah.
until the posterior limit. So how do we do that? First I start removing this mucoperiosteum from anterior to posterior until I find the first olfactory neuron.
Yes.
And staying anterior to that, there is no critical structure. You can drill away this entire bone.
Yeah.
And then your frontal will be there in front of you with a 0 degree.
Yes.
So that is draft. There are variety of draft procedures. Draft 1, 2, 2A, 2B,
Now this
3,
is 2A, sir.
that is modified endoscopic Lothrop. Now there are lots of modification we do. We do 5 types of modification with different indications in our practice.
Sir, now this is 2A,
Modified
sir.
hemi-Lothrop, modified subtotal Lothrop, modified central Lothrop. Variety of Lothrops we have been doing for different indications. In this case, it is not required.
Sir, in this it is 2A, sir.
Pardon?
You have done? What you have done so far is 2A.
It is draft 1, I would say. Draft 1 in the sense because we have reached to the level of the frontal ostium.
Okay.
In a regular fess, you are not supposed to go to the ostium. You are supposed to widen the frontal recess from below
Okay.
without even touching at the ostium. Why we are doing so this? 2A, draft 1, because I want to enlarge the frontal outflow at the maximum
Yeah.
to the limits, keeping the mucosa intact. See everywhere the
Yes.
mucosa is intact?
Very, very clear.
That is most important. If you remove the mucosa, then it is not going to be fess, it is going to be mess. Then the mucociliary activity will become dysfunctional. See my lateral limit,
Yes.
my medial limit, all in view.
Yeah.
And now I am going to remove this bulla.
Yeah.
And then you will see the anterior ethmoidal artery coursing
Yes.
at the skull base. So anterior ethmoidal artery comes out of the orbit, runs along the skull base, and then enters the lateral lamella.
Yeah.
It runs along the skull base.
Yes.
sir.
Since the anterior ethmoidal skull base is relatively thin, you will see this artery most often prominent. See this. My
Yeah.
bulla is reaching till here.
Yes.
sir.
Can you see the anterior attachment of the bulla?
Yes,
sir.
yes.
So this anterior attachment, see where my instrument is. This is the anterior attachment of the bulla.
Yeah.
So if you keep the bulla intact,
Yeah.
you can work here like anything without any fear of anterior ethmoidal artery.
Yes.
The moment I remove the bulla, see behind,
Yeah.
the anterior ethmoidal artery will come behind.
Yes.
Yes, yes, you can widen the frontal recess. Yes, you can widen very well without any fear. So as long as bulla is intact, you can do anything. Now I am removing this bulla. First what you can do, simply you can out fracture it anteriorly, like this.
Posterior to anterior.
Yeah.
Yes, sir.
Yeah.
See, some mucosal attachments, what you can do through cut. Without peeling off the mucosa. Mucosa is diamond. See this, I can use through biting. Through biting is a sharp instrument. You can cut like this. And get this, see this bulla. I am getting this bulla already fractured and getting this out. See this?
Yes.
This is now like a garbage of no use. You have to remove this in toto. And then you will be able to see the skull base in depth. Once you remove the bulla, then only you will be able to see the skull base. This is also part of the bulla. See the skull base is behind. Can you see?
Yeah. Yes, yes.
The glimpse of it? See the
Yeah.
skull base behind.
Yes.
This for the anterior attachment of the bulla.
Yes.
So I have exposed the skull base now. See this?
Yes, sir.
Sir.
I told you the anterior ethmoidal artery courses through the posterior most part of the
Yeah. Sir,
anterior
in this
ethmoidal-
case,
Yeah.
this case, the bulla is not attached to the skull base, if I am correct.
It was the
It
thin
was, sir?
attachment. I showed you the attachment
in
over
toto.
here.
Edges are attached,
Yeah.
but in the middle it is not attached. Mucosal
Yeah,
surface is very clear.
Yes. It was compressed because of the polyps.
Okay.
Had Madhusudan not prepared this case with a steroid, this would have been a very, very difficult situation to
Yeah.
orient for us.
Yes.
So half of the job is done by Madhu
Yeah.
already. And it had made my life easier. See what I want to show here now.
Yeah.
All this,
Sir.
you know, terminate. See, I have my lateral limit in view.
Yeah, very clear.
Orbit,
Sir,
under vision you can do. Always use sharp
Yeah.
instrument like debrider, through cut so
Yeah.
they don't peel off mucosa.
but Dr. Satish,
Yeah.
it is very difficult for youngsters or beginners to get the orientation with the 70 degrees.
Yeah. So
How to get that
yeah,
orientation?
Right,
Your
right,
advice.
you're right. So, before sinus surgeries,
Yeah.
we always advocate practicing in cadavers, on cadavers, to understand orientation with the anatomy,
Dr. Jain?
to get used to instrumentation.
Dr. Jain,
Yes,
there's a small announcement. There's a small announcement. Sorry for interruption.
please.
There is a car preventing the some water people. So please kindly remove that vehicle 3688. Kindly we request the owner of the vehicle, please kindly remove the 3688 from that parking area. Car, which car? We don't know. 3688. Is there anybody owner here? Car owner
No, one-
of
one
3688? Sorry,
Holding.
man, చెప్పిరా పో.
60 milligram OD.
Sorry for the Jain, we are with you.
Yes, sir. See the lateral limit, the
Yeah.
lamina.
Yeah.
See, again and again I am using the same sponge
Yes.
soaked in this. Now see the further anatomy.
Yes.
That was the frontal. See that?
Yes, very clear.
That is the frontal. Behind the frontal, what I showed you, narrow supraorbital recess.
Supraorbital recess.
This is
Yes.
your supraorbital recess.
Yeah,
See
yeah,
that?
very clear, sir.
Immediately caudal to supraorbital recess
Yeah.
is the anterior ethmoidal artery.
Yes, very, very clear. Can you give a big applaud for the good demonstration? Frontal opening and supraorbital recess and anterior ethmoidal artery.
Now-
Thank you very much.
Now look at this. When
Yeah.
we started working at the frontal sinus,
Yeah.
see some fungal material.
Yes, yes.
When we started working, we were working over here at the beak.
Yeah.
And the anterior ethmoidal artery is far behind and far deeper,
Yes.
right at the skull base. So don't terrify yourself unnecessarily.
Yeah.
Frontal sinus anteriorly, this supraorbital cell, see
Yes.
behind, see that?
Yes, sir. Very clear.
With the 70 degree, now I am into supraorbital recess.
Supraorbital recess.
That the caudal limit of the supraorbital is this artery.
Yeah.
See this?
Yes.
And then behind is this recess, after which the postethmoidal
Yeah.
roof starts. See, this
Yes.
is the recess, after which this is your ground lamella.
Yes. Yes.
See, this is your turbinate,
Yeah.
this is the second part, and this
Yes.
is ground lamella which is attached over here
Yes, yes.
onto the skull base.
Yes, sir.
See where the ground lamella is attached, just caudal to the anterior ethmoidal artery.
Yes, yes.
So now before ground lamella, we have removed everything.
Yeah.
This is called anterior ethmoidectomy.
Anterior ethmoidectomy.
Now I'll change to 0 degree. Yeah, that is intersinus septal cell. Yeah, so this is the question. See there, this is the small intersinus septal cell.
Intersinus septal.
The most anterior cell,
Yeah.
if it is bigger, it will narrow the frontal drainage pathway, it will push laterally.
Okay.
Okay, so this is there. Now I am with the 0 degree.
Sir, you are with the 0.
Yes,
Sir, kindly orient with the 0 degree, sir, now.
yes. Beak, beak.
Yeah.
Beak is the guide for frontal.
Yeah, yeah.
sometime if you accidentally open into one of the cell,
Yeah,
which might be bigger than the frontal sinus curve.
yeah,
Some cells, sometimes the supraorbital or intersinus septal are bigger than the frontal sinus and may get, misguided.
yeah.
You have to be careful, follow the beak.
Yeah, maxillary sinus.
Yes,
This is the
same
maxillary sinus.
See
Yes.
the wide opening, adequate?
Wide opening, yes,
I have almost flushed till posterior wall.
yes,
So I can call it as a mega middle metal enterostomy.
yes,
See my lateral limit?
yes,
See the frontal up there?
yes,
Intersinus septal cell?
yes.
This is supraorbital there. This
Yes.
is your
Anterior
anterior artery. Very clear.
Yeah.
See that?
Yes,
And this is now what you see in front of you is the the middle turbinate second part. This is
Yes.
ground lamella.
sir, fungus material is coming.
Yeah, that is behind.
Yes, behind.
See?
Yeah, that's
Now-
the posterior ethmoids.
Yeah, give me straight. Pardon? Glow sign, yes. In the past, when you were not, very sure, when the 70-degree was not prevalent in practice, people used to take frontal glow as a guide.
Yeah,
But now with the 70-degree, you can go inside the sinus and see.
yes,
There's no need of checking any frontal glow. You are always sure. You are right into the sinus.
yes,
See this part of the, this bulla, the floor of the bulla.
yes,
I am taking off. And this way, I am developing another landmark. See this.
yes,
This is my roof of the roof of the maxillary sinus.
yes.
This is the roof of the maxillary sinus.
Roof of the maxillary sinus.
This is a very important guide for posterior work.
Yeah,
See, because of the polyps, even the ground lamella is destroyed.
yeah,
Massive polyposis can distort the anatomy to any extent. Yes, yes. Can we have a infraorbital cell, retromaxillary cell,
yeah,
which all can distort your identification of the maxillary sinus. So CT scan, a prior CT scan will guide you. Get a 0.5 mm CT scan on DICOM.
Sir, can you show the ethmomaxillary crest, sir?
That is the medial orbital wall,
yeah,
inferomedial orbital wall. See this?
yes,
Always open it adequately so that you don't leave any infraorbital cell here. See this?
yeah,
Adequately opened up. See the medial part of the
yes,
upper part of maxillary sinus, thoroughly opened up.
yes,
Otherwise, one may miss unaerated infraorbital cell and then it can keep on causing symptoms. If it is, look at the CT scan and communicate with the maxillary sinus properly. Yeah, you can debride. Now, see the bulla, ground lamella itself is destroyed.
yeah,
This is your turbinate.
yeah,
Generally at this stage,
yeah,
we don't recommend doing post-ethmoidectomy.
uh-huh,
The reason being, if I keep doing post-ethmoidectomy from here,
yeah,
I never know when accidentally I can enter into the sphenoid sinus.
okay,
And if I get disoriented and keep going inside the sphenoid, I can damage a lot of important things and that could be a disaster.
so what is the best method, sir, now?
So what you can do best to prevent that, identify the sphenoid ostium first
Sphenoid ostium,
and then go for posterior ethmoidectomy,
yeah,
keeping your sphenoid ostium as your posterior limit,
okay,
not to go beyond that.
yes,
Optic nerve, carotid artery, anything, any distorted, anything will never come anterior to the sphenoid ostium.
yes, yes,
So what I am doing here, going medially, see
Yes.
lot of polyps,
yes,
See here, you know the septum was even
Yeah.
distorted, pushed laterally.
Yes.
See everything, all distorted.
Yeah.
Identification of the sphenoid is a, ostium is a big challenge.
Yeah.
So what I will use here, this roof of the maxillary sinus.
Yes.
See this roof of the maxillary sinus?
Yes.
I will draw a line
Yeah.
and stay either in line or inferior to it, not to go beyond,
Okay.
to look for the maxillary sinus ostium, flush to the septum.
Yeah.
See here,
Yeah.
flush to the septum.
Yeah.
Ostium is always flush to the septum.
Yeah.
That is.
Yes.
See this?
You have opened the sphenoid sinus.
Had I gone above this level,
Yeah.
what
No.
can happen?
You might have
This,
used the
this,
roof.
this
Yeah.
sinus ostium
Yeah.
is never along the floor, it is along
Yeah.
the roof.
Along the roof.
One can damage.
So roof you might have damaged.
Yeah. Even this turbinate is not very stable because
Yeah.
of the polyps. We'll do something later. This looks like superior turbinate.
Yes.
Pardon? Which? Yes. Yeah. Fierce elevator or suction periosteum is a very safe instrument. See now inside the sphenoid,
Yeah. Mucinous discharge is there.
lot
Fungal,
of mucin.
fungal mucin.
Yeah. I have not done post-sphenoidectomy. See this?
Yeah.
Because I have fear of entering into the sphenoid.
Yeah. Now you will come
Both are there.
retrograde.
Now see, lot of mucin,
Yes.
thick mucin. And I'm using now large bore suction.
Yeah.
Suction and irrigation is the best tool
Yeah.
rather than using any. See this suction,
Yes.
irrigation.
Yeah.
Sir, is there any role of this hydrodebrider in this type of scenario, sir?
Yes, hydrodebrider has a huge role. And we have bought hydrodebrider only for this pathology.
Okay.
Because you have to thoroughly wash and remove each and every bit of fungus.
Yes. Yes.
See the sphenoid sinus?
Yes, very clear. Sir, can you just orient all the structures with the
Yeah,
0 degrees?
I will. Yeah. Irrigation is the key. If you leave
Yeah.
any fungal material,
Yeah.
then the same reaction can start again. Now see, I am in the midline. This is clival
Yes.
recess.
Clival recess.
On either side are the carotid artery, paraclival
Yes.
carotid.
Yeah.
Above is the sella.
Sella.
And
Yes,
see,
sir.
because of the expensile
Yeah.
sphenoid sinus, because it is expanded because of this
Yes.
fungus,
Yeah.
see how the structures have become so dehiscent.
Yes.
See, there is a sella, and that's the
Yeah, it's a dehiscent.
paracellar
Sir.
carotid.
Yeah, bony dehiscence is there,
Yeah,
sir.
see here laterally,
Yeah.
the bluish is the paracellar carotid.
Yes.
So,
Paracellar carotid.
yes. So the question from Dr. Here in the in the theater, where the diaphragma cella and where the,
Clivus.
okay. So yes. So plenum sphenoidal is the roof of the sphenoid.
Yes. Planum sphenoidale.
So
Is the
I
roof.
will show you all the three structures and all the structures inside the cella.
Yeah.
Let me now see what I said. As I identify the sphenoid ostium,
Yeah.
we will go for posterior thymoidectomy through cut. See this? Now is the turn for posterior thymoidectomy, and I have my structure behind very clear now.
Yes, sir.
So it is very safe now.
Yeah. So now you are dissecting anterior to the sphenoid.
Yes.
Opening.
Everything anterior to it.
Yeah.
Through cut और अच्छी नहीं है क्या? See this?
Yeah.
I can remove everything. Give me the divider. I can take away with a good through cut or with the micro debrider. Now everything has to go.
Yes.
To give a wide cavity, full house has.
Yeah. So your steroid spray will go to nook and corners.
Pardon? Yeah, you can use a sphenoid punch, Carrison punch, through biting, scissors, drill. We are not supposed to widen it too down. The sphenoid ostium, we are not supposed to widen too down, otherwise it can take away the vessel supplying the nasal septum. Because that vessel is a future supply for the Haddad flap in case required. Why to unnecessarily damage in sinus surgery? Widen laterally. See this?
Yes, sir.
More and more sphenoid coming in view.
Sir, is there
That's the dehiscent carotid artery.
Yeah,
Yes,
yeah.
sir. Yes, sir. Is there lateral resist, sir, in this case?
Yes.
Lateral resist.
Yes, in this case, yes, there is lateral recess.
Sir. Sir, can you show the surface landmark for trans-pterygoid approach to the lateral resist, sir?
Yes,
Surface
yes.
landmark.
Through cut this is.
I think camera needs to be focused a bit, sir.
Oh.
Small vessel. Small vessel.
Sir, is it post-septal artery branch? The spurt is horizontally onto the septum.
Pardon?
Post-septal artery branch is bleed is there, sir?
Yeah, that's a small vessel. Doesn't look like that main one. That's the the optic now there above. See what you are ensuring. Removal of all disease, antigenic material, establishing ventilation and drainage, and ensuring your topical steroid reaching everywhere efficiently.
Sir, little bit focusing of the scope, and also with the ball probe, can you show all the structures, sir?
Yes, yes.
Now it's clear.
Clear.
With the ball probe, can you show the structures?
Yes, yes, I will. See what I am doing, what I suspected on CT scan. This is actually the right side sphenoid which is ballooned and pushed
Yes.
the left sphenoid like a small clap.
Small. Sir, can you show the left sphenoid, sir? That is a small one.
Very small clap.
Yeah,
See
that
this?
is the one.
See this?
Yeah.
Trans-pterygoid approach, sir?
No, that is a small.
And that's the lateral recess here.
Yeah, yes,
Yeah.
sir.
So I am removing this septation. It has to be first fractured very clear and then removed rather than pulling it. See that?
Yes.
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 Because it can be attached to the optic nerve, carotid
Yeah.
artery, anywhere. So cut. Yeah, the carotid is above. Huh? Yeah. Oh, can you give me another Savlon? Yeah, carotid, optic nerve, everything has to be kept under vision.
Yes.
See this? This is the cell. I am biting through the through cut. Never pull. See, never pull. गीला गोर दे दे गीला दे दे गौर जब तक Huh? True cut is easy instrument. See this, the thick septation again here.
Yeah.
I am opening up all this area behind so that my irrigation reaches.
Yes.
See this?
Sir, the cell what we are seeing is the left side sphenoid, sir.
Yeah. So left sphenoid is just pushed like a small recess.
Yeah, small cell it is appearing.
If you have seen at the CT scan,
Yes.
yeah.
Yeah. This is an intersphenoidal septum you are removing, sir.
Yes. And the thing which is most important is,
The intersphenoid septum sometimes in relation to the internal corridor artery, sir.
yes, sometimes, not always.
Yeah, yes, sir.
So you have to be careful.
Careful there.
Now we are at the finishing stage on this side.
Yes.
I will show with a 70-degree from inside as well.
Sir, can you find? No, good.
See flushing. See, that's the carotid artery, dehiscent. See that?
Yes, sir.
This one, this one.
Yes, yes, sir.
This one dehiscent. See this?
Yeah,
Yes,
yeah.
sir, yes, sir.
Yes.
This is optic now above.
Yes.
This septum was right coming over there. So I
Yes.
use my through cut. Very clear?
Yes, very clear. Sir.
So large sinuses, dehiscence is not uncommon. Yeah, divider. Now the entire posterior sphenoid sinus is one cavity.
So you are not pulling any attachments.
Never.
See, that is what we have to observe. He is not pulling that one.
Break with the through cut,
Take true cut or debride.
debrider.
Yeah.
I think only sir has the guts to debride inside the sinus with
Yeah.
erosion.
we should use only ball proof.
You can do under vision. Yes, that is important teaching. Anything you do under sphenoid has to be properly under vision.
Yeah.
So that's why dad tells sir is Bahubali of ENT.
Oh,
Any
come on.
disease is nothing. Whatever disease is there, it just belittles in front of Satish Jain sir.
Come on.
Sir, can you show the Vidian level landmark, sir? Vidian level landmark,
Yeah, I will show you. I will show you.
ICA landmark.
All possible landmarks I am going to show you now. Let me focus it better. Look.
Yeah, it's focusing good, sir.
See now, that is
Yes.
interior
Yes, sir.
through cut. Yes. And now with the 70-degree, I'll show you the lateral recess.
Sir.
We'll go with the. Oh, there's Sevlon there. Rider?
Sir, if you don't mind, can you focus a little bit camera, sir?
Yeah, that's what.
Little blurring is there. Yeah. Yes.
I think it is better now.
Yeah, it's clear, sir. Thank
I
you.
will show you some good anatomy now.
Yeah.
See, the best thing what you have to ensure is to keep everywhere mucosa intact,
Yes.
maximum possible.
Yes.
And that is done by using sharp instruments.
Yeah.
Through biting, debrider, scissors, drill. If you try to pull anything, the mucosa will peel off.
Yeah.
See, everywhere the mucosa is completely intact. See this? And give me 70 degrees. This is your lateral recess.
Yes.
Give me 70 degree to show you. So now I am showing the sphenoid and the maxillary sinus from inside with 70 degree.
Yes, sir.
70 degrees.
Yes. See this.
Yeah.
Yes, sir.
This is your maxillary sinus from inside.
Yeah.
All little bit edematous mucosa, nothing else.
Yes.
Now going into the sphenoid and
Yes,
see
sir.
this
That's the
recess.
lateral recess.
Yeah.
That's
This
the,
is visualizing lateral recess with 70 degree.
yes.
Yeah. Lateral recess.
See, 0 degree cannot afford to give you this view.
Yes, yes, sir.
Value of 70 degrees remains. See this anterior wall of the maxillary sinus you can see well.
Yes, yes.
With so much of ease and comfort.
Yeah.
For the CSF leaks from the lateral recess, the same approach, sir.
In CSF leak,
From the
we
lateral
remove this
recess.
pterygoid process to make it visible with a 0 degree.
Sir.
See, this bone is the hindrance, this bone.
Yes,
Yeah.
sir.
See this recess is there?
Yes.
In CSF leak, we remove this bone.
Yeah.
Completely the entire pterygoid,
Sir.
Okay.
which is
Oh,
pneumatized.
that is the yes.
And then it will be head on with the 0 degree.
Okay.
Skull base surgery is always done with 0 degree.
Sir, phenopalatin foramen, sir, can you show there, sir?
Sphenopalatine foramen location I will show you.
Yeah. In relation to the spinopalatin foramen.
See, complete inside view of the sphenoid sinus.
Yeah.
Yeah, you can. Now, coming back to 0 degree to show you sphenopalatine artery location. In the simplest way, see this. See, sphenopalatine comes out of the pterygopalatine fossa.
Yeah.
Yes, sir.
Behind this is pterygopalatine fossa.
Yes.
Okay?
Yes.
This is your attachment of the middle turbinate.
Middle turbinate.
So, if I elevate, if I go behind, see this,
Above.
that's the medial wall mucosa.
Yeah.
Yes, sir.
If I elevate this, go behind, it will be right in the sphenopalatine area.
Yes, sir.
Suction, I need a suction periosteum if you have. Yeah, posterior nasal nerve. There are fine filaments which pass through this palatine bone, the sphenopalatine foramen, destined to supply the nasal cavity. So when you abolish them, that is posterior nasal neurectomy.
Okay.
That's a good way. Pardon? Yeah. चल रहा है कि suction नहीं चल रहा? See, when I elevate this flap,
Yes.
I will be right on the sphenopalatine artery.
Yes,
The suction
yeah.
is not working.
Ethmomaxillary crest.
That is the crest there.
Yes,
Yeah.
sir.
Ethmo
Maxillary crest.
maxillary crest.
Yeah.
Yes.
So
Just
you have
behind.
to, just behind the crest. You have
Yes.
to punch out this crest,
Yes.
Yes.
and the artery will be there behind.
Yes, sir.
Yeah.
Yes, sir.
Yeah,
Yes,
the nerve
yes.
also comes through that.
Yes, yes.
Yes. Yes.
So that's the region of the sphenopalatine.
Yes, sir.
We are not supposed to do anything to it.
Thank
Yes,
you.
sir.
But exposure technique and anatomical landmarks really nicely exposed.
That is interior
Wonderful.
of the
These
sphenoid.
sphenoid and its total expansile, skull base, sella turcica, optic nerve, carotid vessels. My God.
Now, we have utilized this as a landmark, this middle turbinate.
Yes.
But this is very, very, you know,
Sir, can you show that planum, sir? Planum sphenoidal with the
plenum
ball
is
probe?
here. Plenum is there right in front of you.
Yeah.
Yeah. This
Post
is plenum.
lateral.
This
That
is
the
plenum.
sphenoidal.
Yeah.
Yes.
This is sella,
Cell.
Yes,
Yes,
sir.
optic nerve, and above that this is plenum.
Yes, sir.
Now,
Sir, upper
this
clivus.
middle turbinate, because of the massive polyposis on either side, is not stable. This is always useful as a landmark.
Yes, sir.
Okay.
Since we have utilized this as a landmark, we have to do something to stabilize it. If it falls off, suppose it falls off laterally like this,
Yeah.
it will block off all the ethmoids where the steroids can
Yeah.
penetrate,
So,
So that will stop penetration with steroid.
yeah.
So you have to do a lot of maneuver. One thing is you can do bulgarization.
Bulgarization.
Yeah, you can make what the either side of the septum and the
Yeah.
cabinet one keep like this for a day or two
Yeah.
to introduce invite adhesions.
Yeah.
Another is partial turbinectomy. Partial turbinectomy in massive disease is a good option.
Okay.
In partial turbinectomy, you have to leave the upper part as your landmark. See this?
You are leaving the upper part
As a landmark.
as a landmark. Good.
This will not fall off.
Yeah.
This is
And-
called Weigand's middle turbinectomy, sir.
Yeah, partial. See this? I have left a stump as well where close to it the artery comes.
Yeah. So you have left a little bit at the
So
artery.
now with 0 degree and with your douching, everything will go freely inside.
Yes.
So in massive disease, massive mucosal disease, this is one of the way to prevent turbinate problems in future. Particularly
Okay.
when that massive disease has made the turbinate floppy.
Yeah.
Sir,
Okay.
of course, not related here. Unnecessary middle turbinectomy may hampers the olfaction. Can you comment, sir?
Yeah, so that is affected in the uppermost part. See this, I have left above.
Yes, sir.
Yes.
The olfactory area is in the upper part of the
Middle turbinectomy.
Middle
this
turbinate.
recess here.
Yeah.
In the cribiform plate, this uppermost part of the middle turbinate and the uppermost part of the septum,
Yeah.
which is spared.
Yes, sir.
I have not done a complete chopping.
Yeah.
Okay?
Yes.
So this is full house fast on this side. Now, the treatment, as I said, since it is AFRS, treatment is steroid.
Yeah.
You have to push topical steroid, this patient will never come back with any problems.
Okay.
What is the post-op course of steroids, Satish?
Yeah. For AFRS, we give in a tapering dose 2 to 3 weeks oral.
Okay, 2
minimal.
to 3 weeks or
How much prednisolone,
And
sir?
only topical then.
topical. Okay.
Sir, in case of sinusitis after surgery, any antibiotic solution to wash the sinuses?
No. Antibiotics have no role in sinusitis unless there is proven secondary infection.
What is the role of mupirocin solution for the
Yeah,
antral wash?
in known Staph aureus infection, Staph aureus biofilms, topical mupirocin is a magic.
Magic.
We acquire mupirocin because mupirocin in the topical form availability is very difficult.
Difficult.
Of course,
What
it's
we
not
get-
available in India. It's
Yeah,
not available
in
in India.
clinical form it is available only in the form of ointments.
Yes, sir.
That is oil based,
Yes.
tea-backed,
Tea-backed,
oil
yes.
backed which cannot be mixed in saline.
Yes, it's a Vaseline.
So what we have done, we have approached manufacturers. Still we have, the 3 months back we acquired 1 kg of mupirocin. This was this time costing 3.5 lakhs. 3.5 lakhs.
1 kg mupirocin.
So in all those Staph aureus infection, anywhere in the nose, ear, or any open wounds anywhere,
Yes.
if you have MRSA, any staph infection, give mupirocin, washes or dressing, it disappears like anything.
Wow.
Deadly.
Deadly.
In 1 or 2 washes only, it clears off.
Clears off.
So 1 or 2 gram of mupirocin is good enough. Mix in saline and wash it. That's it. For those infections.
So
But
post-operative
routine
role of
nasal douching
macrolides,
is a-
clarithromycin.
Which one? Clarithromycin. Clarithromycin is very useful.
Yes.
Clarithromycin is a wonder drug. It acts on the neutrophils basically. It curbs the neutrophilic activity. That's why it is a principal way of treatment in non-polypoidal sinusitis. We give in low doses for long term. In the post-op also, whenever there is infection, the neutrophils have the role. So in order to control the infection also, in order to prevent biofilm formation, this macrolides are very important. Clarithromycin is very important. How the biofilms form by the quorum sensing mechanism, where a lot of bacteria come together and they sense like there should be a minimum quorum number of bacteria to form the biofilm which secrete the polyglycan sheet around and protect from the patient's immunity and the antibiotics and all those things. This clarithromycin prevents the quorum sensing and prevent the biofilm formation. So in all post-operative nasal sinus infection, we always add on clarithromycin to prevent,
The role of methyl
2
glycol,
to 3
sir.
months, 4 months sometimes. Low dose is 250 OD.
Role of methyl glycol to prevent the biofilms.
Which one?
Methyl glycol means Maduka honey.
Manuka honey is
Manuka honey.
superior to all.
Yes, sir.
That is lethal.
Yes.
We use very extensively in the topical form in the post-operative sinus cavities, even the ear infections, open wound infections, irrespective of the bacteria, whether it is Pseudomonas, Staph aureus, anything without even culture sensitivity, if you use it is lethal.
Sir.
Not only to the bacteria but biofilms as well. See the cavity ultimately. Now what you have to do, you have to teach your patient introducing topical steroid in the right areas. Into the difficult areas like frontal sinus also we tell them like a prayer position or lying head back and all that to introduce. Train them for a day or two and they will keep doing. Call them in a month, two like that whether everything is okay. Now with this kind of a bone work done, suppose in the worst to worst condition, patient lost to follow up, again the polyp develops, the allergy and all those phenomena develops. Since the entire bone work is done, even if you give a good course of oral steroid in the post-op and debride those polyps under local anesthesia, it will revert back to normal very fast. This patient you can indirectly guarantee that you will not need a formal sinus surgery in future, because you have already reached to the limits everywhere. There is nothing left for the future sinus surgeon to do any bone work.
Yes.
What my point?
Yeah.
So in sinus surgery, a lot of patients may ask you, will it come back? Yes, it can come back. Your follow-up, topical douching, allergy treatment, whatever desensitization, whatever treatment, immunotherapy is required for the comorbidities and a regular follow-up and douching. In spite of that, if you are lost some time, you are not able to do adequately, and even if it recurs, you will not need any formal sinus surgery in future. That is sort of indirect guarantee, not a direct one, that it cannot come back.
Okay, good.
So that is the role of the value of full house sinus surgery. See, this is full house sinus surgery.
Yeah.
Sir, can you define appropriate medical treatment instead of this maximal medical therapy?
Yeah. So actually the appropriate term is appropriate medical treatment, not the maximal medical one.
Yes.
And it depends upon the pathology. See, there has been a standard teaching that sinusitis is a medical disease, yes. Medical treatment is the core treatment, yes. When the appropriate medical treatment fails,
yes,
then the need of surgery arises. Okay? Now, in appropriate treatment, medical treatment, you have limitations. You can't use oral steroid for life. They have their own adverse effect. Like such polypoidal patient, you keep giving oral steroid, they remain symptom free. But how long? So you have to resort to topical steroids as a safe option. Now in unoperated situation like in this patient, how will the topical steroid penetrate? It cannot. And what options you have in unoperated situation when all sinuses are closed? Only nasal sprays. Nasal sprays do not cross beyond anterior 1/3 of nasal cavity. So in unoperated situation, your only option left with topical steroid as nasal sprays. So when your appropriate medical treatment, which includes saline irrigation and nasal sprays, it doesn't work, you have to open up the sinus. The role of sinus surgery comes so that you are able to penetrate topical steroids in future. That's the role of sinus surgery. Got my point?
Yes, sir.
All inflammatory load. The inflammatory load was so much to be tackled by the topical steroid earlier. If your saline irrigation and topical spray control the disease, there is no need of sinus surgery. That means your inflammatory load is too less. If it is too much to be controlled by the topical steroid, you cannot give oral steroid for life, then you have to switch over to surgery and make the topical steroid penetrable. That's the role of sinus surgery.
Counseling that
Sir,
steroidal
the role
spray
of
is
CRP,
lifelong.
C-reactive protein estimation case of for follow-up to know the inflammatory load. The
Pardon?
role of CRP.
Pardon?
C-reactive protein role.
No, zero.
Yes,
C-reactive protein is a marker of bacterial infection.
Sir.
This is not infective disease. For everybody, make sure, keep in your mind forever, this is inflammatory disease, not infection. Infection can be secondary sometime for which you can use antibiotics, otherwise antibiotics have no role. Only superadded infection will require antibiotic, that too a short course. Even the clarithromycin used for months is not used as an antibiotic, as an immunomodulator.
Yes.
It works at various levels of cascade of sinusitis to curb the inflammatory markers. You know, it works on various cytokines to curb the inflammation. It's not used as an antibiotic.
Yes.
So it is inflammation where the steroid is a role.
Any connection, relation between vitamin D deficiency and AFRS?
Yes. 100%.
100%.
Not AFRS, any sinusitis.
Any sinusitis.
Vitamin D deficiency improves the immunity.
Okay.
Sinonasal immunity.
Okay.
It improves the sensitivity to the steroids. It works on the sinusitis cascade at various levels to control the cytokines involved.
Yes.
See, if the patient is severely vitamin D deficient, even if you are giving full dose steroids, they are not working.
Right.
Make insensitive. They make the glucocorticoid receptors insensitive to attach to steroids.
So
by and large, this is immune complex disease. Anything which improves the immunity is going to give benefit. Anything which is going to halt the immunity, going to deteriorate the immunity, is going to have a negative impact. For example, probiotics, prebiotics all improve the immune system by means of improving the gut immunity, improving the good number of bacteria in the gut. So anything prebiotic, probiotic which improve the immunity are going to have a positive impact. Antibiotics which reduces the good bacteria in the gut have negative impact. So there is no point in giving unnecessarily antibiotics in sinus unless culture directed specific antibiotics. Broad spectrum antibiotics are contraindicated because they will kill the good bacteria as well, which are required. We have to use bacteria specific culture directed antibiotic, that's only. No, okay.
Sir, small question, sir. So do you order vitamin D test for every CRS patient, sir?
Yeah, ideally it should be. We have a list of investigations which we order to direct our, future treatment. For example, like Madhu asked, for example, we have a list of investigations which we direct in every patient of CRS. Not only vitamin D, IgE, eosinophils, aspirin sensitivity if patient has asthma, immune function test for B cells and T cells if the patient has recurrent bacterial infection, not only in the sinus but elsewhere also in the body, like recurrent, bacterial infection in the ear associated with sinusitis, recurrent purulent infection in the nose, recurrent lower respiratory tract infection. Those are the patients where the immune system has to be thoroughly assessed, both B cell and T cell pathway. So IgE has a big role. You know why? If patient's IgE is low, I would never go in for surgery first. I will first start the clarithromycin. If the patient IgE is high, there is no role of macrolides. Zero. If the patient's IgE, eosinophils, both are very high, there could be staphylococcal enterotoxin, there could be staphylococcal biofilms, there could be severe allergy like AFRS. So those are high inflammatory profile, and then you have to accordingly treat them with immune skin prick testivity and sensitivity and immunotherapy or staphylococcal directed therapy. If associated asthma, always aspirin sensitivity test to prevent future relapses. So there are a list of investigations. Take a sample of polyp and send for histopathology. I tell you to protect you from lot many problems. Not only knowing the profile of the patient by means of eosinophilia, but directing post-op therapy also, because every patient asks, will my polyp come back? Polyps come back. How long I'll need this post-operative therapy, irrigations? It all depends upon your profile. Like in cancer surgery, when we operate, we say Your post-operative specimen, the neck dissection specimen will guide us whether the post-operative radiotherapy is required, whether a concomitant chemotherapy is also required. Like if your lymph nodes show extracapsular spread, multiple levels, you will give added chemotherapy also. Similarly, take a histopathology and tell your patient your final report will guide us how long will, depending upon the eosinophilia, how long the post-operative irrigation will go on, how are the chances of relapse. Like in massive disease profile like AERD where the eosinophil count is too high, you can warn them you have a high chance of relapse. You have to be in very, very close follow-up. You will need more intensive irrigations, steroid irrigation. You will need more adjuvant therapy. So you have to warn and prepare them for the future. So this, all these investigations gives you insight of the inflammatory profile of the patient, which can guide your post-operative protocol. Any other questions?
Thank you very much, sir. Are you going to other side or not?
Other side is a yes disease because of this septal dysfunction, minimal disease. We have other case ready. If you want, I can show you. If you have a septal deviation, I can show you a limited septoplasty as well.
Thank you,
sir. If you want. You want this septoplasty to be seen? Endoscopic?
Yeah. Sir, everybody is interested to see your endoscopic septoplasty.
Okay, I will show you minimal septoplasty. See this?
Okay.
We have shown on CT scan this huge deflection of the septum.
Yeah.
But this entire septum need not to be removed. Yeah, so that is mechanical blockage. That is not inflammatory disease. That is not fungus trapped. That's not sinusitis. See this?
Yes.
Entire septum is, it's like a U kind of a curvature.
Yeah.
But I am not going to remove the entire septum.
Okay.
See the goal of septoplasty on this side, two-pronged. Might be giving some obstruction also.
Yeah.
So I have to clear the obstruction. That is not a big, I would say problem to this patient with obstruction on this side. See this?
Yeah.
The issue is we have to do sinus surgery on the other side. With this kind of the septum, will not be able to ensure our topical steroid reaching everywhere efficiently.
Yeah.
So some septoplasty required, and I will show you how a limited septoplasty can help a lot in this patient. See this? I am not infiltrating anywhere.
Yes, no
Yeah.
hydrodissection.
Nothing. No hydrodissection, no infiltration.
How far? I think 1 centimeter from the caudal.
Yeah, see, this is far off, far behind.
Far behind. Okay, right.
All your septums you don't infiltrate, sir?
I never infiltrate. I have a fear of this adrenaline dissemination in the systemic circulation and giving havoc. We can't afford to do in such a benign disease.
Only compression, packing.
Yes, it's simple topical. See, I
Sir,
use the same, your sponge packs, nothing else. See this?
Yeah.
I am in the right plane.
Yeah. This is a suction elevator, sir.
This is suction periosteum.
Yeah, periosteum elevator. You gave incision with that and you are elevating.
Yes.
Knife, acha, you give. knife.
Bande yaar. Very clear?
Yeah, very clear.
Even saline you don't infiltrate.
Yeah, I didn't infiltrate even saline. You can infiltrate saline if you want to. See this?
Yes.
This is your cartilage.
Yeah.
This is your cartilage. Now what I am doing, I am breaking this cartilage with the bony junction. See this?
Yeah. Yes.
Only one instrument. See the opposite side?
Yes.
This is the deflected portion.
Yeah.
See the massive deflection.
Yes, yes. We
are not supposed to use a, something like you have to make it very, very straight. You have to make sure that it doesn't obstruct the airway and it doesn't obstruct your irrigations.
Yeah.
It is pushed, not present. It is pushed. See, I am removing this deviated portion.
Okay.
Can you hold the head for a while? Can somebody hold the head, please? See this deflected part.
Yes.
I need not to remove everything. If it is not obstructing, not. Sometimes you have an inferior, spur.
Yeah.
Then obviously you have to deal with the maxillary crest. See this? See now, let me check my airway. See this?
Yes.
This is the deflection which is left behind. Now for the sinus work, see this? The whole area is opened up. Can you see?
Very clear.
Earlier there was no space to go inside. See, I will remove this little bit of the spur because it can obstruct the airway.
Yeah.
See, the rest of the thing need not to be removed.
Yeah.
There.
Plaster.
So little bit more.
Sir, where is the middle turbinate on this side? Can you just show? Yeah, that is. It's almost plastered. Yeah, plastered.
Completely plastered. See there?
Yeah, that is the middle turbinate. Yeah, small.
There is.
Yeah.
It was massive deflection. I have adequate, see this upper strut. Swell body is rudimentary. It has no active role in the present scenario. See, this was the spur now I wanted to remove. See this? See this spur? Very sharp one. One side little bit tear doesn't matter unless you have opposing surface tear. Can you see?
Yes, sir.
Rather it will act as a drainage to prevent hematoma. It's such a big spur. Now, see this? See Madhu, the airway. Can you see the airway?
Yes, sir.
So goal is to improve the airway. Now see the airway. And goal is to access all sinuses without any problem. Not to straighten the septum or nothing.
Yeah.
See now the airway I have. This
Yeah,
is
very
limited.
clear, sir.
This is limited septoplasty.
Yes.
Now the other side face can be done, a limited one. And this is, I tell you, the challenging one because you want me to do?
Yeah, you can do. I think
You want me to do or go to other case?
Sandeep will take over.
Sandeep will take over. So now we move on to the other case. Since we have discussed a lot of things regarding sinus surgery on one side, the other one is a submandibular gland.
5 minutes by the time case is organized, a small gratitude from our side in front of the theater. You
Come
may
on.
not
No,
have
not needed.
had this anytime
Come on,
in
Madhu.
anywhere.
Not
only,
needed.
only here only. No, we are not going to the auditorium. And I told you yesterday, we are just felicitating Dr. Satish Jain
Yeah.
in front of the theater because it's more important. Your time is precious and our time is also precious. Are you getting the picture of here the OT, outside OT?
Yes, sir.
So, small felicitation, you all know, tomorrow is birthday of, I don't
Wow.
know, what's
Happy-
the age of Satish Jain?
Yeah.
Must be 50 years. I think in such a small age, the amount of perfection he has got, it's unimaginable. Anni ready. Shawl, a moment, plaque. Danda?
Sir, is it 57 or 58 years, sir?
Madhu, how young he is? How young he is?
How young he is, he's always sweet 16.
Sweet 16.
Everybody is telling how, they are asking how could he achieve so much of professional and academical efficiency. Please, it will not take only 2 minutes. Just sit down, all the only, yeah, thank you. Yeah, no problem. With Sagar, shawl, please. Yes. Ravi? Sir. Sir, parle, వదిలిపెట్టేసి. Subramaniam, Krishna and Chokalingam. A small cake cutting for in advance for your birthday tomorrow. Yeah, please. No. I'll give my citation. My words of love and affection to Dr.
Sir,
Satish
hey,
Jain.
Madhu,
Ah.
if you don't mind, can you remove the surgical cap?
Yeah. Sir, they want you to remove the surgical cap also because we are-
Yeah.
1 minute and just Satish, just sit down, just for a couple of minutes
Yeah.
only, right? So, no. Maybe you never had a felicitation in an operation theatre complex. Just for the sake, happy birthday.
Happy birthday, sir.
Yes, sir. Come on, sir. Cake cut.
Sir, happy birthday, sir.
Happy birthday to you.
Whole
Happy
auditorium.
birthday to you. Happy birthday to our giant Satish Jain.
Happy.
Wow. Madhu.
I will not give you much. Thank you. Give me the plaque. Satish, this is my heartfelt felicitation, but I'll read fast. He is ENT Bahubali, 5D ENT surgeon. What are those 5Ds? Daring in doing complicated surgeries, dedicated surgeon with 100% involvement, determined in achieving his results with perfection, disciplined in every step of the surgery to give the best results, and dashing demonstration in surgical steps. Who else is other than Satish Jain as a 5D ENT surgeon, not only in India, in the whole world? He is all-in-one incarnation like Almighty. Godly gift of Lord Dhanvantari, meticulous medical knowledge of Cheraka, the amount of knowledge he has, surgical skills akin to Shushruta, healing touch of Hippocrates, compassionate attitude of Mother Teresa, all are put together to make our Satish Jain an inspiring incarnation.
Yeah.
And Satish is Bahubali, and Rajmouli's famous term in ENT, now it is given, quest for knowledge, passion for teaching, determination in training, dedication in learning, innovating new techniques, compassion for suffering, the empathy he shows for the poor people in Jaipur, and simplicity in living, Satish. Nobody, down to earth, even if you give a pillow and a small bed sheet, he will just enjoy his sleep. He doesn't expect anything more than that. Services to rural areas, I have also got inspired with his services. That's why here Madhumani is doing. And ever smiling face makes him as a Bahubali of ENT. Give him a big applause. And Satish, as an inspiring personality, down to earth personality, simplicity is living, always helping attitude, responding and advises about difficult cases. And this is what Madhusudan's heartfelt flowers of gratitude made as felicitation garland given to my friend Satish Jain on 23rd 7 by Madhusudan Rao and Manideep for his services to poor people in our live ENT workshop. Thank you, Satish. We will pack it up. Right. This is as a faculty with a plaque and myself as a memento. And I think your today's enormous explanation and total full house fest was really amazing. And the next cases, all the delegates, I request you, please be and watch the next surgeries also.
Yeah, Dr. Satish, you had to give a advice to the youngsters how you able to reach all these.
No. He is a very good cricketer.
Yeah.
You can see his cricket style.
Yeah.
Cricket photograph. I tried to get more photographs, but I could not get Satish.
Yeah.
So, yeah, Satish. Yeah. Right.
Dr. Satish.
And we would like to thank
Yeah.
Dr. Satish Jain on behalf of IMA AP State also, sir. We are very grateful for coming all the way from Jaipur to Nandyal for giving enhanced knowledge to the young budding ENT surgeons. Thank you, sir.
Sir, we are so grateful for him. Even though he has his birthday, he flew all the way from Jaipur just to teach the people of AP. So Madhumani always, thanks for always having us in your heart and coming all the way and operating and teaching the young PG, sir. It's like you have told them an entire essay that they can write in exam. They need not read any standard textbook. They can just see this and they can write an essay answer. So hats off to you. Jaipur Maharaja.
మధు సార్ ఇంకా నేను ప్రైజ్లు అయినాయి కదా ఏమి
Hello, auditorium.
Yes,
Sir,
yes, please.
So just our arrangement. This will be useful for many people. By
Hello.
the time next case is submandibular
Yes, sir,
styloiditis.
yes, sir.
So I just want to show how we track, how we use our debrider blade, because we have so many. One delegate has asked me, so it will be useful for many people. Show this Excel sheet.
Hello.
Hello, sir.
Yeah, please.
So this is regarding how we manage so many debrider blades.
Yes.
How to prolong the life of the blade by tracking how many number of cases that we use. One delegate has asked me, I thought this will be helpful for everybody. So are you able to see the Excel sheet, sir?
Yes.
So we write 0 straight blade 1, straight blade 2, straight blade 3. So how many blades we have? We write in the list.
17.
And yeah, so each has a separate, so we use around 17 type of blades with M5 blade separately, adenoid blade separately, 120, 60, 0, and also pediatric, and also we have one turbinator blade also for debrider turbinectomy. So we write on the date of the opening when the blade is opened.
All are in the month of June. Hello.
Hello, sir.
In the month of June, most of them.
Yeah. So in the month of June, we have opened this
Yes.
0 straight blade 1.
Yes.
And we will track maximum, he says 5 to 6 patients, but we can prolong it up to 10. So I've put 10. So whenever I reach the 10th usage, I'll discard the blade. This will help in improving the life of the hand motor as well as the debrider console. So we write on which day the blade has been used, 24/6, 26/6, 28/6, 10/7. So this will be useful for everybody to have in OT. This is a small Excel sheet that you can fill up and train your staff, and show the blades here. So I organize my blades separately. So how to track which blade has been opened? As I have spectacles, I had so many spectacle boxes in my home. And my mom and my wife were, why do you have these many? You discard. I thought I'll reuse this like this way. So each blade has its own box.
Yes.
So I've written 0 straight blade number 4. So each box has its own formalin tablets, and each blade will be in the box like this, so it can be used at any time. So whenever they give me from straight blade 4th one, they again have to put it back, and they will write when the date we have been used. So by doing this simple arrangement, I think so we can prolong the life of the blade as well as our saving the console and handpiece, sir. This is a simple thing to track the debrider blade. This is how we are doing. Because once I came back, after joining my dad, we had so many issues with M2 handpiece. And now M2 handpiece has been discontinued by Medtronics. So, but M2 is the best handpiece. Even Satishian sir right now, he wanted M2 instead of M4 or M5. So in order to prolong the life of the handpiece as well as to use more blades, we can do this. Yeah. Thank you.
Manideep.
Sir.
For the benefit of the juniors, how will you clean this one blade?
Sir, first we'll place this in hot water, sir.
Yes.
So the inner tube and outer tube will be little bit warmth, so it will be dilated. Then we will clean it with the stylus. Stylus will be given with the 0 degree, 0 straight blade.
Yes.
So this is the cleaning brush. And we clean it and then wash it, and then we again clean with sterilium and then put it in this formalin chambered spectacle box.
Any oil for the console? Oil
yes,
or
sir.
spray?
Yeah, spray is there, sir. I think so. Medtronic's guy itself sells that.
Yeah.
So even for micro drill also, after every week our people will oil the hand pieces in order to prolong the life of the even micro ear drill also, sir. I have seen an instrument where it's a pressured system which will inject oil into the micro handpiece, but the original brand one is very costly. Earlier some people used to get it from China through Alibaba, but because Alibaba right now Chinese and shipping is problematic, so even I am not able to get that. But manually we can inject the oil into the handpiece and then wait for a few seconds. The oil will lubricate the handpiece.
What is the next case? Can you read the history, or how much time will take for that?
Sir is having some food, I think.
Yeah.
So 5 minutes stops, he'll wash. This is a submandibular gland styloidinitis. It's a small left side level 2A swelling.
No, this is not small. You might might have done the ultrasound or CT.
Yeah, ultrasound, everything.
Yeah, read the
Yeah.
ultrasound
Yes,
report,
sir.
Mr. Mani.
Yes, sir. Yes, sir. Sir, just give me a minute.
Yeah,
This
please.
I'll ask the sister where's the file. Okay.
Hello. Thank you, Dr. Manideep.
Manideep.
The most important point you have given as a take-home message for all the beginners, amateur ENT surgeons. The maintenance of equipment is equally important as of learning of the surgery. Thank you.
Manideep. Hello.
Hello, sir.
With your permission,
Yes, sir. Yes, sir.
I want to give a message to all the postgraduates in the auditorium
Yes, sir.
regarding the salivary gland tumors.
Sir, please,
In
sir.
a matter of one or 2 minutes only.
No issue,
Yeah,
sir.
please.
You did not take my permission, sir.
Yeah,
Please
yeah,
go
yeah,
ahead.
yeah.
PGs will
Yeah.
get benefit, sir. Thank you.
This 80% of the salivary gland tumors are arising from the parotid gland. Point number 1, 80%. Second, 80% is 80% of the salivary gland tumors are benign. Third, 80% is 80% of the benign tumors are pleomorphic adenomas. 1, 2, 3. 380s are over. The 80% of the gland contributed by the superficial lobe of the temporal bone. This fourth 80%. The fifth 80% is 80% of the parotid secretions are coming from the deep parotid lobe. This is fifth 80%. So here there are 5 80s, 80% is. 80% of the salivary gland tumors are from a parotid, 80 from superficial gland, 80% of them are benign, 80% of them are pleomorphic adenomas. The major 80% of the total gland contributed by the superficial lobe, 80% of the secretions are coming from the deep parotid lobe. 6 80s. This is my message to the postgraduates. Don't feel otherwise the senior colleagues. They might be knowing it. Thank you, Mani.
Thank you, sir. Thank you, Dr. Nageshwar.
Thank you.
From Vijay.
We thank you, sir, for educating the PGs. Sir, shall I read the ultrasound report,
Yeah,
sir?
please.
Yeah. A well-defined hypoechoic lesion measuring 2118 into 13 mm, noted in left submandibular region. This is seen abetting arising with exophytic contour from right submandibular gland. On color Doppler, this is showing mild peripheral vascularity. And thyroid is normal. Few subcentimeter lymph nodes are noted along the jugular chain on both sides with normal echo texture. The large one measuring around 7 by 6 millimeters in right upper jugular. So not on the left side. And no other abnormalities noted. Posterior triangle, strap muscles, everything are normal. So impression is well-defined hypoechoic lesion in left submandibular gland region. And we have done FNAC, sir. Moderately cellular smear consisting of small clusters and acinar arrangement of epithelial cells with numerous lymphocytes and polymorphs against a hemorrhagic. So suggestive of chronic non-specific sialadenitis. And the gland is also bimanually palpable.
Is it freely mobile?
Yes, sir, freely mobile. I'll show it.
A small announcement, working lunch is being served, so whoever wants to have a lunch can go and have the lunch. The surgeries won't stop.
Mandeep?
Sir.
Can we go for lunch or the case is going to start now?
Sir, I'll just go outside.
Our
I'm
first
in the
preference
OT.
is case.
I'll give you an update, sir, in 2.
No, sir, Nageshwar, sir.
Yes.
Working lunch will be going on one side and cases will be running on another side, sir.
No.
Independent of that. Both will be running simultaneously, sir. There is a plan. That is scheduled so, sir. ఎవరైతే వెయిట్ చేస్తారు నో గ్యాప్ ఎవరైతే
Thyroid and left AC polyp. Next fisters. One pediatric fist, one adult fist.
నేను చేశాను సార్
If time permits.
2003 సార్ కన్సల్టెంట్ నేను స్టూడెంట్
One, but if time permits.
Mandeep.
Prostatectomy plus T plus.
Hello, theatre.
Prostatectomy plus T plus.
We are arranging the
Hello.
OT
Yeah.
and we will be with you shortly.
Yeah, please.
Dr. Satish is getting ready for the next case.
Sir, what are the other cases, sir, other than this submandibular gland?
I think we have thyroids.
Thyroid.
Sir, one hemithyroidectomy.
Sir.
One debrider adenoidectomy by Satish Jain sir, 60 rad blade technique.
Yes.
And we have one pediatric fist, one AC polyp, and one, if possible, bilateral styloid, and one tympanomastoid, sir. We have planned in DCR is also, DCR is not, we have just sent them home. So these are all the cases. We will show sir as preferred submandibular and thyroid, and then debrider adenoid with then AC polyp, sir.
Yeah.
So we'll show.
He is using
as per,
microscope for the
time permits.
submandibular and thyroid.
We are trying to show you maximum number of cases by sir.
Yeah. He is going to use the microscope for thyroid and.
Are you getting a CT scan image
No, sir.
there
No picture.
on the screen?
No, sir. Yes. But
This is, I am just showing my technique of choanal atresia.
Sir.
And this anybody can do. Any person can do this technique of choanal atresia.
Sir.
Play the video. Close. Close. Are you seeing the sagittal section of?
Yes, sir. Yes, sir. Bony.
Yes.
This one.
Yeah,
atresia.
it's a bony atresia.
Atresia.
You can see. Yes.
Sir. Complete one.
Yeah, complete bony atresia, and there is some amount of adenoid also is there. And వెళ్తా ఉందా? And you can see adenoids and bony atresia of sagittal section, because this is the best view where you can see the choanal atresia baby had, but luckily it's a unilateral, I think.
What is the age of this baby, sir?
This baby is 7 years.
7 years.
7 years, and this is a unilateral.
Unilateral, yeah.
That's why the other side is compensating. I think this. Now you are seeing, I have just perforated the bony plate.
Yes, sir.
And just put the suction, and then I am totally removing. Puncturing the atretic plate is not a big issue, and it will stenose within no time.
Yes, sir.
You have to make in such a way that you have to do a posterior.
Sir, can we puncture the bony, sir? I think it's membranous, so can puncture. But
no,
the bony
membranous you can puncture, but
Yeah.
it is a bony plate.
Yes.
Now I am taking a debrider, you are able to see.
Yes, sir.
And you can see the septum also bending on to the atresia
Yes,
side.
sir.
And we have to see, in my view, both eustachian tubes with a 0 degrees endoscope.
Yes.
That should be the final result of choanal atresia you can achieve. And this is not a, previously atresia was a big surgery.
Yes.
Now we have, and everybody is now doing, and now you are able to see.
Yes,
I am
sir.
going into
Yeah,
the nasopharynx.
yes, sir.
Small adenoid is there.
Yes,
This is not sufficient.
Yes, sir.
Don't stop at this level. Now I am taking a sphenoidal punch forceps and taking slowly the posterior end of the bony septum, and this Carrison's sphenoidal punch you have 2 mm and 3 mm. So once you take
Otherwise, you can use the micro drill also.
yeah. I think yesterday you have seen Gaurav.
Yeah,
We are
yes.
having skull-based drill in Madhumani
Yes.
because we are doing now little skull-based, anterior skull-based. But this is actually, this case was done almost 4-5 years back.
Yes, sir.
And slowly, once this thing, I am not stopping short at this level of posterior septectomy. Still,
Yes,
I
sir.
want to remove more. So I am taking this Carrison sponge again and removing the bone more and more. I'll just fast forward so that time. Now you are able to see some more amount of posterior septum is removed.
Yes, sir.
And what you are able to see, the 4 mm suction cannula is going, and this is the debrider which we are making. Now sometimes we may have to use drill also.
Yes, sir.
To make this uneven bony surfaces of the pterygoid plate and all these things. From the opposite side, I am giving a small incision on the septum so that I should go to the opposite side. And now from the opposite side, I am debriding the septal mucosa and making almost a 1 centimeter wide posterior septum. Now I am removing the upper roof of the nasopharynx, which is also a bit projectile and causing. Now the lower part of the bony septum is also removed, and this is the final drilling. You can see this is Meditronics.
Yes, sir.
Diamond drill. This you can use even for DCR also.
Coarse diamond or coarse diamond?
Yes. It's a guarded drill.
Yes.
You can have a guard and only one surface of this will cut so that it will protect and you are safe. That means the skull base drills are all now you are having stylus from IPC, but it's very costly. Now Marathon got now skull base drill was very cheap, I think 35,000. Now are you able to see how wide I have created? You can see both eustachian tubal orifice openings in a single view with 4 millimeters
Yes, sir.
endoscope.
Yes,
And
sir.
this should be your final result, so that, and this is the result, and I'll show you the post-op. So
Sir,
post-op after
sir,
2 weeks.
Sir, did you keep any spacer, sir? Spacer?
No spacer,
Yeah.
nothing. We have not even kept Merosil also.
Yes, sir.
Because we were sure, and now this is the post-op after 2 weeks, Nageshwar Rao.
Yes, sir. Yes,
So
sir.
it's a mucosilation just comes and beautiful. This is a unilateral. That's
Sir.
why she could survive almost up to 7 years. I do not want to waste your time.
Sir,
because
why don't you use the debrider, sir, in this way?
we have used debrider.
No. This coablator.
I think at that time I did not got the idea of coblation at all.
Yes, sir.
Because bleeding was not much at all.
Yes, sir.
Bleeding was not much because the bony perpendicular plate of ethmoid and vomer in coblation doesn't help. Only the mucosal surface.
For mucosas.
Mucosa you can certainly use. And I just want to show. And this is, I'll just show you. People may think even adenoidectomy. How can you do adenoidectomy under local anesthesia?
Local anesthesia.
So we have invented audio unte audio. Are you able to get the audio there?
No, sir.
Okay, then I'll speak about. Now you are doing under local anesthesia. There is
Now we are getting, sir.
Point of the posterior choana where it meets septum,
Yes, sir.
and through the substance of
The first infiltration to the postnasal branches.
tissue, aspirate
posterior
twice
choanal border.
and
Yeah, the
The same
posterior
way on the
nasal
left
vessels.
infiltrate the medial part of posterior choana.
This is
where it meets
accidentally
septum.
we could
Again,
took the decision.
infiltrate
Yes, sir.
through the adenoid tissue. Now taking 4 mm Zomid micro debrider blade, slowly with low speed remove
all the adenoid tissue bit by bit, taking enough precaution to preserve the eustachian tubal cushion tissue. And slowly after removing the adenoid under endoscopic examination, as under local anesthesia, you have to go up to the prevertebral layer. Here you are able to see again on the left side, from the eustachian tubal cushion, I am debriding all the adenoid tissue totally to give her a good airway and give relief from the snoring. This is only done for adults, not for children. It's just not possible. And a cooperative adult can be done under local anesthesia for removal of adenoid. After the removal of the adenoid, for packing we are using furniture sponge on both sides, 2 pieces, that impregnated in ferracryl solution, which is
Hemlock.
a beautiful hemostyptic. This is the sponge which is sterilized and autoclaved after cleaning. Keep this Indian merosil, which I call, for 5 minutes and remove. Keep for any.
And you will see after 5 minutes.
Yes, sir.
Cauterize or
Sir, what is the cost of the Hemlock's bottle, sir?
I think 100 rupees you get for more than 5 cases. It's a 100 ml.
Area of the
Sir.
nasopharynx, which was 75% blocking from the superior surface of the soft palate to the.
So, a adult, which was an accidental decision taken on the table, and I thought with a spinal needle we could be able to infiltrate and do, and patient also cooperated with a good vasoconstriction you can do. Next.
Yes, sir.
So, just to keep the time, I do not want to make you waste your time. I am just showing my videos which are workshop to be. And this is a Sheshamma. You should be able to see this. It's an extensive sphenoidal pyocele with V2 severe neuralgia,
Yes, sir.
pressing on to the trigeminal nerve.
Sir, you are looking like Hollywood hero, sir.
No.
From Madhumani Nursing Home, Nandyal, Andhra Pradesh. You can see the CT scan, there is not much disease. Only the sphenoidal area, you will see an expanding soft tissue pyocele with pressure on the metal.
See the sphenoid sinus.
Yes, sir.
Causing terrible, intolerable pain on the trigeminal V2 nerve. Now you are going to see the real
sphenoid.
agony of that old woman in her voice.
Amount of suffering.
Yes. Is it pain, sir?
Yes, pain. She is not able to tolerate that pain.
Trigeminal neuralgia.
Trigeminal neuralgia. For
Yes.
this, we have got V2
Yes,
radio frequency ablation by pain therapist first.
Yes.
Then we have taken up for her FES, and now you will see my FES surgery, and
Yes.
last you will see the result.
Radio frequency ablation under anesthetic were the
Just we have punctured, and you see the
Yes, sir.
thick pus coming from the sphenoid.
in the
Yes, sir. Mucopus.
Yeah, mucopus, yes. And now you can see the Playman sphenoidal, and everything is eroded. Now I am doing a middle turbinectomy for want of space.
Yes, sir.
to have
Now
such a
I think you can see the sphenoid done, and you can see the sella turcica above,
Yes, sir.
and both optic nerve, chiasma, and even the trigeminal nerve area.
Yes.
You can see the destruction. I will show you my with a ball probe how much amount of surface. This now I am doing a posterior septectomy. I
Sir.
want to see the both
Yes.
carotid arteries in
Sir, is it
situ.
trigeminal area or this one max
V2
area?
No, no, this is optic nerve, chiasma, sella turcica,
Yes.
and this is keratico-optic recess, and this is totally dehiscent.
Yes.
See, this is totally dehiscent, and this pyocele is pressing this area
Yes, sir.
and causing some pressure on the, and the MRI has given
Yes, sir.
clear report that Meckel's cave
Yes,
is
sir.
getting pressed. That's why
Yes.
first for pain relief, we
Yeah.
got RF ablation,
Yes,
and now you can see the carotid artery, keratico-optic.
Just
this
like
thing-
morning case, sir.
Yeah, very chronic case.
Yes,
And this is how, and you can see how much amount of it going into up to the clivus. This is the
Sir,
pituitary.
can you show with? Oh, it's no. You
This
cannot-
is pituitary. And this is at 82 by 52, and the Dr. Ravi Krishna, and this is this thing, and you should see the post-op result within 2 weeks, and this is after 2 weeks, and you can see the whole
Yes, sir.
skull base in front of you, and she was so relieved, and not even now you can hear her voice.
భరించలేక డబ్ల్యూసీ తరం సార్ దగ్గరికి పోతే హైదరాబాద్కు పంపించినాడు. నాకు ఇక్కడ నుంచి ఏమో చేసినారు, ఆడికి కూడా నొప్పి తగ్గలేదు. నాకు నొప్పి తగ్గకుండా మళ్ళా సార్ దగ్గర పోయినా, మళ్ళా సార్ దగ్గర పోయింటే నంద్యాల మధుమని హాస్పిటల్కు మధుసూదన్ సార్ దగ్గరికి పంపించినాడు. గురువారం నాడు నాకు ఆపరేషన్ చేసినారు. ఎంత రిస్క్ అయినా కానీ కూడా నాకు చేసినాడు. నాకేమో ఇప్పుడు బాగా ఉంది, నాకు ఇప్పుడు బాగా ఉంది, నొప్పి లేదు, బాగా తింటున్నాను, నిద్రపోతున్నాను, బాగున్నాను.
Just a recording of that
Yes, sir.
patient.
Sir, what is the pre-operative treatment, sir?
Pre-operative treatment, RF cautery by Dr. Shiva Prasad.
RF?
Radio frequency ablation from the mandibular condyle under radiological guidance.
Yes, sir.
They have ablated the V2 branch of the trigeminal nerve.
Yes, sir.
So that she got first good relief.
Yes, sir.
And this is done by Shiva Prasad from PGI Chandigarh, anesthetist.
Anesthesia. Yeah.
And you can see how a cobblator extends. This is a papillomatous growth of Mr.
No picture, sir.
The whole larynx in between the vocal cords.
See the
you
amount
can
of
see
polyps?
totally filled
Yes, sir.
with more than
Anything
20
larynx
to
is
30
visualized?
small papillomas.
And this person had done a
Prasad,
tracheostomy.
32 years old man from Nellore district has come, and we have done this very rare procedure. This is Havas Karl Storch laryngoscope suspension. You are exactly seeing the larynx. Now I am taking
This is Meditronics laryngeal
micro debrider, which makes the pathology or the tumor to excise bit by bit. You are seeing the pathology between these two vocal cords, and it's like papillomatosis or papules which you see on the skin. Squamous epithelium in the larynx has the propensity to have papilloma. It is a viral disease, highly infective, but it also has highest rate of recurrence. We have explained to the patient, and now you see this is a beautiful instrument which has about 17 centimeters long and it's about 3 millimeters wide. It has a small bent sharp cutting blade which oscillates, and I am passing in between these two vocal cords. Now you are able to see the cobblator. This is not debrider. This cobblator has irrigation as well as cauterizing with heat. You can see sparkles of light. This also cuts the tissues as well as controls the bleeding. So where there was more bleeding, we have cut and removed the whole papillomatous growths from the larynx. This is not an easy surgery, and you can see I am operating with exterior Zeiss microscope with Storch Spice camera, and I am holding the cobblator or debrider in my left hand and right hand, and suctioning has its own channel, and so delicately operating millimeter by millimeter through the oral cavity. behind the tongue, we pass this Havas suspension laryngoscope and we operate. And the anesthesia was given by doing tracheostomy, and so many instruments, more than 100 instruments are used in this surgery. And you can see now the extensive wide opening of the airway between two vocal cords, giving him a beautiful airway. Tracheostomy anesthesia was given by Dr. Madhavi, and really I should say hats off for this heroic surgery. Now you can see the debrider wand and cobblator wand which we have used, and that's how a extensive laryngeal papilloma case is operated. And to show you in summary, this is before surgery, more than 30 small papules in the larynx, and this is after 4 weeks. His whole vocal cords and larynx is totally free and he is able to breathe nicely. And now this is with me, and we have even closed his tracheostomy and discharged. This is, thank you very much.
Hello. Hello. Hello.
Hello, sir. Hello, sir. Sir, are you calling the auditorium?
Hello.
Hello, sir. Good afternoon.
Good afternoon. Am I audible?
Yes, sir. Audible, sir.
So we are all set for the next case.
Sir.
As you all know, there is a case of submandibular sialoadenitis,
sir,
requiring submandibular gland excision.
Sir.
So I will be demonstrating our steps and techniques of submandibular gland excision.
Sir.
Submandibular gland excision is a very fascinating surgery as it involves preservation of certain critical structures.
Sir.
Neurovascular structures like mandibular branch of the facial nerve, lingual nerve, hypoglossal nerve, facial artery. So you have to deal with many critical structures.
Yes, sir.
So our technique is to do this surgery under microscopic guidance, microscopic visualization for certain regions, which I am going to share with you.
In many hospitals, it's being done by general surgeons.
She's not prepared for today.
If we convince, I think we will be able to.
For anesthesia, fasting.
Fast. What time is your flight?
I have to leave before 6.
You have to.
Still I can do if she is fasting. Hello.
Sir.
So this is left side submandibular gland excision.
Left side.
See, let me orient you first. Are you getting any picture?
It's visible, sir.
Are you getting any picture, sir?
Sir, pardon, sir. Not waiting, sir.
Okay. So submandibular gland excision surgery, as I said, requires preservation of many critical structures. There are many ways to do submandibular gland resection, this removal. A lot of people try endoscopic as well. And you know, endoscope has been pushed or being tried everywhere now.
Sir.
With submandibular gland excision, even we have done endoscopic, but the problem, you know, doing with endoscopic as compared to the open technique has many.
Sir, please stand.
The biggest one The biggest one is the narrow field with lack of control over the facial artery, which is far below and behind the gland if you work from inside the oral cavity.
So open technique is being done by general surgeons. Nowadays, most things are...
What?
the general
Infiltration?
surgeons-
What?
So in many hospitals, these are being done by general surgeons.
General surgeon. To me, this is a, yeah, if they are trained, they can do it, but this is a prerogative of ENT surgeons, what I believe.
And when
As
ENT
you are
surgeons...
more well versed with the anatomy of the neck. See, let me orient you first. This is left side,
Sir.
this is superior, this is inferior. This is anterior, this is posterior.
Sir.
This is right, this is left, you can say. And I am standing here on the left side. Okay?
Sir.
This is the lower border of the mandible. Can you feel? Hello? Are you oriented?
We could. Not feel, sir, we could see it. You feel, we could see.
Hello.
Can
we
you
are able
see?
to feel also, sir. The
Can
way you are
see-
explaining.
Can you see me feeling?
Yeah.
Okay. So that's the lower edge of the mandible. And this is the posterior edge, very important landmark known as gonian.
Yeah.
So, and this is the gland. You can see the bulge of the gland.
Satish,
Yes?
just a few seconds, we are giving memento to Dr. Prasad Reddy, who has come from Medical Council India as an observer.
Oh.
Just one minute. Sir, Prasad Reddy, sir, please come.
Conference is, this workshop is accredited with 4 credit
Four
hours. sir,
credit hours,
by the
Medical Council of India.
So Medical Council has sent an observer. SK Prasad Reddy sir has come as a...
And he is also an ENT surgeon.
forever good like...
Prasad Reddy is also an ENT surgeon.
The Medical
And
Council observer happens to be the ENT surgeon, sir.
Dr. Jafrullah, sir, shawl, Ravi, garland. Mahendra.
Go. Incision with a knife only. Yeah, little beyond the gonia.
Yeah, unnan sir. Right. Sorry for the interruption, Satish. Continue.
No issues, no issues.
Thank you, Dr. Madhu.
Yeah.
Good afternoon, everybody. I congratulate Dr. Masood Anrao and his team for conducting so many free camps for ENT patients, that too under his charitable trust. I congratulate, and the ENT surgical, 14th surgical workshop for postgraduates and consulting practicing doctors, it is a very useful one. So AP Medical Council is encouraging these workshops rather than CMEs. So I think that today 248 delegates were registered. So it is a very good number for our ENT faculty. Thank you, Madhu. And I thank my IMA, my President, IMA State President Dr. Ravi Krishna, local branch President Dr. Jafrullah, and thank you, one and all. Thank you.
Dr. Satish.
Over to theater, please.
Yeah. Am I audible?
Yes, sir. You are audible.
Yeah.
Yes, very
see,
clear.
I have not done anything, but
Okay.
just given an incision,
Yes.
which is roughly 2 finger breadth below the, less than 2 finger breadth below the lower edge of mandible. And what I have gone through, this is skin, subcutaneous tissue and the platysma. See the edge of platysma. Hello? Hello?
Sir.
Can you
It's
hear me?
audible, sir,
Hello.
and
Hello.
good.
Dr. Satish, we are just 1 second. We mementos are going on. Yeah.
A little anterior. This gland is a little anterior. A little a centimeter anterior. And in demo, I take 1 centimeter extra.
Whoa.
No?
Sir.
It is a mandatory to hand over certificates.
Demonstration always 1 centimeter extra.
So it is my privilege that my juniors, Dr. Prabhakar, Mahendra, Ravi Krishna, Madhu, all are juniors. This is a favorite one for me.
Thank you, sir.
You want to sit? Chair is there.
Thank you. Over to the theatre, ma. Please.
Okay.
Hello, Dr. Satish.
Hello?
Yeah, we are with you, sir.
Yes.
Yeah.
So could you see the incision?
Yes,
Yes,
yes.
yes, yes.
So this is less than 2 finger breadth below the lower edge of mandible.
Okay.
Then I cut through the skin, subcutaneous tissue and this platysma.
Yeah.
Yeah. That white fascia.
Is subplatysmal.
Okay, okay.
So the everything has gone up to the level of platysma, cutting through the platysma.
Platysma.
We tend to raise all flaps in the neck deep to
Okay.
platysma because platysma gives strength to the flap and subplatysmal layer is relatively avascular.
Okay.
See now, I am raising my superior flap using a monopolar cautery.
Very good.
Most important thing is hugging the platysma.
Okay.
Just hugging the platysma, not going deep to it at all.
So cutting the platysma and superior to that only, lateral to platysma, and that loose areal or tissue.
Yes. So I am staying, see the platysmal fibers.
Yes, yes, yes.
So this is exactly underneath the platysma. See this? We are not supposed to go too deep to damage the mandibular branch.
Beautiful. The fibers of platysma, very nicely reflected.
Yes.
Hope everybody is appreciating that strands of platysma muscle fibers.
See, that gives strength to the skin flap as well. And see this plane should not be deep to this layer. If you are too deep, not hugging the platysma, you will end up injuring the mandibular branch. See this? Stay suture. Now, my point of interest, there are many ways to protect the mandibular branch of facial nerve.
Yes.
Direct, indirect. We believe in positive identification and preservation. Indirect, many ways you reflect the facial vessels and the nerve is lateral to the vessels. Got my view?
Yes.
So there are many ways. So I am going to show you our technique. Now see, the point which we always emphasize, this posterior edge of the mandible, this is known as gonian.
Okay, okay, okay. That is mandibular margin.
Yes, the posterior edge of this mandibular margin is where I look for my facial nerve. See this facial nerve mandibular branch coming out of the parotid gland.
Okay.
This goes around this gonian. Now the anatomy is variable. It may be within 1 centimeter superior or inferior to the gonian.
These are stay sutures for retraction.
Yes, yes, stay sutures.
Yes.
So we won't use any retractor. Okay. Now looking at the gonian, see this. I look for the nerve. Simplest way. See, this is my gonian.
Yes.
For junior colleagues to identify this facial nerve, I am opening the level of the gonian.
Okay.
Within a centimeter of gonian.
That mandibular edge.
Yeah. That is the plane.
Yes.
Can you see some nerve coming?
Yes.
Can you see the nerve?
Yeah. Yes.
See, so easy to identify.
Satish, Why should we identify facial nerve in a submandibular gland dissection?
Yes, that's a very important question. So, you keep in view
Okay.
so that when you dissect in the vicinity, you don't end up injuring this nerve.
Okay, okay.
You have to leave it above. Your point is right.
Right.
Why we are doing?
Yes.
To stay extra safe, because this nerve sometimes arches too low.
Okay.
And why this runs on the capsule of the submandibular gland. If you have not seen, you don't know where exactly it is running, because the course is many a time so variable.
Yes. Got the point.
Now see my nerve coming.
Yes.
Very clear?
Very clear.
This nerve divides into various divisions and supplies 3 major muscles. Anybody? Yes, one from Vidyasagar, depressor anguli oris. Second, the small part to the orbicularis oris, yes. Third, to the platysma itself, partly. And fourth, to the one of another angular muscle which is known as mantalis. This also supplies. You know why I am asking this?
Yes.
With even if you preserve this nerve 100%, see like this.
Okay.
One may still get a facial, there's effect on the lip, some paresis, some drooping, something, because this supplies the platysma as well. When you cut the platysma, some sort of lip irregularity is going to happen. So always count. If this nerve is paralyzed, the lip will completely go. In spite of the best effort, some patient may appreciate some weakness in the lip, so maybe 5%. So in more demanding patient, you must counsel there will be some effect. Minimal.
And that is because of the vasonervarum is going down?
It gives branches. See the main trunk?
Yes.
Very clear?
Very clear.
See Madhu, why I am identifying this. See my gland is here.
Yes.
I don't want to damage this while dissecting the gland.
Yeah. Yes.
So I will keep it above.
Yes.
That's it. Keep it away. See my nerve is away now.
Yes.
That is the edge of mandible. See here. Okay? Okay?
Okay.
This nerve is going up towards the angle of mouth. We are here below to deal with this gland.
Yes.
Very clear?
Yeah, very clear, sir.
Now the second thing you need to deal with, see this is the gonian here.
Yeah.
The facial vessels
Yeah.
are around 2.5 centimeter anterior to. This is gonian. See this nerve is right at the gonian.
Yes.
Next. है तो सही ना full. Full of adenoid. देखो. See, this point is gonian where my thumb is.
Yes, sir.
And see right there is the nerve. Can you see?
Yes, sir.
For the PGs.
Yes.
This is the easiest way. Make sure you raise the flap just hugging the platysma. Identify gonian and then lift this subcutaneous tissue. And right there you will find the nerve. Okay?
Yes, sir.
Now, from this gonian, around 2.5 centimeter anteriorly are the facial vessels. See the facial artery and nerve.
Yes.
Very important. I have seen people doing some mandibular dissection, sacrificing the facial artery. In non-tumorous condition like this, the facial artery nowadays has become more important with the advent of free flaps. Madhu,
Sir,
Yes.
yeah, we are here, sir.
Yeah, with the
Dr.
advent
Nagesh.
of free flaps, now the facial arteries become very important.
Yes, yes, sir.
So in non-tumorous condition, we tend to preserve it.
Yes.
In tumors, malignancy, no issues. We can cut above
Yes.
and still use it in the same time. But in non-tumorous, we should try our best to preserve this. Now see, I am working at the lower edge of the
Yes, sir.
gland. See this lower edge.
Yes.
Just opening up the lower edge. See, all the time my mandibular branch is in my view.
Yes,
Yes,
sir.
sir.
That's why I dissect it.
Yes, sir. This marginal mandibular is a pure motor nerve, sir.
Yes.
Yeah,
This
if we-
one is pure motor.
If we cut, again, any grafting is needed or not necessary?
There are many ways to deal with that. That's a
Sir.
good question.
Yes, sir.
Sometime it is cut intraoperatively, suppose.
Sir.
You can do many maneuvers.
Sir.
You have to do dynamic reconstruction of the lower lip, angle of lower lip.
Sir.
What you can do, let me dissect this and then I will show you.
Yes.
Digastric. Digastric is a unique muscle where both bellies are supplied by different nerves.
Yes, sir.
The posterior belly is supplied by the nerve to digastric from facial nerve.
Yes, sir.
But the anterior belly is supplied by anybody?
Sir, is it hypoglossal, sir?
Come on. Anybody? Audience,
Sir.
quick.
Anterior
No.
Anterior belly of the digastric.
Is supplied by? I'll give a prize. Anybody? Quick. Don't Google.
Mandibular nerve.
Which branch?
Which branch of the mandibular?
Your prize is still intact.
Third part of the mandibular nerve, sir.
Huh?
Third part.
Third division of the mandibular.
Yeah.
Inferior
Which
alveolar
branch?
nerve.
Still which branch?
Inferior alveolar nerve.
No, wrong. You will give the prize now to whoever wins.
Third part.
Which branch? Come on. Which branch? Specific branch. Nerve to mylohyoid. Nerve to mylohyoid comes from the third division. Through the
Division? I know third division, but I don't know
through the
exact-
inferior alveolar.
Yes.
Then nerve to mylohyoid, and from there is nerve to anterior belly of digastric.
Yes.
So why I am asking, even in the facial palsy, the nerve to my anterior belly of digastric is intact.
Yes.
And you can cut the tendon of digastric and rotate the anterior belly of digastric to suture to the angle of mouth to make it dynamic.
Yes, sir.
What is my point?
Yes, sir.
Other thing is, you can do grafting. This is a tiny nerve, slender nerve. You can take the ansa hypoglossite just behind, arising from the hypoglossal, just deep to digastric.
Yes, sir.
You will see digastric, I'll show you immediately. Deep to digastric is ansa hypoglossite, you can easily identify. Cut the ansa hypoglossite lower down and rotate it and suture to the marginal mandibular branch. That is anastomosis. That's a motor nerve. And that is of same diameter as of mandibular branch.
Sir, such a small nerve, how can you, what is the suture material?
Yeah, 9-0 ethylone.
Yes, sir.
Proline or ethylone 9-0
Yes.
under microscope. So there are many ways to do that, okay?
Sir.
Now coming to the surgery. This is the lower part of the gland. I hope it is visible.
Yes, sir. It's a very visible.
How is the picture?
Fine.
Very, very
Wonderful.
fine, sir.
Okay. Now lateral to this is the facial vein. See that?
Yes, sir.
Yes, yes.
This is going there, I told you. Keep safe. See the facial vein?
Yes, sir.
Yes, sir.
And this is your lower edge of the,
Yes, sir. Can you show the digastric
Yeah.
muscle and tendon?
yeah. Yeah. चलो कर देंगे ज़्यादा पकड़ लिया छोटे. See, I am elevating the gland. इधर से पकड़ना. To show you the digestic lower
Yes.
edge. See
Yes,
this
sir.
digestic?
Yes, sir. Very beautiful, sir.
Very clear?
Yes, sir. Very
This is digestic mop.
Yes, sir. Sir, the medial dissection is easier than the lateral dissection. Can you comment, sir? The medial dissection of the gland.
I don't know, I can't comment.
Sir.
See, this is digestic.
Yes, sir.
Now at this point, this is the facial vein. See the facial vein? See the network of facial vein.
Yes, sir.
Bipolar. There are many unnamed numerous branches. Venous anatomy is always, variable as compared to the arterial anatomy. Not working? Yeah. See, keeping the facial vein away. Could you see?
Yes, sir.
यहाँ से पकड़ाओ. Coming to the posterior edge of this gland.
Sir.
Posterior inferior edge.
No important structure, sir.
ओए हिलाए मत यार. यहाँ retractor लगाएगा. Can you see something?
Sir.
Oh. You have seen the facial vein?
Yes, sir. Again the facial
Yes,
vein,
sir.
sir.
Now will be the artery.
Yeah. This where you have to ligate upper and the other one is lower. Two ligatures, sir.
See the big facial artery?
Yes, sir.
Yes.
Coming from deep to digestic. That's the difference.
Sir.
The vein is lateral to digestic
Yes, sir.
and the artery is deep. How the facial vein is, common facial vein is formed? Anybody? PG? Price?
Any post case? How the common facial vein form?
Fast. Retromandibular vein has two divisions. Anterior and posterior. So anterior division joining the facial vein forms the common facial vein. Now see, this is facial artery. Could you see? Leave it.
Yes.
This is facial vein. This is facial artery.
Yes, sir.
This facial artery is not culprit. Got my point?
Yes, sir.
Need not to be unnecessarily destroyed. Now see, I am deep to the gland.
Yes, sir.
In this plane. See this? In this plane.
Yes, sir.
See there?
Yes, yes, sir. Yes, sir.
This is digestic.
Yeah.
This is in the submandibular fossa.
Yes, sir.
Can you see some now there?
Hypoglossal nerve, sir.
Hypoglossal nerve with
Yes,
lot
sir.
of vena committents.
Yes, sir.
Around. Can you see?
Yes,
sir.
So this is submandibular gland. This is your digestic. This is your hypoglossal. And this muscle is what?
Mylohyoid muscle, sir.
Come on, come on. Hyoglossus.
Hyoglossus.
Hyoglossus. So this muscle is hyoglossus and the facial artery is running over it. See this.
Oh, yeah, yes, sir. Hyoglossus.
What are the structure running deep to hyoglossus? Anybody? Again prize. Name one artery, one nerve.
Lingual nerve.
Yes, lingual?
Nerve.
Come on.
Artery.
Lingual artery.
Sorry, sir. Lingual artery.
Lingual artery
Yes, sir.
is the second branch of the facial,
External carotid artery.
external carotid. Facial is the third one. So lingual artery is given off and it travels deep to hyoglossus and the nerve.
Yes, sir.
Now,
So far. Now above, sir.
huh?
Lingual nerve. Which
No.
nerve? Lingual
Anybody now? Big prize. Come on. Glossopharyngeal, high up, deep to hyoglossus. Glossopharyngeal. Bipolar. See now, this is facial artery.
Yes, sir.
This gives lot of intraglandular branches.
Yeah.
And this big one, this one, can you see?
Yeah.
Hata, hata. Can you see this big branch?
Yes, sir.
Anybody?
Yes, sir. Sir?
Which artery? No, come on. कर इसको अच्छे से कर ले और कर बड़ा पकड़ हेलो
Sir.
Yes, this is submental artery.
Yeah.
इसको पकड़ could you see?
Yes, sir.
That is submental artery, which is a very, very important branch for which flap? Submental flap. Submental flap is a very useful flap for oral cavity reconstruction. You know, if you have a small defect, need lining in the oral cavity, then submental flap can be a good choice. Available in the immediate vicinity. You know?
Yes.
See my artery left behind?
Yes. Yes.
Bipolar. This artery is innocent in this surgery for sialoadenitis. Suction rakhna. Why this is not spared in cancer surgery? Because there are lots of nodes around the facial vessels, vein and artery both, and should not be preserved to leave the nodes behind. You know?
Is it lymph node, sir? Where you are retracting?
This is reactive. See, I am taking my gland away from all this. Away from all means first away from the nerve. See this? See this? Marginal mandibular?
Yes, sir.
Yes, sir.
Yes.
Absolutely intact. Then facial vein. See this?
Yes, sir.
And then facial?
Artery.
All away. These need not to be unnecessarily sacrificed in a benign submandibular gland resection. Okay, done?
Sir, where is the duct, sir?
Yeah, I will come to it. So now we have seen facial artery. Oh, get some another pickup. We have seen mandibular branch. We have seen facial vein, facial artery. Okay. I hope it is very clear.
Yes,
Yes,
sir. Very
yes.
clear.
There should be no confusion.
No, sir.
Yes. Now coming below again. See this.
Yes, sir.
This is your hypoglossal nerve.
Yes, sir.
Yes, sir.
See this one?
Yes, sir.
Yes, sir. Yes, sir.
A lot of vena committents.
Yes.
Yes, yes.
Yeah.
The duct
Now, I will come anterior and show you the mylohyoid. See, at the anterior surface I am coming.
Yes, sir.
Yes. See, now I am coming at the anterior surface.
Yes, sir.
All this superficial tissue I can dissect. See this?
Yes, sir.
Can you see this muscle?
Mylohyoid.
यहाँ लगा हाँ छोड़ दे भाई हिला मत हाँ ऊपर काट नहीं नहीं वो ऊपर हाँ चलो छोड़ एक बार छोड़ो see this muscle mylohyoid
Yes, sir.
see this is digastric and this is mylohyoid see this
Yes, sir.
and this is your hypoglossal now going deep to it
Yes.
see that
Yes. Then the duct between the lingual nerve above and hypoglossal nerve below.
yeah I will show you.
Yes, sir.
So let's focus on the mylohyoid first. See this mylohyoid?
Yes, sir.
See this is mylohyoid?
Yes, sir.
Yes.
Half of the gland what we have dissected was lateral to mylohyoid. See this?
Yes, sir.
Completely alone. Now see, I will retract the mylohyoid. See the mylohyoid?
Yes,
Yes,
sir.
yes.
Can you see some now? Let me show you.
No, sir.
Let me show you. See the now. See this now.
Yeah, yes, sir. Yes, sir. Yes, yes.
Can you see this now?
Yes, sir.
This is coming from above here
Yes, sir.
and going there. Can you see?
Yes,
Yes, sir.
Arching here
Yes, sir.
to give some fibers. See this. See these tiny fibers giving?
Yes.
I hope the picture is good.
Yes,
Yes,
sir.
very good.
See this, let me show you again. Don't get confused, don't get disoriented. I have just retracted mylohyoid here.
Yes, sir.
Okay? Again, reorient. This is your marginal mandibular.
Yes, sir.
This is your facial vein. Below is your facial artery. Okay?
Yes, sir.
And छोड़ना ये छोड़ो.
Mylo-
This is your
Retract
mylohyoid.
mylohyoid.
Okay? Now retracting mylohyoid. See retract. And see this nerve arching.
Loop of the lingual nerve.
Loop of the lingual nerve. Very clear?
Yes, sir.
And this is giving some fibers over here.
Yes.
Postganglionic fibers to this gland. These fibers belong to which nerve? Which cranial nerve these fibers belong to? These fibers belong to which cranial nerve?
Is it hypoglossal, sir?
No. This is lingual nerve.
Yes, sir.
And this is giving postganglionic fibers to the gland.
Submandibular cellular gland.
Postganglionic fibers to the submandibular gland. Let me.
Facial nerve, sir. That.
Yes. See this?
facial- Yes, sir. Facial nerve.
See these fibers?
Yes, sir.
These fibers. So they belong to facial nerve.
They
Through
the
which branch? Through which branch?
Sir, those fibers, they don't rely in the geniculate ganglion and traverses to the geniculate ganglion, they enter into the submandibular gland.
Through which
Those-
nerve?
Sir,
Chorda tympani?
Chorda tympani. See, these are the fibers.
yes, sir.
Yes, sir.
So now we have three structures together. See now below is the hypoglossal nerve. See there?
Yes.
Above is the lingual.
Yes, sir.
And just anteriorly here is the duct.
Duct, yes.
See here. See, this is the duct going. This is the
Yes,
duct.
sir. Yes.
So I have to cut these fibers as well as catch this duct.
Yes, sir.
See this?
Yes, sir.
Yes, yes.
I am bringing them together and clamp this. See these fibers?
Yes, sir.
See the lingual nerve?
Yes, sir.
And the duct.
Yes.
This is lingual nerve fiber, this is duct.
Yes.
sir.
And below is the hypoglossal.
Yes, sir.
Okay.
So I can cut this. Only the duct. And my gland is away. See this?
Yes. Great.
So what I could preserve? What all I could preserve?
You preserved all the structures, sir. You did not sacrifice anything, including facial artery.
Yes. So we could preserve marginal, we could preserve facial vein,
Facial artery,
lingual nerve, hypoglossal nerve,
digastric tendon,
and digastric.
muscle and tendon.
Yes. So now this is our bed. This is lingual nerve. See this?
Yes, sir.
Yes, sir.
This is your hypoglossal nerve,
Yes.
and this is where the duct is ligated.
Yes.
Okay. Now we have ligated the duct.
Yes.
Can this duct develop stones again?
The residual part of the duct, I don't think any secretory elements.
There is sublingual gland.
Can anybody in the audience can develop stones again? Hello?
Sir.
No. Yes or no? After removal of the gland, the source,
Yes, sir.
can this duct, the remaining ligated duct, develop stone again?
No.
Sure?
No.
Sure?
Sir, submandibular duct stones are there now.
Can, after this ligation, after removal of this gland, can this remaining stump of Wharton's duct, after ligation,
Yes, sir.
develop the stones again?
No, sir.
No, sir.
No.
Huh?
No.
It can, sir.
It can.
Because the
Now, how
sublingual
come?
also develops,
The
drains
function.
into that duct.
Huh?
Sublingual also has the
See,
gland.
the master Vidyasagar is here to tell you. See, sublingual gland has many ducts.
Ducts, okay.
And there are ducts of Bartholin
Okay.
which open in the distal part of the Wharton's duct.
Okay.
More than 20.
Okay.
Oh my
Small
God.
ductules open in the Wharton's duct. In spite of the submandibular gland resected and the duct ligated, still because of the saliva flowing through the duct of Bartholin's can give rise to stones again in the distal part of the submandibular duct. Is that clear?
Yes.
So never, why I am asking this, never ever guarantee your patient that I have removed your gland,
And
I have
you
removed
no
the
more
source,
stones.
now the stones cannot develop.
Okay. Very
Got
good
my point?
Right.
Yes.
Yes, sir.
Can your assistant close down? Sripati has adenoidectomy.
Oh, yes.
Then we will come back for thyroid.
Okay. So, just 2 minutes last.
No problem.
So that's the final picture. Can you see?
Yes, sir.
Madhu,
Yes.
this is
Super.
your nerve,
Yes.
entirely intact and preserved.
Super.
This is your vein.
Yes.
Yeah, lymph node I am not disturbing, that is reactive. This is your artery.
Yes.
Only thing I sacrifice is the submental artery,
Submental.
which is the source for submental flap. And this is digastric.
Yes.
Below that is, this is
Yes.
hypoglossal, above is lingual.
Lingual. Super. Very good
And see, in
demonstration.
between them the duct is ligated.
Right.
I hope it is very clear.
Yes, sir.
Now the question here from Dr. Vidyasagar. If your marginal mandibular is accidentally
Cut.
sacrificed, what you can do for the dynamic, reconstruction of the lip?
Okay.
What simply you can do, I told you, this
Yes.
digastric is unique in terms of having two nerve supplies.
Okay.
The posterior division gets supply from the facial nerve, the anterior division from the mandibular nerve.
Mandibular.
Through the inferior alveolar, through now to myeloid and then now to digastric, anterior belly of digastric.
Okay.
So what you can do, in spite of this, the facial nerve paralyzed, what you can do, I will, see, I will cut at the level of the pulley.
Pulley.
Yeah.
Why pulley? This pulley is formed by which muscle? Big price.
Posterior
Yeah.
belly of digastric.
No.
Digastric pulley.
This digastric pulley is formed by which muscle? PGs.
Is it subcutaneous muscle, sir?
No, it's a big, well-defined name, muscle. This digastric is pulley. See, there is a tendon of digastric around
Yes.
which is a pulley which is keeping this below.
Okay.
So this pulley is formed by stylohyoid.
Oh, stylohyoid.
Stylohyoid
Wonderful point, sir.
Wonderful
So-
point.
Wonderful point.
Cut the digastric at the level of the pulley here.
Okay.
Cut this
Yes.
and dissect this completely free till margin of mandible. And this pulley has to be sutured to the modulus at the angle of mouth.
Wow.
Oh my God.
See this, this is angle of mouth modulus.
Yes, sir.
Lateral to that is a modulus here where all the superior, inferior, lateral, all the muscles join. So this pulley is to be sutured to the modulus to give dynamic lip movement,
Lip movement.
which is generated by the through the fifth nerve.
Okay.
Got my point?
Yes.
Yes.
Yeah, this is very effective. Number one. Number two,
Answer hypoglossy grafting.
yes, ANSA hypoglossal grafting. So ANSA is very close here. See, just below the digastric, if I dissect, would be the hypoglossal nerve. And from hypoglossal, the ANSA hypoglossal arises, which goes down along over the lateral surface of the carotid sheath. So cut the ANSA from below, rotate it up and suture to the marginal mandibular branch. The diameter of both is almost same.
Okay.
ANSA is a strong motor nerve, and if you anastomose this, in long run, in couple of months, it gives dynamic movement as well. Yeah, you can do both.
Okay.
So this is how, and in spite of like what I have done, Madhu will tell me in the post-op after 3 weeks, patient may have 5% appreciation of the lip
Mandible.
weakness because
Okay.
you have cut the platysma.
Platysma.
Platysma
Okay.
contributes to the lip movement.
Uh-huh,
So it
uh-huh,
has
okay.
to
Yeah.
be having a little bit of movement effect on the
I
lip
think that will
movement.
recover with the routine
Yeah, it
physiotherapy.
may recover with time, but will have definite impact. So never
Okay.
tell your patient that nothing will happen.
Nothing will have. Okay, okay,
In
understood.
spite of the
understood.
best preservation you can have, minimal
Yes.
weakness.
Yes.
Any questions, sir? Any questions related to this? All vessels.
Excellent demonstration, sir. I'm Dr. Nageswara, sir. For a few more delegates are added now after the lunch break. Can you show the two parts of the ligation of the facial artery?
Two parts of the?
Two, where the two ligations.
Artery where you have ligated at two parts.
Two parts.
Okay. If we
Facial.
ligate, where do we ligate? Huh?
Yeah, where to ligate?
First is when it emerges into the submandibular fossa.
Yes, sir.
Here. See, this is facial artery.
Yes, sir.
This is facial artery.
Sir.
First ligation over here. Second, just at the edge of the mandible, above the gland.
Okay.
But this artery passes through the posterior part of the substance of the gland, from which you can easily separate.
Okay.
There are numerous glandular branches you can bipolarize. One bigger one, the submental artery, you have to bipolarize and sacrifice because submental flap is not very commonly used.
Right.
Not very common. Though I use commonly in my practice for the oral cavity lesion. Like for example, if you resect the lateral margin of tongue lesions, even if you resect the 3 centimeter, 2 centimeter lesion, there is a defect. And you can do a primary closure easily. But if you give a submental artery flap, it works like amazing and the entire tongue contour is preserved.
Sir, if we remove both the submanual glands bilaterally, can it affect the salivary secretions or gerostomia?
It affects a little bit, you know why, but doesn't much. Why?
Sir.
In the active phase,
Sir.
majority of the salivary secretion is through the parotid duct.
Deep lobe.
Parotid gland.
Deep lobe.
80% of the parotid secretion is through the deep lobe.
Yes.
So like while we are eating, in the active phase, majority of the saliva is produced by the parotid. In the resting phase, while sleeping, majority of the saliva is produced by submandibular. So by and large, it doesn't affect.
Yes.
And there are more than 300 minor salivary glands in the oral cavity as well.
Case
So take
is
care of
ready.
that.
Adenoid's case is ready.
Okay?
Yes, sir.
Next case is Satish Jain's technique of adenoidectomy.
Oh, great.
Thank you, sir.
So after that, on this table, we will put thyroid, so that by that time you will see, you have seen almost 5-6 adenoids in these 2 days, and you will see Satish Jain's technique of adenoidectomy with RAD 60 adenoid blade, okay?
And I think cobbler, right. Both. You have seen submandibular meticulous anatomical dissection, okay? Many postgraduates and delegates have postponed this journey. They were actually supposed to leave by after lunch. All are staying, full auditorium.
Yeah, Madhu.
Drain betala. Rubber drain betisal. Hello, Prabhakar.
Yes, please.
History.
Huh.
It's she is I think 11 years old female child.
Okay.
Actually, her mother also got operated in our free camp.
Okay.
She just stays opposite our hospital. She is Bajji, the patient whom you are going to operate, Satish. They live opposite in our hospital on a trolley. Evening they fry snacks and bajjis and bondas. I mean, the way we select the poor patients are... and that girl is having a massive adenoids, Prabhakar.
Okay.
And she's a chubby girl, maybe 11 years of attaining menarche, and she's becoming fatty, plus adenoid hypertrophy, only adenoids, no tonsils. She is having a lot of snoring. And her mother we operated for FES also. And meanwhile, I'll try to show one draft type 3 which we have done in the hospital by the time shifted to the camera. Hope you don't mind, it's a running video.
Yeah.
Are you getting the video?
Yes, draft type 3.
This we did actually 3 months back, draft type 3, Lothrops, underwent surgery 2-3 times earlier, but extensive still discharge. You can see the septum and frontal, see multiple cells and crowding and lot of sinusitis. Looks like hypoplastic and maxillary sinus and everything. And now you are able to see I am debriding.
Yeah.
Left side frontal recess.
Yes.
అక్కడ సార్ వాష్ చేసుకుంటేనే చెప్తే నేను ఇక్కడ స్టాప్ చేసేస్తా. I just want to not to waste your time. Are you able to see the picture there?
Yes.
So left side I am operating and exposing the frontal recess, and actually this is a 12 minutes video. Now are you able to see, you have to see my draft type 3, how I am giving incision. So this is middle turbinate, this is a needle cautery, anterior to the almost 1 centimeter anterior to the middle turbinate on the frontal process of the maxilla or the lateral wall of the nose. I am just giving an incision, going and go up to the roof of the nose, or not skull base, we should not call it, it's roof of the nose.
Anterior.
Turn it down.
Yeah.
Like what Satish told, you can come almost 1.5 centimeter in front. That is called anterior septectomy, so that both frontal sinuses should be visible for you. And we also do this hardly 2-3 cases per year, not that common. Now I am elevating with a septal elevator, ultimately just to identify the first olfactory nerve. And now see the blanket of mucosal fold, just like a Haddad flap. We are elevating down, and now slowly you will see the first olfactory. I am using a cobblator, debrider, all instruments, because draft type 3 takes a lot of time. Now I am removing all the mucosa of the septum, and I think first olfactory fiber has already been gone. And now see the big chunk of septum cartilage I have removed. Now what is there? Horseshoe shape base of the frontal sinus. So I am taking the debrider and making all these uneven surfaces, this thing. Now this is the skull base diamond drill you have to take and almost make this. What you make in front of the horseshoe, like, or Krishna Galley or this thing, you just in the frontal sinus only. You need not worry that I will injure the skull base or something. See, now what is there? Now I am taking a cutting drill. I am removing the interfrontal septum And going, I'll remove, is the theatre ready? Sati, if theatre is ready, then marches. I am just removing the interfrontal systems, drilling the frontal process of maxilla. Otherwise, it will stenose. I am telling you in draft type 3, don't think that you just open the only frontal sinus. You have to drill extensively and and now even drilling the excess mucosal folds also. And I'll fast forward so that you can see the post-operative picture. Now you see the main thing is both frontal sinuses are in between. The interfrontal septum is there that you have to remake, and that is the ready. I am stopped this thing ready to the Satish Jain.
Clearance.
Dr. Madhu sir. Hello, theatre.
We are getting ready for the next case.
Yes,
I think it's going to be an adenoidectomy by Dr. Satish Jain. He is going to demonstrate you with his technique of debrider adenoidectomy along with use of coblator as needed. And the difference is going to be he is going to use the 60-degree blade, unlike the radenoid blade that I myself or Manideep showed you. So you can sit back, relax, enjoy the wonderful art of adenoidectomy by Dr. Satish Jain.
Able to
I'm coming back to draft type 3. There is another 2 minutes delay. Okay? Voice in there.
And the
are you getting voice there?
Yes, sir.
Yeah,
Yes,
usually
I don't know that I was not. Okay.
Dura matter.
Dura matter. You can
And
see the.
We are trying to
Positable
still
dehiscence.
delineate
Dehiscence.
with my septal elevator the whole frontal recess posterior frontal sinus posterior wall on both sides, which is a 2 centimeter square box shaped opening in the sagittal section. Now the left side frontal sinus, interfrontal septum, right side frontal sinus, the frontal beak, and posteriorly you are able to see the starting of skull for minimum of 2 to 3 months with a long-term antibiotic coverage also, because it's a chronic osteomyelitis changes or osteitis of the bone will be there, which needs a good lavage and a mucokinetic mucoregulatory agents like ambroxyl or acetyl frontal polyposis is done.
This is post-op.
Horseshoe, 2 middle turbinates, and in between the septum and cribriform plate will be starting.
Are you able to appreciate the post-op picture?
Very beautiful. Frontal process of maxilla on both sides, both maxillary sinuses.
We will switch to Satish Jain's surgery, okay?
Okay, yes, Madhu.
Now, I do not want to waste even a single minute of this workshop.
Yes, yes.
After adenoidectomy, please go for thyroid, sir.
Next will be thyroid.
Yes, sir.
And after that, a preauricular sinus. He want to show his technique of preauricular sinus. And if time permits, under AC polyp.
Yeah.
Now, Satish Jain sir will show you his dual coblator and debrider adenoidectomy.
Yes.
Over to you, sir.
The position of
Dr.
the
Jain?
patient, head position is in the neutral position, sir.
Yeah.
Neither flexion nor extension.
Yeah.
The regular position.
Regular position.
Yes.
Yeah. So, am I audible?
Yes, sir.
Yes.
Are you getting endoscopic picture?
No, sir.
No. We are getting outside picture. We can also increase the volume of the Dr. Satish Jain's mic.
Patla, back. पतले पतले उसके बना ले गॉज के कॉटन के बना लो पतले कॉटन पैक भी बना लेना पतला ना जल्दी लो इनसे ले ले ईयर वाला जल्दी लेके आओ सेक्शन कहाँ गया वो पतला सेक्शन और कर्व्ड सेक्शन
Dr. Satish Jain's mic volume can be increased.
Hello, sir.
Yeah, now we are able to hear.
Are you getting the picture now?
Yeah. No, still we are getting outside picture. Endo picture, please. Endo picture better. Endoscopic picture. Phone just check. Endoscopic. Audio visual. May we have the endoscopic picture, please?
क्या बहुत मोटा है तो
Yeah, now we are getting endoscopic picture.
Right. Thank you.
Thank you.
Okay, getting the endoscopic
Yes,
picture?
yes.
So, this patient has adenoids, classical symptoms. See, once it comes to adenoidectomy, we need to define the indications as well.
Yeah.
You know, the commonest indication for adenoidectomy in our practice is obstruction. Obstruction.
Yes.
The adenoid obstructs the nasal airway, particularly children, they become mouth breather.
Yeah.
And in the growing children, ultimately, they develop adenoid facies.
Yeah.
This is one of the indications, obstruction. In our
Yes.
practice, we have more indications. Non-obstructive indications are more common than obstructive. Obviously, still the leading is the obstructive indication. But non-obstructive indications are many. Particularly in two groups. Number one, as I mentioned in the morning, for pediatric CRS patients, not responding to the adequate medical treatment. When it comes to surgery, the first line surgical treatment is adenoidectomy, as the adenoid becomes the source of biofilms which propagate infection to the sinuses. And adenoidectomy solves the problem in many of these children.
But majority of them, they land with pediatricians, sir.
Yeah. So,
That's where these CRS and adenoids patients
yeah.
getting suggestions, and that's the problem.
Yes, you are right. So, Madhu's version is majority of these patients do not come to ENTs earlier. They keep following the pediatricians. This is right.
Sir.
You know, Madhu, on this fact, let me tell you.
Sir.
Whatever number of CRS patients, what we are seeing in our practice, ENTs, what ENTs are seeing are less than 10%.
10%, that's what.
This is so funny. Majority of the CRS patients are being treated by the GPs. General physicians, because the symptomatology is overlapping.
Yes.
They present with nasal blockage, some
Cough,
cough, post-nasal drip,
Yes.
some facial headache, some sneezing, associated allergy. And pediatrician have a single treatment for all: antibiotic, steroid, nasal drops, painkiller. Steroid is the mainstay for them, GPs. And the patient become all right in couple of days. They again develop symptoms, they again go to GP. That's how they linger on for years and years together until it becomes unbearable, so frequent, and develop complications. That's why we get many patients after such a big disease.
Yes, sir.
More than 90% of the patients are still lying with a pediatrician and general physician. And the irony over that is, see, what CRS is this? This is asthma of upper airway.
Asthma of upper
This
airway.
is purely asthma of upper airway. The true asthma that belongs to the lower airway has the same inflammatory mediators which are working.
Yes.
Same eosinophilic activity, same cytokines are involved. So, long-standing upper way disease, CRS, ultimately leads to asthma in majority of the patients, in long run. And the irony is that then those patients are following with a pulmonologist.
Yes, pulmonologists and
So in their lifetime, they never come to ENT.
process max.
There is lack of coordination among specialties.
Yes.
In their lifetime, they don't come to ENTs.
Yes.
See, such an interesting thing. Earlier, they keep following with the GPs and physicians.
Yes.
Don't get adequate treatment, appropriate treatment, don't get appropriate diagnosis.
Diagnosis.
Ultimately develop asthma and then finally follow judiciously the treatment of asthma with a pulmonologist lifetime.
Lifetime.
Now, if you follow the studies, majority of the patients lying with a pulmonologist with asthma, if you scan their sinuses, majority have CRS.
CRS, yes.
And if you treat their CRS with sinus surgery and proper, post-operative adequate topical steroid douching, their asthma improve like anything.
100%.
The need of the asthma treatment is reduced by 90%.
90%.
But unfortunately, no pulmonologist will refer to ENT.
Yes.
Because it's a lifetime patient. Lack of coordination. So it is so pity, 90% and over, more than that, true CRS patients are never lying with the ENT surgeons. What we are treating is less than 10%.
Sir,
the magnitude of CRS problem is so big.
Sir, why the allergic rhinitis and asthma are coexistence? Why the allergic rhinitis and bronchial asthma coexist in one patient?
Both are same inflammatory.
The same inflammatory mediators.
Yes.
Same eosinophil, IgE mediated mechanism, same cytokines are involved. Once they involve the upper airway, if left untreated, inadequately treated, happen to involve the lower airway. And now, more than that, the new specialty, allergic specialists have come in.
Yes.
They will keep on giving steroid, immunotherapy, this, that, but that never be able to reach to the correct diagnosis. So less than 10%, I am giving a huge figure, probably less than 5% are actually being treated correctly by ENT surgeons. So call is for the coordination among specialties to tell them the philosophy of treatment. We must go to the pulmonology conferences and present your work and bring this fact in front of pulmonologists. Make the team with the pulmonologists. Pulmonologists will keep on adding steroids in their, inhalers, oral steroids in between, so many other biologic therapy and all that, but never look at the sinuses. This is what need to be, the need of the time which should be done.
Or we may have to conduct some free camps to educate all this, sir, for the suffering patients.
Sir, we have given precise max.
Yes. Right. So, in this patient, I told you the indications. The non-obstructive indications are many, adenoid, pediatric, and third is the patients who are developing recurrent otitis media. In second group of pediatric adenoid patients, the problem is non-obstructive. Adenoids are not obstructing the airway, but yet they are source of biofilms, giving pediatric CRS again and again. Third is non-obstructive indication, again patient developing recurrent ear infection, sinuses clear, adenoids not obstructing, yet adenoids is the source of problem for the inflammatory mediators, for the infection biofilms affecting the eustachian tube. In those patients, if correctly diagnosed, adenoidectomy definitely helps them. So indication has to be reassessed and implemented in the practice correctly. Number two, here coming to the surgical technique of, adenoidectomy. What exactly the adenoids are? Adenoid is not a tumor. This is just a lymphoid tissue which gets hypertrophied in response to repeated allergy and infection. And majority of these children are either having allergic rhinitis, associated allergy, or immunocompromised giving repeated infections. These two underlying causes, if are not assessed and treated further, it can come back. It's a tumor. It's not a tumor. It cannot come back being a benign disease if removed comprehensively and followed by comprehensive treatment of allergy and immunity. So that's a comprehensive treatment required for adenoid. Not like mechanically you remove the adenoid and tell your patient you are all right. They will keep coming to you with the same problem. Sometimes, in spite of adenoid removed, they will come to you, doctor, I have the same problem, my child has the same problem. Still he has sneezing, he still has intermittent nasal blockage. I think the adenoids have recurred. It's not adenoid recurred. Your treatment is inadequate. You have not followed with the treatment of allergy and immunity. There must be immunocompromise, developing repeated infection, allergy, which requires a long-term dedicated treatment. Secondly, coming to the adenoid treatment. Since it is a lymphoid tissue which responds to allergy and infection, it can regrow. So our goal is to remove them comprehensively. Got my point?
Yeah.
Thoroughly, so that they do not come back.
Yeah.
So here I am going to show you our technique. The technique involves removal of the adenoids, at the same time preservation of all surrounding structure. Surrounding means there are a lot of things surrounding the adenoids. The Eustachian tube on either side, soft palate below. See the adenoid, I am just applying an adrenaline pack. See this? From the oral cavity side, see this? Hello? Yes. See this adrenaline pack on the surface. Then beside the Eustachian tube and palate, there is the musculature behind, nasopharyngeal musculature.
Sir.
That
Okay.
need not
Yeah.
be damaged.
Yes.
Our goal is just to remove the adenoids, that's it. Preserving everything. At the same time, comprehensively removing the entire adenoid, the chances of hypertrophic and infection should be avoided. Repeated hypertrophy should be avoided. See this purulent discharge coming from the maxillary sinus. Very
Yes.
commonly you will find these children having associated maxillary sinusitis. If you have a slightest doubt, you can do a middle meatal antrostomy. Not really. Balloon sinuplasty is never an answer to sinusitis, never an answer. Yes, it has a small space in pediatric population because it is highly atraumatic. Because pediatric patients are never going to cooperate with douching and all that, removal, crust removal and all that. So balloon sinuplasty, presently the indications are squeezed to certain levels, like in pediatric patient, immunocompromised patient. HIV patient, you don't want to do an extensive surgery, you can dilate with a balloon and drain the sinus, that's it. Post-operatively, you have done a good job, your frontal sinus stenos, you can put a balloon and dilate, something like that. But, yeah, for frontal and maxillary, any dependent sinus. See now.
Yes.
So my goal is to remove the adenoids and preserving the tissues all around. So I will accomplish this in 3 stages, 3 phases. My first phase involves gross removal quickly. The advantage of this technique is this involves little bit of the bleeding because I am going to use the microdebrider for adenoid removal. The advantage is I will not damage the surrounding muscle and anything. If I use the coblation to remove this and try to go into the plane, it involves unnecessarily charring of the underlying muscle. Inevitable. So that this debrider prevents inevitable charring of the underlying muscle, yet involve little bit of the oozing, which we will control the way I will tell you. See now, my first phase involves all these adenoid gross removal in no time, quickly, in less than a minute, so as to minimize the bleeding Cross removal. See this? Quick. This is not adenoid blade. This is the rate 60 sinus blade through the oral cavity and 0-degree wide angle telescope through the nasal cavity after little bit of the decongestion and space. करना सर करना सक्षम नीचे करना सक्षम डायरेक्शन गलत है सक्षम ब्लेड ब्लॉक कम ऑन क्या दिया ब्लेड see this the blade got clogged. That should not have happened. See this on the other side?
Yes.
With this little bit of the oozing, find out. I'm not massive bleeding. Yeah, good decongestion. Irrigation डाल नहीं रहा पानी सारा.
Irrigation is from outside.
See, this is gross removal.
Yeah.
And this opens up the airway.
Yes.
Okay?
Yes.
And most of the people end up here considering this as sufficient. See this?
Yes.
Now, I will, at this stage, at this stage, I will pack with the same adrenaline gauze for a minute. Look there. Just for topical decongestion. See this?
Yes.
This is after first phase.
So is it pure saline or any fracture?
Saline with adrenaline.
Saline with adrenaline.
Yeah, topical.
Topical.
Pardon? No, I will do something for that. I will show you. That's a very important question. I will tell you where the bleeding is coming from and how it will stop. That's a very, very important point. That's why we use this technique. See, this is just an application for a couple of seconds. That's it. See, it may take little time, but this is a comprehensive adenoidectomy. You don't have to look back again in life. With least chance of complications. Find out. No, wash. पानी देना यार, तो कुछ assist नहीं करा रहा. पकड़ इसको. See this? This is after first phase. See, there would be little bit.
Yeah.
Like this.
Is it plain saline, sir, or warm water? 37 degrees.
Plain saline.
Plain saline.
It looks like we have removed the adenoid.
Yes.
But I'll show you how much of the adenoids are left behind. Still a lot of adenoids are left behind. And those are the source of problems. We have done more than 10,000 cases. Our team, everybody is doing the same technique, following the same. Yes. See, this is after first phase. One is it? Section. This is after first phase, okay?
Yes.
Now give me. Our second phase involves complete adenoid removal in the midline. See this?
Yes.
How to get into the adenoid plane. Why I was not using the collator. These adenoids are sitting on the muscle behind.
Yes.
And there is a fascia covering that muscle.
Yes.
I don't want to leave any adenoid tissue if I scrap completely off the fascia of the muscle
Yes.
without damaging the muscle and fascia.
Yeah.
If I try to remove this adenoid completely
Yeah.
with the cobblator, that will inevitably char the muscle and fascia.
Yeah.
But see now,
Yes.
you see this oropharyngeal mucosa?
Yeah.
Now see, tangentially using this blade, same
Yes.
blade, see how much are the adenoids left behind.
Yeah.
Madhu, look at this. How much are the adenoids left behind? Yeah. Right now I am removing in the midline.
Yes.
Niche kar. Yeah. That's what I will come to when I come to lateral one. Here now, see I am using it tangentially by the same blade. The blunt face of the adenoid blade is facing behind. Yes. See, I am into the plane section. नीचे
Yeah.
करना.
Here above the plane.
वहाँ करने बिल्कुल नीचे साथ साथ. देखो कुछ नहीं कर रहा यार. कर रहा है. घुमा. अब डाल पानी. See this. I am scraping off the fascia.
Yes.
पानी डालता रहे आगे पीछे. No. See this?
Yes.
पानी डाल दो मैं फेशिया चुकाऊं. तू तो बोलना किसी को. बस करा. संदीप पानी डालना यार. इसको भर के दे यार. Yes. See this, the perimysium behind?
Yes.
That is my goal.
Yeah.
Hire yaar.
Without injuring perimysium, you are.
Yeah, that is important.
Yes.
Yeah, a very important question. I will come to it. What are the complications which can happen in adenoidectomy? And why? Yeah. See this fascia. Now, as I go up, see this. There is a change. Here is. Sandeep, तेरे को क्या कहा था? What are you doing, Sandeep, यार? Sandeep. See, below is the muscle. See this mobile tissue.
Yes.
इनसे हाथ से ले ले पानी. And above this is immobile tissue. See that there is no muscle above.
Yeah.
Above is basio-occiput. There is no muscle.
Yeah.
So here I am going to strongly combing off. पानी डालो ऊपर से संदीप. 50 बार बोलने के बाद भी संदीप. तू इस पे डाल, इस पे यार. Come on, don't be. सक्शन करते रहो. नहीं कर रहा. See this? I am combing off.
Yeah, combing off.
This is
Yeah.
hard combing because there is no muscle tissue there.
Okay.
Pull और का नहीं करना. See, this is all irrigation going on.
Yes.
This is hard combing.
Okay.
Combing, हाँ. Not really. See, 0 degree will show you everything where we want. See, now I have come to the superior edge.
Yes.
See this, the lower down is the fascia. पानी डाल इस पे. Lower down is the fascia,
Yes.
all intact.
Yeah.
And upper one was the basic occipit, the debrider not working. What happened? See, the debrider stopped, so I stopped. Hello?
Yes.
Right there. इसको ऊंचा कर, इसको ऊंचा कर. Suction कर. So I am packing for a while, just for a minute. This is after second phase. Second phase means I remove the adenoid in plane in the central part in the perimycial plane.
Yes.
When I remove the pack, I will show you. Because the irrigation was not continuous, so you may not have seen properly. पानी इकट्ठा कर लो, मैं नहीं कर रहा. Give them one more syringe, please. जब ये हटाऊं मुझे सिरिंज चाहिए होती है. Hello?
Hello, yes.
Yes,
Ye-
I'm removing the pack to show you what
Yes,
has
yes.
been done in the second phase.
Yeah.
ये जरूर है. Telescope पे डाल. See this.
Yeah. Sir, how do you control this small capillary oozing?
Yeah, I will show you that. So I have not used the coagulator yet.
Yeah.
See my perimycial plane
Yes.
and above that combing,
Yeah.
hard combing. Could you see that?
Yes.
These are two different areas where the adenoids are attached to.
Yeah.
The lower surface is on the perimycium. Upper surface is on the basi-occiput
Basic occiput.
with no muscle intervening.
Yes.
Where the perimycium is, why I didn't use the coagulator, I didn't want to damage or char the perimycium and the underlying muscle. If you try to remove in this plane with a coagulator, you will inevitably char the perimycium muscle, and which is not our target.
Yeah.
Our target is only adenoid
Adenoid
removal.
tissue.
So now in a minute I will show you what we have achieved and what is the, like Madhusudan asked, the source of bleeding post-operatively. That is very, very important to know. पानी दे और एक पैक. One down. One down. See this surface?
Yes.
How is the picture there now? Madhu, look at the picture. See
Very
the
clear,
source
sir.
of bleeding?
Yes.
Very clear picture.
Very clear, sir.
Coagulator. Pedal. Now let me show you with the coagulator. Come karo pani. See, this is one bleeder here.
Yes. Is it the basic occiput area?
Basic occiput area. What I am trying to show is the key
Yeah.
behind doing all this. I will show. This is ProSize Max. See, Madhu, when you preserve this perimycium, see this? No adenoid on the perimycium now?
Yes. Very clear.
Very clear?
Yes.
And the perimycium is pretty intact.
Yeah.
If your perimysium is intact, there cannot be bleeding from there. Because bleeding is from underlying muscle.
Yes.
The adenoid bleeding comes from two sources. One is from the periosteum above,
Yeah.
this area,
Yes.
and below is from the muscle. So if you preserve the perimysium and automatically muscle, there cannot be any bleeding from below, number one.
Yes.
Impossible. This fascia is never going to bleed. What's my point?
Yes.
Bleeding is through the muscles. Now, secondly, so the lower source of bleeding is over by preserving the perimysium.
Yeah.
The upper source of bleeding is always there. Almost all post-adenoidectomy hemorrhages are from above. Because here is the periosteum, it is not muscle, it doesn't contract to stop the bleeder. And since there is no adenoid, no muscle below, we do carpet coagulation of this. Only upper part,
Yeah.
no muscle.
Yes.
See this.
So you are doing only diathermy.
This is coagulation with the coabulator.
Acha, it is a
Coabulator is very safe because it is always irrigated. The collateral damage is very less.
Yeah. Coagulation with the coabulator.
Yes, see this. This is carpet coagulation. Why
Yeah.
carpet coagulation?
Yes.
Because this is always the source of bleeding.
Yes.
Now see after carpet coagulation below.
Yes.
Below the perimysium is intact.
Yeah.
So what we have achieved practically in the center, there are no adenoids.
Yes.
See this?
Yeah.
We have reached to the limits.
Yes.
The perimysium and the Bezier-oxybate, which is coagulated now,
Yes.
the periosteum, because periosteum is resilient, it doesn't contract.
Yeah.
So we have done a carpet coagulation prophylactically.
Yes.
What's my point?
Yes.
Walder's ring has many parts. It is not the adenoids only. Walder's ring has palatine tonsil. Walder's ring has lingual tonsil. Walder's ring has nasopharyngeal tonsils. Walder's ring has tubal tonsil. Many parts. You know. See this.
Yes.
This is what carpet coagulation I have done. But only above. Not in the muscle region. See the muscle below?
Yes.
Yes.
Completely removed.
Yes.
Look at the picture, Madhu. Look at the picture. No adenoids at all in the center.
Yes.
But this doesn't mean my adenoidectomy is over. See this, the final picture after second phase. The idea what we have achieved the adenoid removal in the plane. Plane is
Yes.
perimysium. That gives us a feeling of complete removal, number one. Number two, it is without using the coabulator, using the microdebrider, we have never charged the perimysium and the underlying muscle. This is absolutely intact. What Madhu was saying, the complications of adenoidectomy. You know, the biggest unnoticed complications come when this nasopharyngeal musculature is charged. That can lead to nasal twang, cicatrization, nasopharyngeal stenosis, fibrosis, all these only when muscles are damaged. Here, we have preserved the perimysium. See this?
Yes.
The muscle is automatically underlying muscle is automatically protected.
Yes.
Only charge is above where there is no muscle.
Yeah.
And why we have prophylactically charged? Because this is the source of post-operative bleeding.
Yes.
Bleeding cannot happen from the perimysium.
Yes.
When perimysium is intact, all the vessels are underneath.
Yeah.
What's my point?
Yes, sir.
Now the third phase of this surgery is laterally hypertrophic adenoids, which are almost always, left behind and become the source of recurrent ear problem in spite of adenoidectomy. Many a time you will find patient, you have done adenoid surgery very well. Patient again coming with the ear problem, otitis media. Recurrent secretory otitis media, the same toxin inflammatory mediators are still there and giving inflammation in the eustachian tube. So now, laterally hypertrophic tonsil have to be addressed, adenoids. And here the Madhu's question was the vessels. Everybody has a fear of damaging carotid artery. See, this muscle behind is a longissimus capitis muscle. Very thick muscle, what you are seeing behind. Section. See this?
Yes.
This is longissimus capitis muscle.
Yeah.
Very thick muscle.
Yes.
Almost a centimeter thick. Laterally, besides this, there is another muscle, rectus capitis anterior. Behind is the fossa Rosenmuller. And this muscle and rectus capitis anterior constitutes thick muscular pad anterior to the carotid artery.
Okay.
And there is a thick periosteum over the carotid artery there. Thick periosteum before it enters the temporal bone. Number 2, the carotids coming in the medial part in the nasopharynx is very, very uncommon. If it is, you will find our pulsatile pulsation, transmitted pulsation. Very, very rare. Why? It is very common in tonsils. It is commonly seen loops or kinking in the lower parapharyngeal part. At the site of tonsil, the carotid sometimes, because of the loops or kinking or whatever, it is very close. But above that, above the tonsil level, it has to enter into the carotid foramina in the temporal bone. And before entering the carotid foramina, it straightens up. And that is where the adenoid is. So you will never ever see kinking loop in the nasopharyngeal segment. Before coming to the adenoid level, it straightens up to enter the carotid foramen. So don't worry about that. Okay. Thick musculature, thick periosteum, and more than that, we will do whatever we do laterally, we'll be doing under vision. So how to do under vision? Because these hypertrophic adenoids are potential source of problem, not uncommon. And see how you can safely remove them. See this, see the same blade I am using. See the adenoid behind the Eustachian tube? Can you see?
Yes.
Yeah. Your cutting edges of the, now see what I am doing, I am pressing on the muscle behind. See the muscle?
Yeah.
And allow, I can't give pedal. Yeah, find out. Pressing on the muscle and allowing the adenoid to fall into the blade.
Yeah.
See this? All soft adenoid only will jump. See the amount of adenoid. See the amount of adenoid.
Yeah.
Keep your cutting edges under view. See this? The lateral muscle coming in picture. Technique here. See this? Empty fossa Rosenmuller now.
Yes.
Because only the soft adenoids will jump, muscle will not jump. See now?
Yes.
There is nothing, no adenoid there beyond. There would be little bit of the oozing, for which I will take care with a small pack and come out. Not really. See, what I am showing is under vision. You have to keep your adenoid, cutting blade edges under vision. See this in the plane. Yeah, and whatever tissue is jumping in the blade is soft only. Only adenoid. Muscle, vessel, anything cannot jump. Got my point? Yes, there can be a source of persistent problems. We get many a time patients after adenoidectomy, the same problem with ear issues. See, my eustachian tube is anterior, never ever damage the eustachian tube. Just leave for a while. That's it. We'll come back. Now coming to the opposite side. Yeah. No worries. Believe me, I am going laterally doesn't mean that I am going to damage anything or anybody. If you are doing under vision. Once you clear the adenoid, the feeling will be different. This is your eustachian tube orifice?
Yes.
And see the massive adenoids behind that. See the massive adenoids behind that.
Yes.
The same tissue which you removed in the midline. Don't use anything forcefully.
Yes.
See all the tissue is jumping into it.
Yeah.
I fail to understand why they do this. Can you see the fossa of Rosenmuller?
Yes.
See, my blade is empty, means nothing is falling out into it.
Yeah.
Under vision.
Yeah.
And I can see the lateral muscle there. This little bit of the oozing, I will pack for a while and go to the other side. And this will solve the issue. This is complete adenoidectomy. I'll show you final picture afterwards. Just for a minute. What is your bag? Bag is too big. छोड़ हटा दो Hello? Hello?
Yes, sir. We are with you.
Yeah. So now we are going to show you the final picture soon. One by one I am removing the pack from both sides.
Yeah.
That is fossa of Rosenmuller on the left side. रुक जाओ.
Are they plain packs, sir, or soaked in adrenaline?
Pardon?
Which the packs we are using, are the plain packs, ribbon gauze, or soaked in adrenaline?
Yeah, soaked in adrenaline also. So one side pack I have removed. Will show you. See this. That is the surface. The coagulator. Yeah. So that is to ensure that no adenoid tissue is left behind. Now at this point you can do.
Yeah.
If you want to, if you find anywhere needed coagulation. See this?
Yes.
Smooth surface.
Yeah.
See smooth.
Yes.
Entire, this is fossa Rosenmuller per se. If everybody, see this fossa Rosenmuller?
Yes.
Yes.
Yes, sir.
I am far lateral, Madhu, see?
Yes.
Yes.
In the depth of fossa Rosenmuller, all muscle intact.
Yes.
Yeah.
Yes. Yeah. Yes. It's very clear.
Fossa is max has a wide surface area. Has a good suction. It doesn't get easily clogged. Yeah. So see, that side is okay. Now I will remove the pack from this side. Now I will finally remove the pack from this side. Suction होता है यार. This side pack I have removed, and then final hemostasis on this side. See, comprehensive adenoidectomy.
Yes.
You don't have to look back for the adenoids in life. That's the goal.
Yes.
And always follow with the treatment of allergy and immunity. When you have a cobbleter, need not to worry about any bleeding or any issues. The role of cobbleter by and large is not in adenoid removal.
Yeah.
Yeah, sometimes you need a 30-degree also. How is the picture there?
Yes.
Picture is very clear, sir.
Wash.
Yeah, almost is very clear, sir. Now we achieved hemostasis.
Yeah, we'll work for hemostasis for 2-3 minutes, 5 minutes. Dhani nahi hai that. Like the small pack. बंद करो हटो हटो one more small pack before I do the survey everywhere. लगा Honey? Honey? See, lot of irrigation is required.
Yes.
Irrigation accelerates the coagulation cascade.
Yeah.
Yeah, this is normal. Warm saline irrigation is required.
Yes.
In bony venous channels. Not here. Like if I am drilling the clivus, drilling the sphenoid bone.
Okay.
Then you need warm saline irrigation.
Okay.
For soft tissues, not needed.
Okay.
See the picture.
Yeah, very clear, sir.
Both sides, fossa Rosenmuller, the midline,
Yeah.
the above where the periosteum is completely coagulated. The lower perimysium surface is absolutely intact. See, both sides, fossa Rosenmuller.
Yes.
This is comprehensive adenoidectomy. We'll irrigate for 5 minutes. To see if any oozer. See this?
Yeah, very clear, sir.
Still will see the fossa Rosenmuller laterally.
Yes.
Eustachian tube intact.
Yeah.
What we have achieved, I told you in the beginning, our goal is only adenoid removal.
Yes.
See both the Eustachian tube orifices, Eustachian tube absolutely intact. Perimysium and the muscle underneath, that is most important. The whole exercise with the coagulator, the debrider was done to prevent perimysium and the muscle charring. See, if this muscle is injured, coagulated, I have seen patients developing retropharyngeal abscess, torticollis, all that. So all those series of complications will happen if the perimysium is breached,
Injured.
if the muscle is injured.
Yes.
See this entire field, panoramic view.
Yes, sir. Very clear.
This is all perimysial surface, absolutely intact.
Can you have a big applaud for the excellent demonstration? Dr. Satish, there is a very big applaud for excellent demonstration. Really, it's we got a very good hemostasis and perimysium is intact.
If you still want to be doubly safe in the post-op period, you can put a small piece of Surgicel in the lateral recesses.
Oh, Surgicel.
If you want to.
Yeah.
Not needed. See, for last 5-10 minutes I have been watching.
Where do you put, sir, Surgicel?
Pardon?
Surgicel you put in the fossa of Rosenmuller?
Fossa you can keep.
Sir, what is the post-operative care?
Nothing, just some saline sprays, nothing else.
Saline spray. Next day you discharge it, we wish. No. No, no.
Wash. See, such patient cannot come back with adenoid issues again in life. All post-operative complication of bleeding happens to occur from above.
Yes.
From there which we have coagulated. All post-operative infection issues come when the muscle is charred or coagulated.
Yeah.
So no question of infection also.
Yes.
No question of nasopharyngeal stenosis because the muscle is untouched.
Yes.
So many angles it has for justification of doing with a microdebrider, not using the coagulator for that.
Yeah.
Coagulator is an amazing tool at the end of the surgery to coagulate the areas with minimal collateral damage. See that? That's all about this case.
Yeah.
See the panoramic view.
Yes, very excellent, sir.
Thank you.
Madhu, next case is thyroid. Huh?
I don't know. Yeah? Yes, yes, yes.
Prabhakar,
Yeah, Madhu.
are you able to hear me?
Yes, please.
Yeah. Next case will be thyroid.
Okay.
Before that, we will take just 5 minutes because sir has to again scrub again.
Okay, okay.
Meanwhile, we will show you a frontal trephination.
Okay, okay.
Hope everybody had your lunch.
Yeah, excellent lunch.
Now, are you getting my endoscopic picture of recorded video?
No, no, not yet.
Okay, right.
Now you got.
Right.
1 second.
This is on the left frontal sinus exploration. Already all amount of the frontal exploration done. You can see 3-4 hanging pit-like deficiencies. Now I am searching with a ball probe where could be the frontal recess exploration, because this patient is having a severe headache and left frontal sinus is totally opaque. Understand? I was thinking, okay, this must be the area of frontal sinus drainage.
Yes.
Yeah, so I just put my curved suction. Now I am putting a ball probe. Yes, it is going.
Yes.
So most probably this is a frontal recess drainage.
Yeah.
And I thought, yes, this is the frontal opening. I am very happy. But once I opened the mucosa, it is actually I am doing something not a frontal sinus.
Yeah.
And I am editing now. You are able to see I just
Yes.
given an incision
Yes.
at the medial end of the eyebrow
Yeah.
and did a trephination with a Meditronics burr
Yeah.
and put a wide bore 12 number needle.
Yeah.
And I am putting a 10 cc betadine syringe with solution.
Yeah.
And now again I am checking, yes, that should be this thing. But to my surprise,
It came behind.
it is coming almost to above the lamina papyracea.
Yeah.
That means in such situations you need not worry. Best is frontal trephination.
Yeah.
It is a simple, safe, secure, stable and sure procedure. And
Yeah.
you can see how nicely the twist, but it is sandwiched. See,
Yeah.
once I stopped irrigation,
Yeah,
the
collapsed.
drainage got collapsed.
Yeah.
Now this will not be sufficient. It will again close with fibrosis.
Yes.
Now I have to make it 360 degrees wide. So with the 24 carats gold mucous membrane, I am totally elevating the mucosal flap. Now even I am taking a curved, upturned fess scissors
Yes.
and cutting like a tympanomeatal flap.
Releasing incision.
Releasing incision so that it should not come into the center and it should be almost at least 5
Falls
millimeters. Hardly it was a
Yeah.
pinhole drainage frontal sinus. Now after
Yeah.
doing this, it got widened.
Yes.
So this is the frontal trephination for a frontal sinus.
Madhu,
Thank
do
you.
do you keep any Merosil or any?
No, nothing. You should not keep.
Okay.
Test paste. Triamcinolone paste.
So, Madhu sir, 1 minute, sir. Hello.
Hello.
I request Dr. Ravi Babu, sir, please come on to the dais and give mementos to our chairpersons. As Dr. Singh, sir, please come on to the dais and give mementos to our chairpersons. As Dr. Singh, SVD Prakash, sir, and give mementos to our chairpersons. Okay. As Dr. Singh, SVD Prakash. So I call Dr. Tejashwini ma'am. She is HOD Akash Medical College, Bangalore. Please occupy the chair, ma'am, as a chairperson. I asked Dr. Amarnath, occupy the chair. Dr. Amarnath, Associate Professor, I asked Dr. Swims, Amarnath. And I call Dr. Hari Krishna, Professor, Vijaya ENT Care, Hari Kishan, and I call from Kadapa. Please occupy the chairs. Vijaya ENT Care, Hari Kishan. Thank you very much. Please occupy the chairs.
Very wonderful. Going to show you endoscopic management of congenital bilateral choanal atresia. This X-ray shows there is a thick plate of bone separating the nasal cavity and the nasopharynx. Axial view also shows secretions are accumulated. There is a block between the nasal cavity and a thick bony plate between the nasopharynx. There is a sagittal reconstruction of the CT scan shows a very thick bony plate. These are the very difficult cases, but it is now easy to manage endoscopically. This is an endoscopic diagnostic scopy where you are seeing a total obliteration of a thick bony plate between the nasal cavity and the choana. Now I am taking a Freer's elevator and trying to puncture and break the bony plate, atretic plate. After making that perforation and confirming it in the nasopharynx, taking a 4 millimeters Zomer debrider, I am removing the bony spicules and bony septa, the mucosal tags, so that all are removed and the nasopharynx is opened. To make the passage. Now you are able to see the nasopharynx from the nasal cavity. The aim and purpose of his endoscopic management is usual procedures of choanal atresia management. They get stenosed because of fibrosis in later stages. In olden days, you all know, in choanal atresia they used to put endotracheal tubes for 6 months, 3 months, and you can imagine children having an endotracheal tube in the nasal cavity, how difficult. But in the recent revolutionized concept after invention of microdebrider and endoscope, we are now concentrating on wide opening of the choana. That means combining both choana, removing 1 centimeter of the posterior end of the septum, such a way that with a 0 degrees endoscope we should be able to see both eustachian tubal orifices in a single view. Such a wide passage should be made, otherwise cicatrization, fibrosis, contraction causes restenosis. Here you are seeing again on the other side. Now I am saying sphenoid 2 millimeter punches to remove the bony spicules all around to make the opening as big as possible. So here blunt instruments like Freer's elevator, Zomet debrider, some 3.2 mm Zomet drills, sphenoidal punches, all varieties of instruments are removed. We have made now opening. Now see, in the middle of the nasal cavity there is a thick bony wall, which is the main hallmark to remove and make both right and left nasal passages into one single entity. Normally also for all of us we have 2 choana separated by posterior end of the septum. Here also we can make the same thing, but the chances of stenosis are high and high. The concept of choanal atresia endoscopic management is patient should be discharged the next day. No question of still there is some amount of tissue partition, bony partition between the two choana. Slowly I am removing that pieces of bone also through the debrider, taking almost care not to damage the surrounding structures, and we should be able to totally remove. Even after all these things, the rostrum of the sphenoid and above and the floor where the posterior end of the septum forms has to be smoothened, the edges. Now you can see the ragged edges of the posterior end of the septum. Now it looks as though it is very adequate. The passage has been already formed. Patient can have a beautiful breathing. I am very sure this is not sufficient. This get stenosed and stenosed. See, now I am taking a 3.2 mm endoscopic Zomed micro drill, Zomed drill, to remove the hard projectile bony margins to make the total circumferential choanal opening as smooth as possible. So you are all seeing the 3.2 mm Zomed drill drilling the bony margins all around, and in this aspect naturally the bony surface gets exposed and mucosa gets damaged, but in the process of healing the surrounding mucosa will get enveloped onto the raw surface of the bony edges. Here now I am saying even the septal midline of the septum bony projection is being drilled out with the Zomed drill. In this way, wherever you feel you need that margins to be exposed, now you are able to see the eustachian tube on the left side, eustachian tube on the right side, and the posterior wall of the nasopharynx, which is some amount of elevations are there, the ragged mucosal edges, the roof of the nasopharynx, the floor where the septum has been removed. So the lateral wall of the left nasal cavity, lateral wall of the right nasal cavity, even the posterior end of the medial turbinates are seen. That above you can see the medial turbinate on the right side is also seen, the posterior end of the inferior turbinate is also seen. This is the way, is the surest way, and we are sacrificing almost 1 centimeter of the posterior end of the septum to give a very wide passage. Thank you very much.
Hello? Hello?
Hello. Thank you, sir, for that wonderful video of release of choanal atresia. Sir, may we know the status in the OT, sir?
Madhu, if there is a delay, you can play one more video.
Very good morning.
Dr. Madhu,
This is a case of
Operation Theatre.
with
Yeah.
subtotal perforation.
Yeah.
You are now seeing after exposure. I am giving an incision in the canal, which is now I name it as 360 degrees canal incision and removal of total skin cuff of the bony external artery canal. Keep it outside and saline, and do canaloplasty and see what is the pathology. You would have seen now many incisions. Here I am using a small cotton ball and elevating the tympanomeatal flap 360 degrees of the external artery canal. You would have seen the orientation, how it is. I am operating on right ear, and the external artery canal skin is also very thin. I am using periosteum elevator, needle, double knife where you have a circular knife and cluster knife, side knife, slowly, gently, in a delicate way, taking care to give. The secret is see 360 degrees, the annulus is elevated and skeletonized and it is removed from the sulcus. The annulus sulcus will be there on the bony ring, give you a ring. Now the last part where at 12 o'clock just anterior to the head of the malleus there are some few fibrous bands. So I am using even a crocodile forceps sharp needle to separate the attachment of the thing. All the fibrous attachments and this thing, taking care there is no tear. This is a very special case where we have decided to do this procedure. There are varieties of incisions you have seen in tympanoplasty, standard coronary vascular flap incision, where they give a endometer incision from 6 o'clock to 12 o'clock and give side vertical incisions to give a vascular flap. And simple single incision where from in right side from 6 o'clock to 9 o'clock there are no incision flaps, like we don't give any incision for the canal and simply elevate. This usually done very wide canals, all are visible. Another incision in cholesteatoma we follow is 12 o'clock incision. Give a incision at 12 o'clock right up to the external level. This is called 360 degrees canal incision. As you all know, Dr. Hugo Fish, international famous microear surgeon, says, under microscope you should be able to see the whole middle ear all around 360 degrees without any protrusions or the canal protrusion. Keeping that in view, we could not get that picture. Anterior bony canal bulge is there. Posterior, inferiorly, there was at a tympanomastoid suture line, there was a bulge. And concentric narrowing of the bony canal. And this is very special. Now you are able to see the whole 360 degrees cuff, which will be varied in length, removed and now kept it in saline. Now giving a good saline irrigation, and you have seen how nicely we have taken enough time. Now the bony canaloplasty is done, which is to widen the bony canal wall so that we have all the view of the canal in our picture. Here you are able to now nicely see how the graft is totally placed on the bony canal wall, and we see that the 360 degrees, the gap is on the bony canal. Now, we usually see the posterior side, the canal wall skin, and anterior side, we know which side we have removed first and which is longer, including the soft tissues of small amount. And it's just like putting a shirt or keeping the total canal wall skin. It's like a free, full thickness skin graft on to the bony mark. And we exactly keeping in contact with the incision line. After keeping the 360 degrees full thickness external artery canal skin graft, I keep dry gel foam as a compressive effect and keeping the ear canal totally filled with graft, and nutritious supply naturally comes from the surface of the bony canal wall, which is drilled out, and it's a good floor. And we have done few cases like this, and it's a good take-up rate, and it is avoids a lot of time, injury, trauma to the external artery canal. And more important is we are able to do good middle ear.
Very nice demonstration, sir. That was a nice surgery. But how about the result, sir? Hello? Madhusudan, sir? Madhusudan, sir? Theater?
Continuously they may be playing, still they may be busy. I think this is, they have removed entire external meatal skin except leaving the annulus, I think. And they kept the graft and again they put back this. Even if you can cut the meatal cuff, need not keep it in the same way. It may be difficult sometime. You can cut and also you can replace.
Epithelium from the margins of the tympanic.
The next case started.
This is almost a total perforation.
Total perforation.
A wide canal. For demonstration, we have selected. Now, 15 number blade.
Hello, sir.
The right ear.
Hello.
From 6 o'clock to 9 o'clock.
Hello.
Hello? Hello, auditorium?
Hello. Yeah, we are from auditorium.
Hello.
Operation theater.
And there may be tape, the viability of the flap, vascularity of the flap. This takes a lot of time. Here after exposure, I can say even a big
Hello. Operation theater.
now with the 3 hours incision.
Let
Hello.
me stop. Hello, we are from auditorium.
Sir, please. Prabhakar, sir.
Yes, we are in auditorium.
Sir, I think so. Few doubts were risen, sir.
Reached the annulus. I am
Hello.
elevating the annulus and
Hello?
also
Mandeep?
Hello, sir.
mucosa.
Mandeep,
Yes, sir. Hello.
are you able to hear me?
Yes, sir. Yes, sir.
Okay. About previous case,
Yes, sir.
the cuff of tissue was removed, no?
Yes, sir.
So, what about the results in such a cases?
Okay, sir. I didn't see the video. We'll play again the video and.
No, Manideep.
Sir.
Manideep.
Sir.
He is asking a question.
Yes, sir.
In tympanomeatal flap, if you remove entire flap,
Yes, sir.
360 degrees, and if you keep it back,
Yes, sir. Yes, sir.
the vascularization will be good or not?
So actually, I think so. Janakiram sir removes the entire skin and again repositions it.
Yeah.
But we prefer having a raised TM flap, sir. We do not.
This is Dr. Janigram's video.
Yes, sir. Yes, sir.
Okay.
Sir's video.
What
But,
about
we,
results? What he said?
Hello.
According to Dr. Janigram,
Sir.
he said the results are very good.
Yes, sir. Results are very good, but we do not follow that, sir, because we are
Dad and everybody, I think so, seniors like your staunch believers of Madhavaya sir's technique.
Yeah.
So we put an intact TM flap.
Okay.
But I think so what sir did last year was very good. I mean, it was good.
Yeah.
There was no chance of flap necrosis, or we didn't see any failure of the graft post-operatively even after 6 months.
Thank you.
But the post 6 months follow-up is not there with us.
Okay.
Okay, sir. Thank you. Thyroid will start in 5 minutes, sir.
Okay.
Infiltration is done. So just setting up the patient and then, sir.
Manideep.
Sir.
A small explanation to that previous discussion.
Sir.
There is a Haversian system of this bone. This
Sir?
external canal bony meatal valve.
Sir.
There is good Haversian system. Through that Haversian system, the flap will get blood supply.
Blood supply.
The
Yes,
flap will not necrose.
Yes, sir.
That takes up well.
Yes, sir.
The results and results are good.
Really
as in
good. Yes,
routine
sir. Yes,
case.
sir. So basically, with Janakram sir's concept is, see, we are doing free flaps, huge free flaps, all in head and neck cancers. So nothing happens even if this is a free flap. It will take up. So that is what sir's concept, if I remember correctly, last year. But yes, sir. It's again year, I think so. There will be many school of thoughts from what I've observed, and results are what matters at the end of the day. So I think so. Even for anterior blunting, there are 3 or 4 schools of thought. It again, what suits you best, what you can do easily. I think so. For the big PG sake, they should concentrate on that. First, develop a skill regarding even raising a TM flap, be it coroners, be it my father's 6 to 9, or be it 2 separate incisions and then raising TM flap, or even do not raise. I think so. If anybody have seen Narayan Jaishankar sir's technique, he doesn't give incision. He's a skull base and lateral skull base surgeon from Mumbai. Sir directly elevates without giving any incision after exposing the mastoid, and then he elevates the annulus directly. So that was a unique technique again that I have seen, and we have not practiced. So, but on ear TM flap, I think so there are so many techniques. But I think so Toss says coroners and then Lempert's, the medial and lateral flaps are what Toss has given. The length of medial flap, if it is very minimal, I think so that's called coroners. If the length of medial flap is more, that is I think so it's named Lempert's, but still there are 3 or 4 variations. But for PG's sake, if they want extensive knowledge regarding flaps and types of tympanoplasties, the go-to book would be Toss, Mirko Toss, the Austrian otologist. He has very good pictures in his books also, very descriptive. Thank you, sir.
Manideep, I think the other case is intubated.
Yes, sir. So
Can read about the issue of that case, details of the case.
Yeah, I'll just announce, sir.
So the take-home message for the PGs is, see all the cases, see all the techniques.
Vocal unilateral paralysis.
Yes, sir.
Vocal cord is in cadaveric position or maybe 1 millimeter in abduction, more laterally.
Yes, sir.
The best is, you know, that lateral medialization of the vocal cord or something you have to push. Which procedure you advocate? Material, like you make a window in the thyroid cartilage?
Here, that Kaufman's formula you have to follow various measurements.
Okay.
You have to take 2 imaginary lines from the upper border of the thyroid and lower border of the thyroid cartilage.
Okay.
And in between the 2 lines, exactly in the center of the 2 lines,
okay,
9 millimeter away from the center.
9 millimeters away from the center.
Yeah, 9 millimeter away from the center.
Okay.
You have to cut the cartilage with the intact perichondrium of the thyroid cartilage. The 2 incisions, above 1 incision, below 1 incision.
The perichondrium should be intact. I mean intact. Internal perichondrium.
Yeah, it must. It is always must. Then 3 millimeter height and 9 millimeter transverse and 3 millimeter vertical height. You have to take a block of this thyroid cartilage. Then you will go exactly over the vocal cord. If you keep the same cyrostic sheet,
Okay.
And again, if you close the pericardium, outer pericardium,
What is the material you are going to put to push?
Silastic
That's
sheet.
what, silastic.
Yeah, so-
But the whole thing is how to make it and to be in place.
Sir,
See,
Just-
you cannot make the exact size of the silastic block.
yeah, then we have to do under local anesthesia.
Okay.
While doing this procedure,
Okay.
you have to see the position of the vocal cord again,
Okay.
and adjust the silastic block.
Okay.
Again, if there is any little disturbance of the voice, again to readjust and ask the patient to phonate.
Right.
If the voice is clear or satisfied by the patient or yourself,
Okay.
then you have to suture the pericardium by intact, after keeping the intact silastic block.
Okay.
This
okay.
is medialation thyroplasty, sir.
Okay. Actually, why I am telling is just for interest sake. Once I did a thyroidectomy, hemithyroidectomy for a Hindi school teacher. She developed recurrent laryngeal nerve palsy. Then I told her, I'll do a thyroplasty because I have done and given you recurrent laryngeal nerve palsy. I'll do free of cost. She did not accept. She went to Hyderabad and got the thyroplasty, and that also did not. And she filed a case against me and Hyderabad surgeon. But by the time process completed in 6 months, when she went to consumer court, somehow she regained her voice and court dismissed that case. I'm just sharing the experience and all these
You
things.
gave a very good message, Madhu, because people should be very careful in counseling. Because if we don't counsel properly,
Yes.
they'll get all medical legal problems.
Yes, yes.
Especially for the youngsters, it will be very, very difficult.
Yes.
So one of my question.
Yes.
See, one thing we will do FNAC, depending on FNAC, we will go for surgery.
Yeah,
Whatever,
yes,
hemithyroidectomy,
FNAC will
whatever.
go for surgery.
If it is wrong, what you say?
What is
Like
wrong?
FNAC, we have taken it has come as simple.
FNAC is not a Supreme Court judgment.
But within 2 months, I have seen one case, we have operated, they have given FNAC report, simple solitary adenoma. Within 4 or 5 months, within 2-3 months only, she developed another node. When
Yeah, there's
what we
possibility.
excised and sent biopsy is, it came as papillary cell carcinoma. While excision, it got injured, recurrent laryngeal nerve got injured. It has like, we felt very bad.
See,
because-
here
So
in
what I am asking is, so a senior person, how are you going to diagnose the protocol of the diagnosis? Because when I am doing in Manipal, we used to give frozen section. But nowadays in peripheries like in Nandyal and all, it's very difficult. So what is your protocol? How you assess the patient before going for surgery? First, because we are as a normal budding doctors or juniors, so you give the best message how to assess properly for thyroid and for selection of the cases. Bless
If you
that.
excuse me, mic is connected to Dr. Satish.
Yes, sir.
We will discuss, Anil. It's a very big discussion, but one thing I can state, FNAC is not a Supreme Court judgment.
Yes, sir.
Pathologist cannot be blamed, nor the surgeon can be blamed because it can change. But giving a recurrent laryngeal carcinoma is the surgeon's, it is also a written complication, so need not worry. Mic to Dr. Satish.
Yes,
Sir.
Madhu.
Sir, just a second, sir. Sir, we are going to present Dr. Anil Kumar, sir, with a small present.
Okay.
I request Dr. Prabhakar, sir, to present the memento to Dr. Anil Kumar.
Anil Kumar is my biggest help and a co-ENT surgeon. His father is the first ENT surgeon in Nandyal, V. Satyanarayan Rao, and he is the president, past president of Nandyal Association, very active, and he is responsible for the all enjoyment yesterday banquet. Thank you, Anil Kumar.
Sorry, sir, I'm going to Pottur for IMA. This meeting is there, sir. That's the problem.
No problem. Your help, because we are all 20 plus now ENT surgeons in Nandyal, 22 ENT surgeons in Nandyal. We are all family. We have a every month academic meeting and discussions, and we are really, I'm happy that to be in Nandyal.
Madhu, we need OT picture, please.
Yeah, OT picture. We will transmit the OT picture.
Sir,
First,
can I interact with Dr. Satish Jain, sir?
Yeah. Mic to Dr. Satish Jain, please.
Hello.
Sir, good morning, sir.
Sir, good morning.
The auditorium is full of audience and waiting for your case, sir.
400.
Hello?
Sir, please centralize the picture, sir.
Yes, please.
Sir, from the beginning of incision of onwards, you please explain everything.
Yeah,
sir.
I will comment on that.
Yes, sir.
You must have known about the details of the patient,
Sir.
which is posted for hemithyroidectomy. वो zoom वो focal length.
आप एक बार आपका पोजीशन रख लो का आपको सेंटर में करना है
हाँ हो गया. Okay, so this is a benign disease.
Yes, sir.
A solitary thyroid nodule on one side.
Sir, what is lower limit, upper limit, medial and that?
Yes. So
Orient the picture, sir, to all the
let
delegates.
me orient you first. What has been done then? See,
Sir.
this is superior.
Yes, sir.
This is inferior.
Sir.
This is right side where we are standing.
Yes, sir.
And that is left side, and this is the nodule.
Yes, sir.
And the incision is been given
Sir.
2 finger breadth above the
Suprasternal
sternal
notch.
notch.
Yes.
Or sometimes in bigger ones on the most prominent part of the nodule, swelling. Like the discussion, Madhu was saying something about FNAC, that
sir.
FNAC is not Supreme Court. This is right. But FNAC is very useful investigation. See, why we are doing all these investigations and operating on thyroids?
Yes, sir.
Because certain percentage of the thyroid nodules harbor cancers. And we have to pick up those only for surgical resection.
Sir.
Not all thyroid nodule need surgery.
Yes, sir.
Yes. So in order to pick up, we need to take help of certain investigation, and FNAC and USG are two most
Sir,
important
what is your
investigations.
protocol in an adolescent girl, 1 into 2 into centimeter to size of solitary nodule, which is colloid in nature?
Colloid.
Yeah.
Confirmed on FNAC.
Yes, sir.
And sonography.
Yes, sir.
Then you can observe.
Yes, sir. Thank you, sir.
See.
Sir,
So
at
that's
this
what
level,
only
will you
those-
ligate the anterior jugular vein? If you ligate it at all, what is the disadvantage is the scar healing?
See, anterior jugular veins are important veins for drainage of the anterior part of the neck.
Sir.
And they have to be respected.
Sir.
Sometimes in larger, lesions, you may have to ligate them. Doesn't make any difference, only but giving some edema in the anterior part of the neck. And see, venous collaterals are so generous. You don't really face major problem with ligation of the anterior jugular vein much.
Sir.
So coming to the investigations to pick up malignancies in these nodules, sonography is one of the most important investigations. Both these are operator dependent investigations. FNAC is FNAC is purely operator dependent investigation, and with the Bethesda categorization, you can have an idea about possibility of malignancy in those. Like pure benign nodules, you can follow. Insufficient aspirates, suspicion of lesion, you can aspirate again. You can do under sonographic guidance. If it's still doubtful, you can operate. Third and fourth categories are indeterminate or follicular neoplasm and all those. They are still the area of research. And there are a lot many, investigations, further investigations are required to assist in order to find out if there is any malignancy going on. You have to bring in the clinical features, clinical history, past history, radiation history, history of malignancy, age, all those criteria into decision making. Then nowadays the marker studies, genetic mutations have a big role to play in identifying those. If possible, you can get done in high risk cases, particularly BRAF 700 and all. Then suspicious or malignant lesions, you need to operate.
Asthmatosis cases, sir?
Pardon?
Hashimoto's thyroiditis.
Hashimoto is never an operative, entity. That's a thyroiditis.
Yes, sir.
And that's a pure medical entity. But yes, sonography, that's what I was coming to.
Sir.
Whenever you miss anything, sonography is very useful. Sonography can tell you to an extent of over 90% any suspicion of malignancy kind of lesion. Even if a nodule which is benign on FNSE, if you get sonography and you find suspicious features, particularly capsular invasion, vascularity, loss of echo, and so many things. Sonography is very useful. And then you can order the FNSE again under sonography guidance.
Okay.
Sometimes you need FNSE under sono-guided guidance for many reasons, in revision situations, in posteriorly placed lesions. Where direct FNSE may not be so informative, so useful, and in situations where there is multinodular goiter.
Okay.
Multinodular are mostly benign, but not always. FNSE will tell you which nodule out of all is suspicious.
Okay.
And then the sonography will tell you. And then you can direct your FNSE according to the sonography of that particular nodule to pick up malignancy.
Yes.
So both these investigations have to be used in judicial manner, very judiciously, to pick up right patients for surgery.
With respect to thyroids,
So many classification risk. Yeah. Yes. So coming to the surgical part, are you getting the picture?
Yes, sir.
See, this is the nodule. One thing you can again get to know with the hormonal status, as majority of the toxic lesions, hyperthyroid lesions, are benign. They are unlikely to be malignant with a low TSH level, because TSH is the stimulant.
Sir, can you show us how will you plan the incisions?
Pardon?
Skin incisions, sir.
Pardon?
Skin incision should we alter or something different?
Incision? We always use the same incision. Why confusion in incision?
No, it was not displayed, sir, that time. That's actually.
No, it was described.
Like normal incision, or you will change from case to case?
So if it is a bigger lesion, you can make incision on the most prominent part, irrespective of level from the supraesternal notch. Basically, the incision should be in the natural crease, lower neck crease, for the cosmetic regions. That's the only importance.
The upper limit of the flap elevation, sir.
Pardon?
Upper limit of the flap elevation.
Upper limit, that's very important.
Yes.
Generally, in small lesions,
Yes,
you
sir.
don't have to go too up, but yes, you should be able to go above the level of the upper pole of the lesion.
Yes.
So that you can catch the upper pole vessel, preserving the external laryngeal nerve.
Yes, sir.
See, this is the upper pole.
Yes, sir.
Yes.
And this upper flap, superior flap, should be a centimeter above the level of the upper pole of the nodule.
This is very important.
Otherwise, you have to struggle a lot in order to catch the nerve. Now see what I am doing. I am just using my cautery to define this midline raphe. See this?
Yes.
Sir, to identify the midline, sometimes we are facing difficulties, sir.
Pardon?
Identify the midline. Like,
Very easy. Lift it up.
yes, sir.
Don't poke your cautery into it.
Yes, sir.
Just try to open up the plane. It will automatically come. See this? See this raphe?
Yes, sir.
See this raphe? And this is the guide for you is anterior jugular vein. See on either side.
Very, very nice.
Either side are anterior jugular veins. Communicating vein, see this? Second is take the full advantage of incision.
Yes, sir.
Take the full advantage of this incision to get a good space.
Yes. Take the full advantage. एक जने को और बुला ले. संदीप.
The microscope lens is 400 mm, sir.
Gloves पहन के रहा. See, I am taking the full use till lower part.
Yes, sir. The lens 400 mm, sir. Lens.
Yes, yes, yes. This is the varioscope, state of the art from Madhu.
Yes, yes, yes.
One thing I would always mention
Yeah.
about the Madhu's setup is it's a complete state of the art setup with all most advanced gadget one can think of in ENT.
No, 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 no.
And more
It's
than
all-
that, his staff was so competent and so oriented for their work. So the things go very fast without asking again and again in the right direction.
My 3 OT staff are working with me for the past 30 years.
30 years. See the love and affection of Madhu. Otherwise, it is so difficult to retain the old staff.
Yes.
Sir, you are very fortunate, sir.
Thank you, thank you. My OT staff, Rafi, Riyaz, Srinivas, Gauss and Nagendra, I consider as Panchapandava, 5 Pandavas in Mahabharata.
See now. So that was the initial division of the muscle in the midline, splitting. Now, over the thyroid gland, there are 2 layers of muscles.
Strap muscles, stenoid and sternothyroid.
Yes. The lateral one is sternothyroid coming from the sternohyoid coming from the hyoid bone to the sternum. This lateral one. And medial to that is
Thyroid.
this is sternothyroid. Right on the gland. This is sternohyoid and this is sternothyroid. So what I am doing now, going underneath the sternothyroid.
Sternothyroid, yes.
See this? This is sternothyroid. See this right on the thyroid
yes.
gland.
Yes, sir.
And I am trying to develop the plane between the gland and the muscle. This muscle is very closely applied on the thyroid gland.
Okay.
Many a times you are likely to miss the plane. See this again. See this layer of muscle.
Yes.
Yes, yes.
So I am getting into the right plane. See this?
Yeah.
Push
So-
your finger in this right plane, blunt finger.
The direction of the fingertips, sir, please.
Yeah, it towards me.
Yeah, towards you. Yeah.
And see, it is blunt.
Yes.
See
And
this
I am
step.
bringing them apart
Yes, sir.
in the right plane to get this gland out.
You don't injure the middle thyroid vein, sir, in this situation.
Middle thyroid is not consistent.
Yes. No, when you do finger
Yeah,
clearance.
it will not breach. You will get an idea of the middle thyroid vein
Yes.
and still you can preserve.
Almost 90% of thyroid swelling is now exteriorated or brought
See now.
out.
See now, most important.
Yes, sir.
In spite of separating the muscle in plane, some muscle is still adherent there. Now I still go deep into this plane with my finger.
Loose areolar tissue.
And this will get me into a very important avascular plane. See this?
Yes, sir.
Ah, very good.
We call it paratracheal gutter.
Yes, sir.
See this? Absolutely avascular.
Yes.
No vessel at all. Bipolar pedal कहाँ है?
Paraglottic gutter.
Sir, is it safe to use unipolar or bipolar cartridge, sir, for this?
Yeah, under
steps?
vision. And I am under microscopic vision now. बड़ा नहीं है.
Sir, when you ligate the pedicle,
See this?
you prefer inferior pole or superior pole first?
Inferior. I will tell you the regions.
Very good question, Nagesh Rao.
Yes, sir.
The superior and inferior pole ligation, which is first, very good question, and sir says it's inferior.
Yeah, I will tell you the reason behind that.
Yes.
See this. The goal of this surgery, this again very, very fascinating surgery for regions that you need to, besides disease removal, you need to preserve certain critical structures, neurovascular structures. Prominently, the inferior thyroid artery, which is the principal thyroid for the artery for the parathyroid glands, beside the
Okay.
thyroid gland. Then the external branch of the superior laryngeal nerve, which is important tensor muscle of the vocal cord, and obviously the most important recurrent laryngeal nerve.
Yes.
So, in order to and the inferior thyroid artery I have already mentioned, and parathyroid glands. So, in a systematic manner, in order to prevent them, we follow a protocol to go from one to another side. See this. First of all, define this paratracheal gutter. Your half of the work job is done if you are in the correct plane.
Yeah.
Can you see the great vessels?
Yes.
Carotid.
Pulsations also you can observe.
Deep focus, sir, little bit.
Yeah.
Deep focus.
Sir, fine focusing is required,
Fine
sir.
focusing. Yeah, very
Yes,
clear.
sir.
Thank you.
See this. This is your IJV.
Yes,
This
sir.
is your carotid artery.
Yes.
If you are in the right plane, see this, what I am doing. Lifting the carotid sheath, opening the carotid sheath in the middle of the course. Can you see some vessel?
That's inferior thyroid artery, sir.
Madhu, can you see?
Yes, sir.
Yes, sir. Inferior thyroid artery.
Sir?
Can you see this some vessel?
Yes.
sir.
This is going deep to carotid. See, important thing.
Yes, sir.
Wow.
Medial to the.
Deep to carotid.
Yeah.
See this?
Yes, sir.
See this. So this is carotid artery.
Yes, sir.
This is IJV.
IJV.
I lifted the carotid sheath and found in the middle of the course this vessel horizontally going deep to carotid. This is the first structure I intend to see.
Yes, sir.
Wow.
This is inferior thyroid
Very-
artery.
Inferior thyroid artery?
Yes, this is very important, going
The artery
coming from
always-
deep to carotid
Okay.
horizontally.
Medial aspect.
Yes.
So this is a branch basically from the thyrocervical trunk given off in the lower neck, which is a branch of thyrocervical branch is a branch of first part of subclavian. So out of the three vessels, supraclavicular and all that, this inferior thyroid is one of the major vessels.
Major vessel.
And this artery is the principal artery for the parathyroid gland, so it is so important. So my first goal is to see this vessel and to ensure that not to clamp this at the level of the stem laterally.
At the laterally.
I don't want to clamp it laterally, otherwise it will devascularize the parathyroid.
Okay, 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 okay.
So, why I am doing with a microscope? For certain region to identify some critical structures and their preservation. And one of the most important critical structure in the entire thyroid surgery, believe me, which can otherwise make the patient's life cripple, is the parathyroids.
Yes.
Sir, what's the magnification you are using, sir?
Pardon?
Magnification.
4x.
This is the lowest one. Now I'll increase for you while working for the parathyroids. I'll tell you the biggest reason for doing microscopic surgery.
Parathyroids will really cripple the life of the patient.
For you, below 7. Yes, that's the
Some general surgeon says, what is the need of microscope?
General
the
surgeons are
advantage
never
of
used to microscope.
The advantage of microscope over the conventional surgery.
See, how can you identify parathyroids efficiently? Parathyroids are so tiny glands. Even if you identify and preserve them, if their vascularity is not preserved, it is of no use.
Okay.
So first of all, identification of parathyroid, which is so variable. You know, during embryonic descent, these parathyroid descend from the base of the tongue, and they ultimately finally engage at some or other place variably.
Variably.
The inferior are more variable than the superior one.
Superior.
We have seen parathyroids even in the superior mediastinum, even in the thyroid gland itself, in thymus. Inferior can go anywhere, though there is a common position where they mostly found, but they can be variable. Superior are more constant. So first of all, their identification is a challenge. Number two, as I said, even if you identify, if their vascularity is not preserved, they become non-functional. And a total hypoparathyroidism, a permanent hypoparathyroidism, believe me, is crippling to the patient.
Yes. The
It is
calcium
much more crippling than the thyroid cancer itself.
Yes.
These, most of the cancers are well differentiated cancer where the prognosis is very good, measured in decades. We have seen our patient doing good for more than 20 years even, because we can treat them with the radioiodine, follow them with the iodine scan. So they have a protocol for that. But hypoparathyroidism, permanent hypoparathyroidism is a nuisance, is a big challenge. So we have to do all possible things to preserve the parathyroids. Now, how can we? The commonest place for the parathyroids you have to identify, and I have seen now. See this. This is thyroid artery.
Yes, sir.
The inferior parathyroids are below the level of this vessel, superior are above the level.
Yes, sir.
Okay?
Yes, sir. Yes, sir.
Now see, this this artery is in close relationship with the recurrent laryngeal nerve.
Yes, sir.
The nerve may be either going lateral to it or maybe medial to it. Or sometimes the nerve branches and this vessel goes through the branch, or sometimes vessel branches, nerve goes through the branch.
Yes.
There could be any relationship with this. Now coming to your first question, whether starting superior or inferior. Why inferior?
Okay.
This now, in majority of the cases, starts at the trunk in the lower neck.
Okay.
When it is given off, and as it courses towards the cricothyroid joint, it divides into branches. Most often, more than 85% it divides into branches. So if you try to locate the nerve superiorly, you maybe end up locating one of its branch.
Right. Okay.
And you may miss the other branch and injure it. So best is to go inferiorly in the right place and as inferior as possible and look for the nerve as a single trunk. See this, my nerve. See
Yes,
this?
sir. Yes, sir.
See my nerve?
That
Yes,
white
yes, sir.
thread-like structure.
Yes, can you see?
Yes, sir.
Yes.
Why? How could I easily identify? Because of the right plane.
Can it be low-risk triangle,
In our
sir?
practice, 90% of the time, we don't have to look for the nerve.
Yes, sir.
If you are in this right paratracheal gutter plane,
Okay.
see your thyroid artery was in front of you, the nerve is in front of you, and the third structure I am going to show you is parathyroid in front of you without doing any significant exercise.
Yes, sir.
See this?
Is it Bear's triangle, sir?
This is low-risk triangle.
Low-risk triangle.
Low-risk triangle means
Yes.
this triangle is bounded superiorly by the inferior thyroid artery,
Yes, sir.
laterally by the great vessels,
Yes, sir.
and medially by the airway.
Yes.
And in between this is the recurrent laryngeal nerve.
Yes, sir.
Okay?
Yes.
So what we have found so far, we have found the inferior thyroid artery, we have found the recurrent laryngeal nerve. Okay?
Sir.
The third structure which I am going to show you quickly is the parathyroid. I can see the glimpse of it. See, parathyroid, the inferior parathyroid are mostly
Very
inferior to the inferior thyroid artery and little anterior and medial to the plane of the recurrent laryngeal nerve.
Yes, sir. Superior thyroid posterior to the recurrent laryngeal.
Yes. And they are embedded in the fat. See this?
Yes. But
This is the
inferior is
fat.
most variable, sir. Inferior thyroid.
Yeah,
fat.
very variable. I have already mentioned.
Yes.
See this? Halka, halka. See this, the bunch of vessels.
Yes, sir.
Bunch of vessels. See these vessels?
Yes, sir.
Can you see the vessels?
Yeah, that's inferior parathyroid vessels.
These are the branches coming from this inferior thyroid artery. Can
Yes,
you see?
Yes, yes, sir.
And that signifies where the parathyroid is. The single
Yes.
most important region for me to use the microscope is to identify these vessels.
Yes, sir.
There cannot be a better criteria to identify the parathyroid than identifying the feeding vessel. And it is so tiny, it can be seen only under microscope. Let me show you under magnification. See this?
Yes, sir. Clearly visible.
Can you see this vessel coming?
Yes, sir.
Madhu, can you see or not?
Yeah,
Yes,
very,
sir.
very
Yes,
clear.
sir.
Where
Very
this
clear.
vessel is going is the parathyroid. This is my parathyroid.
Yes, sir.
Yeah.
See this? Here it is coming. See?
Yes, sir.
Yes, sir.
Can you see underneath something?
Yes, sir.
Yes, sir.
This one between
Yes, sir.
my prongs of the artery fossa. Can you see?
Yeah.
Yes, sir.
Now why it cannot be a lymph node? White cannot be fat, white
Ah,
cannot
white
be
can't
Blood
be
supply.
fat. That's
Blood
what I
white cannot be metastasis.
This blood supply, sir, mainly.
Mainly blood supply, first
Yes,
of all,
sir.
where it is leading to. See, on the surface is the vessel.
Yes, sir.
Okay.
And there is a huge plexus on the surface. See the microvasculature on the surface.
Yes, sir.
Yes,
Can you
yeah,
see?
Yes, sir.
Let me increase the magnification. That is most important. See the microvasculature, which you will never see on the lymph nodes.
Okay.
Multiple capillaries.
See, yeah, this one.
Yes, sir.
This plexus of capillaries, fine adjustment.
Little bit of fine focusing, sir.
Yes.
Yes, sir.
Yes, sir. Beautiful.
Can you see the plexus of vessels?
Yes, sir.
Yes, sir.
See this?
Yes, sir.
This is my parathyroid. See the vessel over it?
Yes, sir.
I'm
Yeah.
making the plexus over it.
Sir.
There, see the vessel?
Yes, sir.
There cannot be any other certain way of identifying this, because this can be seen only under magnification. See that? Once I have seen this, my parathyroid over here, once I have seen this, this is my parathyroid.
Yes, sir.
I will never ligate this vessel lateral to this. I will go further beyond and then ligate the vessel, so as not to devascularize.
Yes.
Got my point?
Yes, sir.
Yes, sir.
See the vessel going. See the vessel to the parathyroid.
Yes, sir. Yes, sir.
So
Distal
clean.
to the distal to
If
the
this parathyroid is devascularized, if this parathyroid is devascularized, it will turn jet black.
Oh.
Under magnification, still you can identify.
Yes, sir.
And if it turns jet black, now is the call to remove this.
And
It is of no use. A devascularized parathyroid doesn't mean anything. You have to remove this, send for frozen section, confirm it is parathyroid, then mince into very, very small pieces like fluid. You can make it just like thick fluid.
Multiple small.
Yeah, load in syringe and inject in one of the forearm
Subcutaneous
muscles. That's it.
Yes.
In 3 to 4 weeks time, 90% of the parathyroid start functioning, if properly done.
So even
when
parathyroid
you-
is got
One
devoid
should
of
rule
blood
out the
supply.
malignancy
Still
before
make it
implanting,
into
sir.
small
But you have to
minuscule
first get frozen section
granules
done.
like
Yes.
and put it.
Confirm
in
that you don't implant
Yes.
metastasis. You
Yeah.
don't implant malignancy.
Yes, sir.
You have to
before
first confirm on frozen section. That would be disaster otherwise.
Right.
So what we have seen,
Yes, sir.
see this is our inferior thyroid artery,
Yes, recurrent
recurrent laryngeal nerve, and this is our
Yes, sir.
parathyroid. Okay?
At this juncture, sir, what about the non-recurrent laryngeal nerve, the incidence and
Yes.
the difficulties in
So,
identifying?
yes,
this?
very important question. The
Yes.
non-recurrent laryngeal nerve has an incidence on the right side, and that happens only in the abnormalities of subclavian vessels. Why? On the left side, the vagus nerve as goes in the thorax.
Yes, sir.
Around the arch of aorta, it gives a branch and it wings around the arch of aorta to come in the neck. On the right side, in the upper part of the neck, it wings around the subclavian artery. In anomalies of the subclavian artery, when it is not arising from the brachiocephalic and the vessel goes behind the esophagus or anywhere, the artery is non-recurrent, it doesn't go in the neck. The vagus gives off this branch high in the neck. Then this vessel travels like this from above, like this.
Yes.
Travels like this from above, and you will not find any recurrent here. That can be picked up only on a pre-operative contrast scan when the subclavian is not in right place.
Yes, sir.
Indirect idea. Mostly we don't get CT scan done before thyroids. So you have to rely on identification of parathyroid. So that's why, again to your question first, why in the lower neck? First identify the recurrent in the lower neck. If you are not, in spite of all efforts, you are not finding the recurrent in the right place, then you have to be suspicious for the non-recurrent and then go to the upper neck. Otherwise, you know what happens? You don't care about anything coming from above in the upper neck. You don't imagine the non-recurrent nerve and you can easily damage if you start working in the upper neck first. So go in the lower neck, identify the recurrent in the stem, it is non-branched. If you don't find, you can be suspicious of non-recurrent laryngeal nerve, and then come in the upper part of the neck.
In contrast, what did you say, sir?
You will miss the subclavian artery in place.
Sir.
Subclavian artery, how it will be?
Subclavian will be retroesophageal. In that situation, there is no subclavian where the vessel is winging off. So it is given off in the upper part of the neck. So that happens in fourth arch abnormalities, branchial arch abnormalities. And it is on the right side only.
Sir.
Now, coming to the, after identification of all these three things, 1, 2 and this 3, this one. See, this is good. Can you see the parathyroid?
Yes, sir.
Between my forceps?
Yes, sir.
See, this is a very small caramel shaped, caramel colored, small nodule. See this?
Yes, sir.
Okay. Now coming to the upper part.
Sir.
Coming to the upper part, you have seen all the three. The external branch of the recurrent laryngeal nerve is again a very important branch. You know, because it
Yes,
supplies the only tensor muscle of the vocal cord, injury to which is going to definitely give the difference in the pitch of the voice.
Especially
A
professional
normal
voice
person can ignore, may not pick up the change in voice, but a professional voice user, now injured, the career is gone. He cannot raise his pitch. So, there are many ways to, preserve this. The old traditional was an indirect one. Stay away from the upper pole and ligate it so that you stay away from the nerve. See what happens, why we don't follow this. Follow the anatomy. See this. This external branch of the, see this, superior laryngeal nerve is given off in the upper part of the neck. And it travels inferiorly. Very nice. It travels inferiorly towards the thyroid membrane. And there, it divides into two branches. The one pierces the thyroid membrane in as an internal laryngeal nerve which supplies the supraglottic larynx, which is a sensory branch. And the other one runs down along the superior pole vessels. Superior pole vessels. And just before the superior pole vessels enter the superior pole, see this?
Yes, sir.
The superior pole vessels.
Here the Joel's triangle, sir.
Yes. Superior pole vessels, these are the superior pole vessels. Where they enter into the superior pole, just before that the recurrent laryngeal nerve takes a median turn. The external branch takes a medial turn to supply the cricothyroid here. So this is the point to catch that. You have to exploit this anatomy. See now what I am doing?
Yes.
I am lifting off this muscle. See this step muscle. This is step muscle.
Yes, sir.
To open up this Joel's triangle. See this. The triangle is roofed by this muscle.
Yes, sir.
I am elevating this off. Now the boundaries of the triangle laterally are the thyroid vessels. Medially is the airway. And now I am opening up this triangle. गलत रिट्रैक्टर है यार. Take a good retractor. Yes. इधर भी लगा दे एक. यहाँ भी लगा दे. One more retractor. Yes. See, the area is focused for you.
Yes, sir.
Non-tooth. Now I am opening up this triangle, too big.
Is it cricothyroid muscle, sir?
No, this is not cricothyroid. Cricothyroid is medially. You have to be careful under vision so as to protect the, see this? If any of the vessel is injured, controlling the bleeding can take away the nerve. This nerve can be very close to the superior pole, can be away from the superior pole. So,
Sir.
there is a classification given by our colleague Brazilian surgeon. When it is close to the upper pole, it is so difficult. If it is above, you can catch the lower pole above.
Yes, sir.
That why the old dictum was to catch the upper pole as close as possible to the
Gland.
gland. See this. See the nerve. Can you see the nerve?
Yes, sir.
Madhu,
Sir.
this
Yes,
nerve
sir.
was coming along like this and taking a
Yes.
turn.
Yes, sir.
Yes.
See, this nerve is going like this. See this nerve?
Yes, sir.
Yeah, yeah, very clear.
Yes, sir, clearly visible.
So I am leaving it above under vision. See this?
Yes, sir.
Leaving it above under vision, and here below that I can catch the superior pole. Can you see?
Yes, sir.
Under vision. So under vision I have left the nerve above. See the nerve above.
Yes, sir. Sir, if we selectively select the vessels,
Yes,
you need
sir.
not worry about the nerve and other
Yeah,
soft
it
tissues.
has been advised to selectively
Select
take one
the-
by one,
Yes, sir.
but doesn't make any difference. We have seen, I don't know why it was initially propagated, but doesn't make any difference. We have ligated so many thousand such vessels without super selective ligation. See the nerve above.
Yes, sir. Loop.
Just before these vessels enter the thyroid, the nerve takes a medial turn. That is where you have to catch it. I will show you again. Yes. The reason was for the recurrent laryngeal nerve.
Sir, you are using silk there, sir.
Pardon?
What is the suture material used, sir, there to ligate
Suture material, just simple barber thread. This is the upper pole, very important ligature. वही आना चाहिए. और लगा एक. See, this was superior thyroid. This was a direct branch of external carotid. See the nerve?
Yes, sir.
Yes, sir.
Very clear.
Such a slender nerve. And see how it is leaving the upper pole, turning medially. See that?
Yes, sir.
That is where you can catch it. Look now.
Satish, in my opinion, 90% of thyroid surgeons don't use microscope.
And 90% don't protect this.
Don't protect that.
See the nerve.
Yes, sir.
See under magnification. तो दिखाना यार क्यों होता है? See this nerve.
Very, yes.
Turning medially. See this?
Yes.
Yes, sir.
This one. This is the nerve. See, this is the nerve.
Yes, sir. Yes.
And we have ligated our pole below that. See that?
Yes, sir.
So now we are away from this.
Yes, sir. Sir, now you please show the superior parathyroid in relation to the inferior thyroid artery.
Yes. Superior parathyroid is above the level of inferior thyroid artery. At the same time, it is situated more, reliably posterior to the plane of the recurrent laryngeal nerve, where recurrent laryngeal nerve enters the larynx. Cricotracheal junction. See this. I can feel the trachea here. Trachea. And now the cricoid cartilage comes here.
Yes.
Where the cricotracheal junction is, at this junction the superior parathyroids are behind the plane of the recurrent laryngeal. Now how to pick up? See this. Very simple.
Sir,
You have seen the recurrent laryngeal now. See this?
Yes, sir.
Follow the recurrent. See this. Follow this recurrent.
Yes, sir.
Now, see now divided into two branches.
Yes, sir.
Yes, sir.
Madhu, I told you most
following.
often it divides. See this?
Yes, sir.
Very keenly following. Yes.
See, it divides into two branches.
Yes.
Yes, sir.
And here at this point, see this? Yes. See, my nerve is below.
Yes.
Arey,
Sir, if we accidentally injure that superior laryngeal nerve, what is the perioperative procedure to
Yeah, I
improve
will
the
tell you.
Yes, sir. Perioperative. If we accidentally injure the superior laryngeal nerve, what is the best method to?
Yeah. See now, what I preserved here. This is parathyroid.
Yes, sir.
Yes, sir.
See, this is behind.
Yes, sir.
Yes, sir.
So I saved this like this. Don't do anything to it. See the parathyroid?
Yes, sir.
Harmonic scalpel is a wonderful thing here. कम कर दो यार. See this? See the superior parathyroid?
Yes, sir. It's looking like jet black, sir.
No, this is not black. This is embedded in the fat. See this fat?
Yes,
Yes,
sir.
sir.
Yes.
So we have seen both the parathyroids.
Yes, sir.
See the recurrent laryngeal now branching. See this?
Yes, sir.
Yes, sir.
Two divisions, very clear. Now finally, that is the vessel going for the inferior parathyroid. See this?
Yes, sir.
And now finally, I will catch my superior thyroid here, or the inferior thyroid here, and then finally take away the specimen. That's it. See this run above the nerve. There are a bunch of vessels here. Lift off away from the nerve. See this?
Yes, sir.
Yes, sir.
How the nerves are opened up. Because you have to separate these nerves. They go here. This is the cricothyroid muscle.
Yes, sir.
That's the nerve which was going to the cricothyroid. See that now?
Yes, sir.
Yes, sir.
External laryngeal. This is cricothyroid muscle.
Yes.
And this now go behind the cricothyroid muscle to enter into the larynx. From here, cricotracheal junction,
Yes, sir.
this nerve runs almost for a centimeter deep to this muscle to enter finally into the larynx. That's how the course is. Now, this is the see, this is the
All this stretching will not affect anything.
too much
I
of
think
stretching.
we are
Too much
doing
of
in
stretching can.
microscope. Yeah.
Too much of stretching can. So be careful.
Yes, yeah.
See now what I am ligating now, and where? Where I am ligating the inferior thyroid artery, close to the thyroid.
Yes, very close to the thyroid.
After it has given off all the branches, if you ligate the stump of this nerve, then you end up devascularizing everything. See this?
Yes,
Yeah.
sir.
Yes, sir.
Under vision.
Please centralize the picture, sir.
Yeah. See this?
Yes, sir.
My nerve is there, and now ligate this. See this vessel?
Sir.
Trunk of the inferior thyroid. See this?
Yes, sir.
Yes, sir.
It has given off all the branches here. And finally I am ligating here. Each and every step is important to prevent comorbidities. देख के.
What is the role of harmonic scalpel in thyroidectomy or
Very,
neck
very
dis-
important. Harmonic scalpel.
Yes.
In the same movement.
Yes.
You can coagulate and cut.
Yes, yes.
I would have been through by now.
Uh-huh.
I need not to first cauterize, catch, cauterize, ligate. You don't need to do anything. Just
Yes.
coagulate and
Go.
cut, coagulate and cut. Fast.
Is it really much became popular for head and neck surgeons? Believe about that oncology head and neck
Some
surgeons?
places like in parotid,
Parotid, okay.
thyroid,
Okay.
because it works on ultrasonic principle. It
Yeah,
doesn't
yeah, yeah.
damage the nerve in the vicinity. See now, see the branches of the nerve. Both the branches.
Yes,
See
sir.
this?
Yes, sir.
Yes, sir.
And staying away from these branches now, I am segregating. See, with this pull, I am taking away my specimen away.
Yes.
This is spray cautery. This is spray cautery. See this?
Yes.
Yes, sir.
I am not using any force because I am close to trachea. One may puncture into trachea. See now we are away from the nerves.
Yes, sir.
My external branch is here, recurrent is here, both the branches. See this? My parathyroid is here. And now I am separating in the pretracheal fascia plane. See this?
Sir, in case of superior injury, can you show the landmark for cricothyroid suturing, tensioning?
Yeah, I will. If the external branch is injured,
Yes.
you can do a cricothyroid approximation. See this? In the pretracheal fascia plane.
This is pretracheal fascia plane. Okay.
Yeah, this is condensation of deep fascia only.
Suppose accidentally a small pinhole occurs onto the trachea, can immediately readjust the fascia and suture?
No, don't do anything. Leave it open.
Okay.
The middle part of the wound.
Okay.
For a centimeter, leave it like tracheostomy. Allow the air to escape. If
Okay.
you try to suture, do anything, the emphysema may take place.
Emphysema, right.
That is dangerous.
Very dangerous.
Leave it like tracheostomy, in 5-7 days it will heal. We leave the big tracheostomy defect and it heals
Yes, yes.
on its own. So never do that suturing or anything.
So that pinhole can be just kept open.
Pardon?
That pinhole injury
Yeah.
can be kept open.
Yeah, it will heal in no time.
Yeah.
Yeah. Keep a corrugated drain. Yeah. Corrugated drain is for the serum and blood for the other areas. For the central part where you injured, leave it open. 1 centimeter, leave it open. Even the skin. The muscle and skin both, leave it like a tracheostomy defect. It will heal by secondary intention. So it will not lead to emphysema. Now see, another very important thing, we have to ligate the lower pole because it has veins draining to the left brachiocephalic. See, I am ligating high up और ऊपर ला. See here, high up, not in the lower part of the neck, because if you try to ligate in the lower part of the neck, it can take away the venous drainage of the parathyroid. So ligate these inferior thyroid veins close to the gland. In central compartment dissections, when you do for the malignancy, most often your inferior parathyroid is damaged. Otherwise, it is difficult to do. Most often you can preserve with a lot of difficulty, but it goes. But superior parathyroid you can always preserve. Out of 4, even if one parathyroid is intact, you can avoid a permanent hypoparathyroidism. But transient may be there, but it goes off in couple of days. See the inferior pole. So now our specimen is coming out soon. You have seen all the structures?
Yes, sir.
Satish,
Yes.
can we do another one case?
Yes, yes.
So that our audience are interested.
Yes, yes, no problem.
Last case.
Oh, Madhu, whatever you say.
And really interesting, a pediatric fest.
No problem. Whatever you say.
The delegates, Nageshwar Rao,
Yes, sir.
Prabhakar sir,
Yes, sir.
we are making arrangement for one and last case, that is pediatric fest. Really all will be interested to see in which case we should have a surgical intervention. After that, Satish Jain will come to the conference hall and have the chat with you and photograph.
Sir.
See, Madhu.
Yes.
What I have removed. See this entire trachea exposed?
Yeah,
This
rings
was
are
the
also
gland.
clearly, yes.
This was the gland and this is the entire isthmus.
Isthmus, yes.
So hemithyroidectomy involves loboisthmectomy.
Yes.
Lobe plus isthmus.
Isthmus. Why can't you just cut with the 15 number blade?
I can, but
Yeah,
just to be doubly sure it doesn't
No, I thought
open.
it will may get, because with cautery it may get slip off,
it
because
will
you have to now ligate also. Oh.
Hey, come on. क्या कर दिया? ऐसा लगा। यार, come on. Madhu?
Yeah, I
Same
think
thing happened. What you said?
I think autoclaving sometimes because of heat.
Weakens that.
Yes.
Rapid and control. What is the suture material, sir?
Barber thread.
Normal thread. Yeah?
See now at the last you can look for the hemostasis. Most often you don't need to do anything.
Cricothyroid approximation, sir.
See this once again. The entire anatomy.
Yes.
Never suck directly on the nerves.
Okay.
Section.
I was getting a doubt. You told that you had to take a frozen section biopsy in case of parathyroid doubt. Frozen section itself, you take the amount of parathyroid. And how much small quantity of that suspected parathyroid to be taken for frozen section?
Whatever parathyroid you remove.
Okay.
Has to be sent for frozen.
Total.
Yes.
Then how will it come back?
So pathologist will take a tiny piece of it.
Okay. So we should specifically mention.
Yes.
This is a suspected parathyroid. Take a small sample of that pyroid, and if you feel that it is pyroid, send it back. We will cut into small.
Like if you don't have an in-house pathologist,
yes,
then take a sliver of tissue from it and then
send it.
Sir, we can put the tissue in the normal saline. The fat will float. The parathyroid will sink.
And what about if it is thyroid tissue or malignant lymph node then?
Sir.
That will also sink.
Yes. Yes, sir.
Sinking.
But when confusion with the fat only, it will be useful.
Yes.
Only for fat.
See, distinguishing from the fat is easiest under microscope.
Yes.
Fat is devoid of blood vessels, network of vessels, which parathyroid will have, malignancy can have. So distinguishing from fat
Satish,
easier.
Ambrose Spear, all these anatomists in 1600s, maybe in that century, they don't have any magnification, no electricity, no lenses, but still how they had traced vagus nerve from cranium to anus, and how they traced that recurrent laryngeal nerve, I don't know.
Even in the 19th century, the entire anatomy was defined, which we are reading till date same.
That's what
Though
I am
it is
telling.
more and more refined now, but by and large they discovered everything.
Majority of the, what you are telling, the parasympathetic fibers from lingual nerve, that small fibers are coming from facial nerve, maybe now microscopic, but Jacobson's nerve.
Yeah, they
Even
identified in
cochlea,
18th
leave about the
century.
nerves.
They identified it.
And I don't know how much great, any hundreds of dead bodies they would have dissected. And what we are all seeing under microscope and thinking that we are all big anatomists. They
Sir,
all
sir,
did without any. Nageswarao.
Some of the delegates are asking, sir, when will you estimate the parathyroid, if at all, if you suspect any deficiency, or thyroid, if you suspect any deficiency, definitely thyroid deficiency, in parathyroid, on which post-operative day, for thyroid functions, on which post-operative day?
See, after the hemithyroidectomy, generally you don't face any issues.
Sir.
Neither hypoparathyroidism, neither hypothyroidism. All those complexities arises when you do a total thyroidectomy.
Okay, yes, sir. Okay.
Because in hemi, your other side is intact. Even if you damage both, your other side is functioning. But if it turns out to be a malignancy and then you go for completion, it is important to preserve on the other side. So, always whether you are doing for benign or malignant, always make a habit to preserve parathyroid. In total thyroidectomy, you have to be very suspicious regarding the parathyroids. Particularly, you should preserve the superior parathyroid for sure. Inferiorly, you may have to clear off metastasis from the central compartment and you may end up damaging. You may have pre-tracheal lymph node that may damage the venous drainage. So inferior can go without any problem if you preserve the superior, because where the superior parathyroids are, lymph nodes are unlikely. And your central compartment dissection doesn't involve the lymph nodes in the, cricotracheal junction. So it is all important in total thyroidectomy. If you are suspicious, immediately after half an hour after the surgery, if you take the parathyroid level, it will reduce by more than 50%.
Sir. Sir, it's excellent demonstration thyroid, sir, because this thyroid and parotid are both functional glands in the head and neck regions. These functions of the thyroid, including white structures, very important structures around the thyroid, excellent demonstration, sir. Especially in the parotid gland also, both functional aspects in the head and neck regions, thyroid and parotids. In this case, thyroid is excellent demonstration for all the vital structures. Excellent. Thank you very much, sir.
Thank you. Thank you for your attention.
So we will go to that case. Next case is last, and CT scan camera. This one. It's a 14 years old,
sir,
having recurrent attacks of sinus obstruction, mucopurulent discharge, and snoring is not much, but just a minute. Madhavi is also in-house anesthetist for the past 20 years.
Oh, really?
Dr. Malleshwari, her husband is a urologist. Madhavi's husband is Madhu Hospital only, Madhumani, and that is Madhu Children's Hospital, opposite to my road.
Oh, really?
So she's very near anesthetist, in-house anesthetist. And main complaint is always discharging, always discharging, always discharging.
See, these patients are never eosinophilic. Pediatric sinusitis is almost always
Okay.
neutrophilic driven, non-polypoidal.
Non-polypoidal, neutrophilic driven.
Huh?
How do you
Mostly.
confirm that?
Yes, yes, you can.
Any biopsy of nasal chamber?
Yeah, swab, blood counts, everywhere, it is not eosinophilic.
Blood count from that tissue or?
No, from the blood.
Blood
Yeah, the IG level must be low.
So much
No,
amount of good space between turbinate shoulder and lamina orbital point, and still they get obstructed. They get
It's immunity.
Immunity. Okay,
Yes,
okay.
immune complex disease. And see, most of the pediatric orbital complications happens to occur in pediatric age group.
So
Antibiotic plays a big role.
Yes.
Yes.
Antibiotics. In children, surgery is the last resort. First is a good
Surgery is the
antibiotic
last
course,
resort.
adenoidectomy to take care of biofilms infection.
Are you able to see
Improve the immunity with
scan
color.
of this patient? And
Yes.
sir is telling it's not polypoidal, non-eosinophilic, and it's a infective nature, and it is all neutrophilic. And this thing?
Yeah.
Some small differentiated density.
Yeah, let's see.
Fungus. And also some air shadow.
Yeah.
Maybe a fungus or something.
Sir, how to differentiate it is because of the adenoids or it's a purely chronic sinusitis?
See, in children, I tell you, adenoids, even if are not enlarged, become the source of infection to paranasal sinuses.
Okay. Yeah.
Adenoids develop biofilms in their crypts. And
So
biofilm is protected by the patient's immune
Yeah, do you
system
mean-
from antibiotics.
Do you mean we have to do only adenoidectomy and wait and watch?
Ideally, after the thorough medical course, the first surgical trial should be adenoidectomy
And do an antral lavage?
and antral lavage.
Antral lavage.
You get
Yes.
a specimen for the culture sensitivity also. And if you get that information, then you can give a culture-driven antibiotics. Then, along with that, you have to assess the immune system, immunoglobulins, vitamin D, all those, and improve the immunity, overall immunity as well.
Yeah. Thank you.
Nowadays, a lot of drugs we use in a pediatric age group to avoid surgery.
Yes.
Yeah.
Besides this, saline irrigation, nasal sprays, adenoidectomy, then we use a probiotic, we use Imulina. Imulina is a pedotimode, is a immunostimulant. We use clarithromycin, lot of things overall to avoid the need of surgery. But yes, many a time they present with complication, orbital complication, and then you have to do a formal FES. Even if everything fails, then you have to resort to a FES. So pediatric decision making is important. In pediatrics, if you have multiple polyps on either side, both sides,
Okay.
cystic fibrosis,
Cystic
until proven
fibrosis.
otherwise.
Take this statement, Prabhakar.
Yes.
Multiple polyps in a pediatric age group, it's a cystic fibrosis.
Yeah.
We have done, 1.5-year-old child cystic fibrosis surgery because that is a pure, because of mucostasis.
Mucostasis.
In cystic fibrosis, the defect is a genetic defect at the level of chloride transport
Lifelong
channel.
nasal douching.
Chloride transport channel is defective.
Uh-huh.
So the secretions formed are viscid.
Okay.
So mucociliary activity can't clear this. So that is stasis, and that is pure infective disease. The only sinusitis which develops Pseudomonas infection. Only variety of sinusitis.
Okay.
Okay.
Cystic fibrosis is pure infective condition,
Yeah.
and Pseudomonas is the predominant. Otherwise, in all sinusitis, Staph aureus is the predominant.
Very
In
very
cystic
good point.
fibrosis, and in that, you have to do surgery, big openings to give gravitational drainage.
Okay.
We have done bilateral medial maxillectomies, complete turbinectomies in a 1.5-year-old child. And then antibiotic lavage rather than steroid lavage.
Steroid,
We
okay.
do in FES. Post-FES we do steroid lavage. In cystic fibrosis you have to do antibiotic lavage.
Okay.
Antibiotic means tobramycin, manuka honey, all those lavages to control infection, to prevent lower respiratory infection. Because their life is, short, because ultimately they develop lower respiratory infection, lung failure, and ultimately need lung transplant.
Okay.
Their lifespan is short as compared to the other people. So ultimately their failure is at the level of lung and the region is upper airway.
Diagnosis is cystic fibrosis by biopsy?
Sweat chloride.
Sweat chloride.
Sweat chloride.
Sweat chloride,
Sweat
okay.
chloride and then genetic testing.
Genetic.
Nowadays, lot of genetic, factor mutation transformers are available. So, which acts at the genetic level to improve the viscosity. So, and those are very, very costly. And then they are needed for life.
So if you come across a multiple polyps in a pediatric age group, be very cautious, and it is a cystic fibrosis and you should be very careful.
Sir, in case of pediatric sinusitis, especially polyposis, there will be extensive osteitis. Sir, Satish Jain, sir.
Yes. What?
In the pediatric sinusitis, especially sinusal polyposis and sinusitis, there will be extensive osteitis when compared with the adult. You please comment on this.
Osteitis in adults is not uncommon, particularly in eosinophilic disease.
Sir.
Osteitis is what? We seen that sinusitis is what? Inflammation of the lining mucous membrane of the paranasal sinuses.
Sir.
When this inflammation goes in the deeper bone as well,
Yes, sir.
it involves the underlying bone, that is osteitis, and that bone is a sort of depot of all those cytokines.
Okay.
So that's a very massive situation of inflammation, and in that situation all those underlying osteitic bone have to be removed.
Yes, sir.
That remains the source of cytokines otherwise. So CT scan will reveal you if any osteitis. Most often it involves the ethmoidal septation, and you can flush them all completely by removing.
So do we need frontal sinus exploration or removing
Yes.
all the disease, naturally the disease within?
No, we'll do frontal.
Will do. Acha.
Though the frontals are not very big, but yes.
I think...
Yes, we'll open.
We'll open, okay.
The
Because
challenge in pediatric is the narrow space.
Challenging in pediatric age group is the narrow space.
Let's see.
She's a 14 years old girl, but let's see.
Not that young.
Yeah. Sinu, అక్కడ అయిపోయిందమ్మా ఇంటిమేషన్.
Corrugated drain.
Yeah, we have already.
Oh, yes, sir.
Pediatric sinusitis, need not to treat. So only endodotomy, if you do endodotomy, that's enough. That is the only treatment. Yeah, sinusitis.
Telling antal wash.
Yes, yeah.
By doing antanasal antastomy.
Childless, sir.
Antal wash.
And endodotomy చేసి
Just remove adenine and leave it.
and metaspray, sir, nasal sprays for 6 months continuously. There is US FDA approval.
Yes.
Approved this metaspray. Excellent results.
Hello.
Hello.
Hello, auditorium.
Sir. We are waiting, sir.
Nageshwar Rao Prabhakar.
Sir.
Yeah, Madhu. We are here.
Yeah, okay, right. Patient is induced.
Okay.
She's a, I think, 13 or 14 years old girl.
Yeah.
Sufian kada? Male, I think. Okay, right. And packing is being done with our thermo wool.
Yeah.
Decongestion with adrenaline. Frank, 1 in 1000 adrenaline, 3 ampoules with saline as usually and everything.
Yeah.
Sir is getting scrubbed up, and because of the want of space.
Okay.
So
Madhu, 3 ampoules in how much saline?
10 cc,
10 cc of saline and 3 ampoules of adrenaline.
Yes. I mean, see, this is my way of doing.
Okay.
Suppose Janakiram, Frank, 1 in 1000 solution of adrenaline, 10 ampoules. No saline, nothing.
Okay.
Satish Jain sir, 20 ampoules.
Okay.
They don't infiltrate. First of all, their phenomena is, concept is no infiltration.
Yeah.
That actually affects the cardiovascular system, and anesthesia will become fluctuating.
Yeah.
Instead of that, you just make use of adrenaline topical and pressure. That is only a locally compressive adrenaline that will not cause. Vessels are getting constricted. How will it get into the vasculature?
Yes.
So, morning also, I think you have seen.
Yes.
With our Madhu's Merosil, whatever it may be, Indian Merosil or.
Yeah.
With Madhu's Merosil, he has dipped in Frank adrenaline solution.
Yeah.
And go on spraying or painting onto the polypoidal surface of the AFS case.
Yes.
I think Madhuri, you have morning you have seen. And right from the sphenoethmoidal recess onto the polypoidal surface, and uncinate process and middle turbinate and all these areas and gain. Morning we were also discussing about the role of antral wash. We still feel in pediatric age group, sometimes we do tonsillectomy, adenoidectomy, and even grommet tubes, and in that cases, in CT scan or in X-ray paranasal sinuses, we see this sort of hazy sinuses.
Yeah.
We don't just jump and go on do middle metal antrostomies and all these things. Tonsils, okay, bulky and grade 4 you remove. Adenoids, yes.
Okay.
Sir was thinking biofilms and all can cause all havoc. That has led to the eustachian tubal orifice block.
Madhu, if you don't mind, can you ask Dr. Jain to demonstrate that inferior
which one?
Antral wash, because nowadays nobody is doing antral wash.
Srinivas, antral wash cannula anta తీసుకొనరా. We will ask Satish.
Because I don't know whether Nageshwara.
I cannot force. If suppose Satish Jain want to do a MMA, how can we force to?
Yeah.
Sir is getting scrubbed up.
Yeah, Madhu. Dr. Nageshwara is telling nowadays nobody is doing antral wash in medical college.
I strongly, we depend and we believe that it is giving good results.
Okay.
That mucopurulent discharge after adenoidectomy, and you can see after decongestion under pediatric endoscope, there is certainly in the middle meatus you see some mucopus. So for that case, instead of pediatric, and it's sometimes very difficult to do a middle meatal antrostomy, small pediatric Blakesleys, small pediatric back butting forceps, just do an antral wash.
Okay.
And really, because the ultimate first primary focus of adenoids is removed, that is the resultant of your stasis of maxillary sinus or dependent frontal sinus.
Okay.
That primary focus is removed, and you have just done
secondary focus also removed.
And that IND.
Yeah.
Doing an antral lavage, in my opinion, is like doing an incision and drainage of an abscess cavity.
Yes.
Primary focus removed, and you have done IND and this thing. All my assistants, right, Rohit, Manideep, we very much feel that instead of jumping into pediatric FES, antral lavage will give very good. And it's a small 2 millimeters hole. If it doesn't respond, in future you can certainly go for FES.
Yeah.
And you all know, Prabhakar, we all did in Kurnool Medical College.
Madhu, you show your sponge. Madhu's
Sponge,
Merosil.
camera.
And what is that quality? Which sponge? Is it foam or sponge?
It is sponge, not foam.
Yeah.
Srinivas, hold this sponge with forceps, chittils to patko. Camera.
Madhu, post-op nasal pack, what do you use? Madhu, post-op nasal pack, what are you using?
Merosil. Don't use this for post-op packing.
Okay.
Abbo, it causes terrible irritation of the nasal mucus.
This is only for the
only
intra-op.
on the table.
Intra-op.
Intra-op for temporary compressive phenomena are able to getting the sponge.
Yeah, we are able to see the sponge.
Go to the furniture shop.
Yeah.
And feel a Merosil which is dipped in water.
Okay.
What is the consistency and compressibility, adaptability or approachability?
Yeah.
Same feeling you should get with the sponge available with the furniture fellow. He uses different consistency sponge.
Okay.
And whichever is comfortable for you, just bring. And autoclave it. See, this is a sterile one. This is not a, I'm not just using just
sterile.
like that.
Okay.
You put, this is a steel kidney tray are you using?
Yeah.
Gauze pieces, our thermo wool cut into 1 centimeter pieces and some cotton and sponge.
Okay.
This we call it as kidney tray which has all these in every set.
Okay.
So even you can focus our FES trial and Claire Thompson's nasal speculum, bone nibbler, bone cutter, 3 Blackesley forceps, but we all arrange here. Packing forceps, backbiter forceps, Blackesley's forceps. మనం ఎట్లా అరేంజ్ చేస్తామో ఒకసారి అట్లా పెట్టు రియాజ్ నాకు ఇద్దామా స్పాంజ్ ఇప్పుడు ఆర్ ఏబుల్ టు feel the sponge in my hand?
Yes.
And Sagar is also feeling the consistency. See, I am pressing and immediately that compressibility. And is very good and hardly you just give me this furniture fellow will sell, I need this much. Sir, what is this? Sir, take freely. How much does it cost? Okay. So, and this is Madhu's, whatever you call, discovery. It is not an innovation. Innovation means which is not there you have invented.
Okay.
Discovery means Vasco da Gama. India was present and Vasco da Gama has discovered.
Yes.
So this sponge is there already. But Madhu has discovered that this can be used as a Madhu's Merosil. But don't use for post-op packing. My sincere advice, though it looks very cheap, it causes tremendous reaction of the mucous membranes and allergy and all these things.
Okay. Thank you, Madhu.
And you can take a scissors and cut into pieces like this and whatever size you like, put it in adrenaline solution. Post-op pressure. Another thing is Manideep and this thing, this will not exert pressure like Merosil.
Yes.
Merosil once it expands, cannot get compressed. It always applies pressure.
Madhu, for the local anesthesia cases, we are using the same sponge with the thread we put in the postnasal area.
Yes, you can nasopharynx peroperatively. We also keep this sponge to prevent dribbling because we do majority under local anesthesia.
No, we under local anesthesia only we are using this.
Yes.
We will put a thread for it and we will keep the thread and artery forceps outside.
We can use it.
Yeah.
And for all intra-op for 1 hour, 1.5 hour, you can put it in middle meatus on one side, come to the opposite side, do the procedure and go to the opposite side. And this is all very useful. And people who have seen this, they all are following because nobody, suppose Merosil, you know, when you write to the MRP rate to any medical store, they will charge 400 rupees. You may get for lesser price. But for patient, certainly it is very costly.
Yes.
And you want to cut 2 Merosils and 2 Merosils for packing, that itself will become 1600 rupees. And we are all under Arogya Sri and
Nandyal is not that rich like Vijayawada, and that is, we have to be very conservative to the areas. These are all small practical tips. Don't
Thank you,
think
thank
that
you.
I am nenedo vidu purti vanevantaru pisini gottu kada purti this thing. Even show that Gauss, show that box. You are using, see this box, we put it the cable and camera in that box, and a sponge is there, put formaldehyde, and small gutter is made. Chinna cut chesinam judu. That from that gutter, the cable of the light source and camera cable will come out.
Okay.
And it's a tight pack, so you get and close grouse. Okay. Formaldehyde sterilization. These are all not described in books, only the practical points. That box which we are
Madhu,
using.
you put the camera and show how they are putting.
No. It's already taken into the table.
Okay.
Cleaned with what do you call sterilium.
Okay. Last you can show.
Okay, thank you.
But he is putting it
That box, we put in this thing and we make a small hole. Gauss malla chubis. This small hole, the cable of the camera and the light cable will come out from this, like this.
Okay.
And you can shut it also, no? You can.
Madhu, what is other black one in the sponge, over the sponge? What is that?
That is the camera.
Camera cover.
Image spice camera.
Cover.
Cap.
Okay. Thank you.
Thanks. Your hats off to your observation, Prabhakar.
No. we came here to learn was.
Right, Itiyama. This is how we arrange the table. This is how this contains a straight 45, 90, backbiter, turbinectomy scissors, and this is an antrum punch scissors. Riaz, just close and open.
Yes.
This is a very useful. This is an antrum punch. Sometimes when you go into the horizontal part of the uncinate and lot of tissue, you can just cut or sometimes bone.
Okay.
And rest of the things are like this.
Yeah.
And this is nasal speculum, the bone cutter, bone nibbler. You asked me antral wash cannula.
Yeah.
And 2 endoscopes, ball point and debrider blades. And this set contains septal elevator, hammer, Riaz. One set contains tooth forceps, BP handle, J curate, ball point and everything.
Okay.
Another all suction cannulas. Number of suction, straight 2, 3, 4, and again curved cannulas 2, 3, 4. Eustachian catheter, and show that Eustachian catheter. Eustachian catheters are simplest and easiest, and long go into the maxillary sinus long back. Again you get 2, 3, 4, and this is number 5, straight cannulas. All should be there in your set number of suction cannulas. These are the, actually the success of any fist surgery is because of the suction machine, not because of this thing.
Madhu, you are using central suction or?
No, Venki's.
Local.
And we have pro sound liposuction. Focus on
you
that.
show the
Gauss,
Venki suction.
This is for fist. We show liposuction. Are you able to see that?
Yeah.
This is called pro aspirator liposuction. It's a 4 times powerful as single Venki suction.
No. Which company this one?
Venki.
Venki only giving.
Company is only Venki.
Okay.
And you should ask pro aspirator liposuction.
You all put these things in the entire basics.
Photographs. Yes,
Amma,
very good idea.
Dr. Sagar.
And my request to all the delegates, you please give your opinions in the WhatsApp group and email group, and also your feedback form. Give us suggestions to improvise what Madhusudan or Manideep can do for the next workshop.
Last year also can take photographs and put in the entire basics.
Last year should get the award for being right from first minute to the last minute in the theater, like a spy. I don't know, not for like 007, but give her some other word.
No. She is there to learn, Madhu. You
No,
have to
no, no.
appreciate her learning interest.
I am feeling jealous that I was never so much learning when I went to a workshop. I was a stalwart, going to stall where I get a ball pen, where I get a chocolate, where I get a notebook, where I get a bag. The three types of delegates are there. First one is stalwarts. They will be always searching the stalls. Second is outstanding surgeons. Which place to go for a tour, outstanding tours programs. The third is chairpersons. There is another delegate called dosing delegate, DD. This moment they sit down, lights are switched off. and the tamasha of these DD delegates, dosing delegates, after the lecture is over, I have a question.
Yeah.
I don't know what he has heard.
Madhu, in America, if they fight with the spouse, they will go for fishing.
Okay.
For some surgeons, they are coming for workshop.
Actually, I have another classification of delegates. Highly spiritual delegates. I think you can understand what is highly spiritual delegates. And evening the banquet, they will be highly spiritual.
They come for that only.
Not that this thing. And highly bookish delegates. The moment what the speaker tells, today I am going to explain you frontal recess exploration, they will try to write 2 TOTA, DIV and everything going on, writing. I don't know what they will actually.
They will read it.
Another is photographic delegate.
Yeah.
And I don't know whether he hears or not. Every screen, every slide, his business is going on clicking the slides. So I think I have classified so many number of delegates. All these delegates, next time when you go to a conference, you will really visit. And most tamasha of all the delegates is the chairperson. And this chairperson, and he will be sitting for that event as a chairperson, and he doesn't know the subject of that particular.
Hey, you should not say now there are 2 chairpersons are here.
No, I am not thinking otherwise. Sometimes if nobody is there, can we call that person who is sitting in the back seat? I request Mr. Abhilash Kumar to come and chair the session. Because no one is there whom to call for the chairperson. This is only as a hilarious part of conference because Satish is...
I am what type of delegate, sir? Nageshwar Rao?
Abbo! Nageshwar Rao. It is...
Nageshwar Rao is a type of delegate. The visiting faculty will go home and read again. And he will make all the faculty to go home and read. Because the way he asks questions, they will never come again if Nageshwar Rao is there.
If Nageshwar Rao doesn't mind, can I tell Nageshwar Rao, sir?
Yeah, that's what he is asking.
He is a pinching and squeezing delegate. And or exploring delegate.
Yeah.
He will try to, even a small, minute bit of that particular topic, he will never leave.
Yeah.
And it's only academicians in medical colleges have that. See, I agree that I am a 35 years old practitioner. Sometimes suddenly you ask me Joel's triangle, I cannot answer.
Yes.
Suddenly you tell me from this branch comes from which nerve, I cannot answer.
Yes.
But in a practical steps, I may answer. That is my weakness. Because I don't have time to go and read the books and refresh my anatomy. And first of all, even if you refresh, I forget. Because unless you read repeated number of times, you will get into your mind and you start memorizing. Suppose I read now, the middle meningeal artery comes from this branch, and I don't see the middle meningeal artery in my lifetime because I don't open the brain. How can I remember the course of that middle meningeal artery?
Yeah, you are correct.
But for practical knowledge, Madhusudan knows what is frontal sinus and frontal table.
Madhu, majority of the delegate comes here to know the practical steps, not the textbook points.
our caption is subtitle entry to entire basics, subtitle is theory to theater.
Yeah. Theory you come from home. Here we will show the theater.
Suppose you write gastroenteritis essay question and get 10 out of 10 marks.
Yeah.
Suppose you are given a ringer lactate bottle, IV set, intracath, 5cc syringe and put on to the vein
Patient.
of the patient. I don't know. So if you learn and get 10 out of 10 marks of dehydration and how to manage, and you can't put the ringer lactate bottle. Sir.
Me not only good in subject,
sir.
I am doing excellent surgeries also, sir, in my practice and institute.
No. You.
I am doing both. I am doing both theory and theater.
You are multi-edged weapon, sir. Not even double-edged weapon. Nageshwar Rao is
double-edged weapon.
We are all single-edged weapons. Only private practice.
Yeah.
You are academician, college and theoretical knowledge, private practice, surgeries, and you go outside.
All-rounder.
No way we can compare Nageshwar Rao.
Yeah.
Because you have that opportunity, Nageshwar Rao. Not that I am this thing. If I were to be in a medical college, I also would have been same way, like asking so many explorative questions and discussions, making the conference worthy. People like
we have 33 postgraduates in our college, sir.
What?
33 postgraduates we have.
My God.
Every day, weekly,
yes.
5 times we have academic sessions, sir.
Right.
Except Thursday, all the 5 days we have academic sessions.
And
case presentations, seminars.
Camera. I'll focus on to the Satish Jain special pediatric instruments. If you're all interested, are you getting onto the table picture?
Yes,
sir.
Just show this. This is a pediatric Blakeslee, pediatric 45. Are you able to see normal Blakeslee and pediatric Blakeslee?
Yes.
And see, these are all cautery. This is all rubber suction cauteries, suction cannulas can be used for cauterization also.
Okay.
And the second thing is, what is this forceps? I don't know what is this forceps. Carrison sponge. It's a very gigantic carrion sponge. I think frontal table, frontal beak can be even. Are you able to see this very gigantic? This is a Lux forceps. Frontal finesse. Snake. Idi chupichama. This we also have. Are you able to see this?
Yes.
Articulated punch.
Articulated punch.
Carrison's big skull base. This Carrison's for skull base. This is articulated punch for frontal recess, so that it can even bite the frontal beak when you are doing exploration. We had a very hilarious discussion, Satish, when you were scrubbing. Type of delegates. There are 10 types of delegates.
Dr. Satish, we are with you.
Mic connected to Dr. Satish.
Yeah.
And Dr. Satish is coming to the auditorium.
Yeah.
Hardly fast we will finish this case and we will come to the auditorium.
Yes.
I keep by 10 degree head raise. No. Raise the table. Hello.
Yeah, please, sir. Good.
Yeah, can you see the nasal cavity after decongestion?
Yes.
Suction. See, classical non-polypoidal sinusitis.
Yeah.
Can you see?
Yes.
And this is look like concha bullosa.
Yeah.
We have to treat this concha as well.
Yes.
Pediatric is classical non-polypoidal. See this?
Yeah, lot of pus.
See this?
Mucopus.
Neutrophilic.
Yeah.
Neutrophilic driven, yeah.
Yeah.
Topramycin.
Yeah, mucopus.
See, all this mucopus.
Can we send it for culture and scientists, sir?
I think already taken.
Yes.
Yeah. So this is the accessory ostium.
Yes. Natural ostium cannot be seen like this. Concha
Yes.
on both sides.
Yeah.
Any ostium is seen means that is not natural ostium.
Yes.
Madhu?
Any
there was lot of
ostium seen.
mucopus inside.
Huh?
Lot of mucopus inside.
Yeah.
Non-polypoidal.
Yes.
Sir, it is looking like paradoxical middle turbinate.
Can you raise the hand by 10 degree?
Everyone will come across these cases in your practice.
Yes.
Very keenly observe this case.
Paradox middle turbinate. Paradox middle turbinate.
Enough. See the high deviation
Yes.
which has pushed the turbinate paradoxical.
Yes.
See this?
Yes.
Yes, sir.
Similarly, the paradoxical, see this concha bullosa on this side as well.
Yes.
This is concha, we will open up this.
Yes.
Dr. Satish, have you tried this crushing technique of concha?
Yes, you can. That is more for the hypertrophic turbinate. For pneumatized one, you need to give aeration.
Pneumatized one, you have to?
Give aeration.
Okay. Even if there is no pus inside?
Yeah, so yes. Because they contribute to narrowing of the osteometal area.
So if you crush it, what happens?
So just there. Crush it, you will crush the mucosa inside.
Yeah.
Our goal is to aerate the mucosa inside.
So it's a straight true cutting. Is scissors. Dr.
Scissors,
Satish
scissors.
is a scissors.
See, this was narrowing the osteometal area.
For considering this Vennupusala.
Debrider. Inferior tabinectomy we rarely do. A partial one very commonly. It depends upon the kind of turbinate hypertrophy, inferior one.
Yeah.
If it is a boggy turbinate, the posterior nasal nerectomy will help.
Yes.
If it is a bony hypertrophy, then partial turbinectomy.
Okay.
So if it is a bony also, you have to make space. That is mandatory.
Yeah, if inferior turbinate is too bony hypertrophic,
Okay.
contributing to obstruction.
Right. This is a small concha bullosa, I think.
This is not doing much. This will help. See this?
Yeah.
This will not fall back now. This
Yes.
will not come in the way. Now see, our osteometal area is open.
Yes.
So now my first goal, you have already seen all the steps in the previous case.
Yes.
Sir.
Here the anatomy is much better than the previous one.
Yeah.
though more challenging because of the space.
Space.
Yes, yes.
This is hiatus.
Yeah.
See this hiatus?
Yes,
Leading to the
hiatus.
infundibulum.
Yes.
Infundibulum is a three-dimensional space. See this? Turn inferiorly.
Yeah.
Turn down. Keep biting through unless you reach the hard bone.
Yes.
Yeah. So you don't do anything to the natural ostium during uncinectomy. Natural ostium is much deeper.
Yeah.
ये पूरा बंद है यार. Blade is not. It is clogged.
Yeah.
See, there
Yes.
is the maxillary sinus.
Yes.
sir.
And see the purulent discharge.
Yeah.
The blade is not that effective. See, that is accessory ostium.
Yes.
Now see, this is not massive disease.
Yeah.
Yes.
This is not fungus. I am not going to create a.
Big one.
Yes. See, this is good enough.
Yeah.
Suction cord. See, nowadays in the era of irrigation, restenosis is very uncommon.
Does
I
it
don't
worth
have-
doing balloon sinusoplasty in maxillary sinus pathology?
Yeah. So in children and immunocompromised patient, if you just want to dilate the maxillary sinus,
Okay.
you can think of that, but that is never a substitute for sinus surgery.
Sir, for the cost of the balloon is very high, sir. That is why it's not.
See this, the upper part of the uncinate, fractured anteriorly.
Yes.
See the bony uncinate coming out.
Yes.
Yes, yes.
And this is a very important step as you reach the lateral limit soon. That's the bony uncinate. See, at this point of time only, we reach the lateral limit of the entire surgery. See this? See the lamina papyracea?
Yeah. Sir, we are with you. We lost because of electricity.
Yeah, see the lamina papyracea laterally?
Yes, yes.
Yeah, see this? This is the lamina.
Yeah, yeah.
Very clear?
Yes, very clear.
Yes, sir.
So this step is very important as you reach the lateral limit soon. See now?
Yes.
I am opening up the axilla.
Yeah.
That's a very crucial step. See?
Yeah.
I have opened the axilla
Yes.
to look at the beak.
Yeah.
I have opened up the axilla. That's it.
Yes.
See this is your maxillary sinus.
Yes.
This is your bulla.
Yes.
We have taken the upper part of the uncinate.
Yes.
This is your turbinate.
Yeah.
And this is your level of axilla,
Yes.
which is more and more opened.
Yeah. Sir, you are opening the agar?
Yeah, that was the agar, and now I'm right into the frontal sinus with 0 degree only.
Yeah.
Now I will corroborate what I was telling you to take the reference of beak.
Yeah.
See, I have done with the 0 degree only.
Yes. Yeah. The 0 degrees.
I'm still with 0 degree.
Yeah, yeah, with still 0 degrees, we are able to see almost frontal recess area.
Yes.
See the space I have created.
Yes.
with the debrider. This is important.
Yeah.
We remove the upper uncinate and reach to the lateral limit. Following the lateral limit, you reach the
Yes.
axilla.
Axilla.
Open up the axilla up, and now I will take the 70 and show you the frontal.
Yeah.
So simple. See this.
Yes.
See this, how much the axilla is opened up.
Yeah, very clear, sir.
Yes, 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 you saw the agoniji. See now.
Yeah.
Section दे दो 120 पतला दे दो यार देख ना बच्चा है. See now, look at my medial and lateral limit.
Yes.
Yes, sir.
This is medial limit, this is lateral limit.
Yes.
Like previous case, you saw?
Yeah.
Yeah.
And now
Lamina
see
and
simply.
middle turbinate.
Yes.
This is our beak.
Yes.
Okay.
See this beak?
Yes.
Yes.
Going behind,
Yeah.
just behind the beak, staying between lateral and medial limit. That is our frontal sinus. Though in this case,
really
Madhu was telling
very
me,
yeah.
we discussed the frontal is not very big. But
Yes.
see, that is our frontal sinus.
Very nice, Satish.
Up there, up there.
I
up
was
there.
really afraid to do
that?
frontal sinus in a pediatric
see?
age group.
Yeah.
Very
You
nice.
made it very, very simple, sir. Can I
Very
have a big
simple.
applaud for the excellent? Within seconds, he demonstrated the frontal
See
sinus.
the frontal process of maxilla,
Yes.
lamina papyracea junction,
Yes.
maxilla, and beak, and just behind the beak, he
Yeah.
just opened the frontal sinus.
Yes.
Give me the reverse bar. Let me
Yeah.
widen it behind. And then I will show you the use of articulated punch. Madhu was showing some instruments.
Yeah.
Yes.
So it just occurred to me to show you the use of articulated punch.
Yes.
Reverse, reverse.
Yeah.
Boss, can you hold the head like this? Yeah.
Yeah. Sir,
So now I am with the so-called adenoid blade.
Yeah, adenoid blade.
We never use for adenoid.
Okay. No.
See, widen it posteriorly
Yeah.
toward the skull base.
Skull base. You are widening posteriorly.
Yes, widening posteriorly.
Yeah.
Now see the frontal.
Yes, sir. Very clear.
Give me the articulated. Let me show you the use of articulated one.
Sir, you show that forceps also.
Pardon?
Instrument, you show the instrument.
Yes. See
Yeah.
the instrument.
Yes. Thank
It has
you.
multiple articulations. This has 6 articulations. So what I will do, use it like this. See this?
Yes.
And wide through the beak.
Yes, sir.
See widened.
Yes.
Sir, is this needed in every procedure, every frontal sinus opening?
No. When you feel like widening it, you can. The projection of the beak. This is not going to take away the entire beak. Only the projection of the beak, if it is projecting. See now, much better?
Yes.
And since there was hardly any disease inside, I am not going to touch. See the skull base now.
Yes, sir.
After posterior widening, see this?
Yes. Clearly.
Now our bulla is intact. Same sequence we are following. See the bulla is intact?
Yes, sir.
Maxillary is here, bulla is here. Now I will take away the bulla.
So we have to go a full house first, remove all the compartments and lamella.
Yeah, it was almost
Yes,
sinusitis. Oh.
అది రామకృష్ణ కింద పడింది చూడు దీపు.
See this behind the bulla.
Yes, yes, sir.
See this behind the bulla, dismantling it anteriorly.
Yes.
That is the safest step away from the skull base.
Away from the skull base.
Yeah, that step is very safe.
Yeah. Sir, you are doing with the 70 degrees.
Yes, right now with the 70, soon I am going to change. I want to show you the artery,
Yeah.
if visible. If prominent, I don't know.
Artery usually will be the just behind the attachment of the
Yeah.
anterior wall of the bulla.
Yeah, see the bulla
Superior.
is attached anteriorly
Yeah.
up there.
Yes, yes.
The artery remains behind.
Yes.
See how deep the skull base is.
Yeah, yeah.
Not holding. No catch hold. See this skull base?
Yes.
Yes, sir.
Very clear,
Sir.
sir.
Artery will only be prominent if the skull base is very thin.
Yeah.
So if skull base is over pneumatized, you can expect the artery to be prominent.
Yes.
See the skull base?
Yes.
Yes, sir.
Yeah, yeah, yeah. అక్కడ ఉంది వెనకల్ yes, yes, you are correct. Cell behind.
In the depth is the vessel there.
Yeah.
Yes.
Yes. Sir, do you think we can call this as an anterior fovea and posterior fovea? Is there any significance?
Yeah, fovea is the roof of the ethmoid,
Okay.
which is completed from above by the frontal bone.
Okay.
So fovea is basic literal meaning of fovea is impression.
Yeah.
Fovia
Impression.
means impression.
Impression.
Yes.
That
First
means
fovea is a first impression.
that ethmoidal cell leaving impression over the frontal bone from below. That is called fovea.
Yeah.
Misnomer fovea ethmoidalis is not
See the
part
skull
of
base?
ethmoid bone.
Yes.
Right.
Yes.
Now I will take 0 degree. Quick debrider. So very soon we are going to complete on this side.
Yeah.
Debrider. See this?
Yes.
This is maxillary sinus.
Yes.
This is the remnant part of the bulla.
Yes.
First of all, I will define my maxillary sinus roof.
Yes.
This is very important.
Yeah.
See the remnant bulla being removed.
Yeah.
I never thought that these pediatric patients need so explorative or explosive FES. I was thinking you will just do some middle metal antrostomy and leave it. And you are making almost 1 centimeter wide middle metal antrostomy.
Yes. See now, at this level, Straight. Now I'll quickly enter the post-ethmoid. Go medially. Look for the sphenoid. Then complete post-ethmoidectomy and over. See, medially I have entered here.
Yeah, inferiorly and medially.
Yes.
It's almost
Can
posterior
you see the
ethmoid.
superior turbinate now?
Yeah.
Yes, sir.
Yes.
Yes, sir.
You can see the superior turbinate.
Now I am between the superior turbinate and the septum. See this.
Yes.
See the ostium of the sphenoid.
Yeah.
Yes,
Yeah,
sir.
See the level of the maxillary line.
Yes.
Yes.
See this exactly.
Yeah.
Yes.
Here now I am entering into the sphenoid sinus.
Yes.
Level of sphenoid ostium is at the level of posterior wall of maxillary sinus.
Yes.
Can you see the sphenoid ostium now?
Roof.
Roof
Yes.
of the
Yes.
maxillary.
Very clear?
Very
Yes.
clear, sir.
That's the level of the sphenoid ostium.
Yeah.
That is sphenoid sinus. See there.
Yes, yes.
And now I will take away all this post-ethmoidal cell anterior to it. Quickly. This is post-ethmoidectomy.
Yes, yes.
So safe now. I have my guide.
Yeah.
I will not go in any given situation behind the sphenoid sinus.
Yes,
Ah,
Yes,
so
sir.
the guide is don't go beyond the sphenoid sinus.
yes.
As long as I am seeing anterior to the sphenoid, see now, my skull base above, that's the post-ethmoidal artery.
Yeah, yeah, very clear.
See the post-ethmoidal artery.
Yes.
And just I have to widen this little bit of. Yeah? Pardon? See, bleeding is never a concern in ethmoidal artery damage. It depends what kind of damage you have given, whether the artery is fully transected and retracted into the orbit, that is the biggest concern. That's a submillimetric vessel. Bleeding is hardly anything. We deal with much bigger vessels in our head and neck.
Yeah.
So bleeding is hardly anything a concern.
But the amount of fear created among budding ENT surgeons, if you hit the ethmoidal artery, it is like hitting the carotid artery.
Yes.
Abba, anterior ethmoidal artery.
No, you should not try to. The question is, if anterior ethmoidal artery bleed,
Sir.
can we control with pressure packing? First of all, see the concern with the ethmoidal artery is,
Yeah.
you're right Madhu,
Yes.
a lot of people are so concerned. The artery leaves the orbit, then runs through the ethmoidal roof.
Yes.
And then enter the cranial
Again,
cavity.
yes.
If the artery is injured close to the orbital exit
Okay.
and happens to retract into the orbit
Okay.
and keep on bleeding, that
Yes.
can be a disaster because it
Disaster.
can give orbital hematoma.
Yes.
And since orbit has bony walls all around except anteriorly,
Okay.
that hematoma, the bleeding artery,
Deepu.
can compress the optic nerve. And that's the biggest concern because it can give rise to
Yes.
permanent vision loss. See the sphenoid now.
Yeah. Dr. Jain, suppose by chance for the juniors, if they cut and orbital hematoma immediately in the operation theatre, what shall we can do?
Lateral canthotomy.
Lateral conthectomy.
Canthotomy is easier.
Have you ever done lateral conthectomy for anterior ethmoidal artery injury, Satish?
Pardon?
Have you ever done lateral canthotomy for anterior ethmoidal artery injury?
Yes, yes.
Oh.
Yes. I have been called at many places intraoperatively colleague injured the artery, fear, orbital hematoma occurred.
Yeah.
So most of the time, with the massage it resolves. But see,
massage
arterial bleeding is always so
Yeah.
massive.
Dr. Satish,
Yes.
can you show with the suction tip or ball probe exactly the anterior ethmoid artery and posterior ethmoid artery?
Yes, why not?
Please.
Wow. Extensive fest for a pediatric.
In pediatric Madhu,
Yes.
irrigation pathway should be
Yes.
better than the adult one.
No, I was afraid
Because
of
the
touching
pediatric patients
Yes.
will never follow the irrigation so judiciously.
Okay. But this case today has really opened a new horizon in my concept of pediatric fest. I was always thinking you should be very minimal, very low,
No,
and
once
don't
you
go
do
extensively
complete job.
like this.
See,
Madhu, she is
Yes.
14 years, well pneumatized
Yes.
sinuses.
Yes.
Nasalization is important, sir, even
14
in
year
pediatric
is not
surgeries.
that small child.
Nasalization is important even in pediatric surgeries, sir.
Yes.
To allow the steroids.
That's a part of the cabinet because of the concha.
Yeah.
I had trimmed.
Yes.
scissors. See, that's the final picture I am doing.
Yeah. Sir, show the arteries, sir.
Yeah. See, this is posterior ethmoidal artery.
Yes.
And that is, here is the anterior ethmoidal artery.
Yes. Thank you, sir.
That is there.
Yeah.
This is posterior.
Yes.
This sphenoid sinus.
Yes.
Maxillary sinus. See this?
Yes.
All sinuses are okay.
Yeah.
Madhu,
Yes.
look at the final picture.
Yeah. I'm
Excellent.
keenly observing
Can
because
you have a big applaud for the excellent demonstration today?
Yeah.
Yeah. Dr. Satish, thank you very much for the excellent demonstration.
that at small middle turbinate lower part you want to remove?
No.
No. That
This
piece.
is not going to bother.
Okay.
See, now all sinuses are exposed.
Okay.
The great space we have now. Will somebody do on the opposite side? See the accessory ostium.
Yes.
Here also I think small concha is there.
Okay. So, any questions regarding this?
We'll go to audit. Prabhakar,
Yes.
the whole credit will goes to Dr. Madhavi, she and Dr. Ravi Krishna, and later Dr. Malleshwari also joined.
Yeah.
And relentlessly for all these 1 week, for more than 10 cases per day, they have
Yeah.
given anesthesia without any expectations for poor patients, sir.
And your staff also.
My staff, big salute, whatever it
Yeah.
is.
Can we have a big applaud for the
Yeah.
entire anesthesia team and the assistants?
Yes.
Madhu, there is a big applaud of thanks to your
Thank you.
people who helped us.
Yes.
Thank you.
We are coming to the auditorium.
Yeah.
And from there, we will have a small valedictory-like thing. And Satish Jain is really tired. And you landed at, he landed in Nandyal at 6 a.m.
Yeah, no sleep.
And came to 9 o'clock and working up to 6 o'clock. What an energy and strength. Madhavi.
Meanwhile, if you have any doubts, Dr. Professor Nageshwara will clarify.
Any doubt, postgraduates?
Thank you, sir. Now I request Dr. Prabhakar sir to give mementos to the chairperson. Now I request Dr. Tejashwini ma'am to receive your